So good morning, everyone. I'm Bénédicte Pensières, and I'm the director of Les Pensières Center for Global Health. So on behalf of the Merieux Foundation, I would like to warmly welcome you to Annecy and to Les Pensières Center for Global Health. It's truly a pleasure for me and my team to host this global summit to deliver prevention in an aging world. And I would like to warmly thank David Sinclair, Lindsay Gorelli, and all the organization team for organizing this meeting here. David came 7 years ago, and ever since he has tried to organize a meeting, and then there was a COVID pandemic. So we are extremely pleased to have you. So I'm happy to see a familiar face, such as David, Professor Salisbury, but I think most of you are newcomers. So we thought that maybe it would be interesting for you to know where you are. So in just a few minutes, I will say a few words about our foundation and this center. So you're here at the Merieux Foundation, a family foundation, which was created by Dr. Charles Merieux in memory of his father, Marcel Merieux, who was actually a student of Louis Pasteur. So Matteo, I don't know if I can have the picture, the old picture. So you will see a picture which was taken in 1894, where you have Louis Pasteur in the middle, and all the students at the time, and one of them was Marcel Merieux, his father. So he's the third man, so starting from the left with the moustache, and they all have moustache. And this was just 3 years before he created Institut Merieux in 1897 to produce, manufacture, and deliver human and animal vaccines. So you will see that it makes sense for you to be here, because we are talking about prevention, about vaccination. And so Charles Merieux, you know, all his adventure was, he took over from his father in the 30s. He developed the human and animal vaccines business, but in parallel, it was important for him to give back to the society, to the community, and he was a philanthropist, you know. So that's why he created this foundation, which has now a public interest status since 1976. And the mission of the foundation is to strengthen local capacities in low and middle income countries to fight infectious diseases, with a special focus on mothers and children. So we have 4 main priorities. The first one is to give access to diagnostics. So as you well know, without a good diagnostic, medicine is blind. And our mission is to strengthen health system, also for surveillance. So you will see that there are synergy with what you also do. The second priority is to strengthen local applied research, focusing on infectious diseases. So it's mainly TB, IMR, emerging viruses and diseases. Third, and it's mainly what we do here at Les Pensières, is what we call knowledge sharing. And it was very important for Charles Merieux, for Alain Merieux today, our president, to bring together, and again, it's quite similar to what you do, people from different backgrounds, different countries, to advance global health. So we do organize courses, advanced courses, and we just had an advanced courses on vaccinology. We have another one on diagnostic, another one on IMR, and international conferences, so on cholera, on dengue, on rabies next week. And last but not least is programs focusing on mothers and children in a global health approach. So it's also similar to what you do. It's not sufficient to look at healthcare, but also at the environment, education, nutrition. So we do support programs in the field that have this holistic approach. And this place, so the Merieux family is from Lyon, but Charles Merieux's wife was from Annecy, from this region. And the family bought this property in the 50s. And Charles Merieux, as I mentioned before, loved to host meetings, to have dinners where he could invite people from around the world to talk about health issues. So at the time it was polio, meningitis, rabies. Later on it was HIV/AIDS. And he saw the power of this environment, the good vibes, you know, between the lake, the mountain. I discussed with a few of you this morning, and they say, wow, there is something special here. And so he decided to create a center dedicated to global health. He first renovated the old barn, and then he created this room to be able to host his guests, and then some rooms, and then a restaurant. And when he passed away, Alain Mérieux, our president, decided to donate the whole property to the Mérieux Foundation so that we can continue and pursue this public health mission. So this is the goal. The objective of our center is really to be open to any organization in health, to host meetings, so congresses, conferences, courses, advanced courses, training and seminars, retreats, to advance global health. So we host about 150 events. It's 5,000, 6,000 people every year. So for instance, this week after you, we're going to host Gavi. Next week we have rabies. We have also eye congress at the end of the week. So it's a plurality of topics in health. And to conclude, I would say that we want to stay faithful to the hospitality family. When the family decided to create this place and to donate it to the Mérieux Foundation, it was really for people to feel at home, you know, such if you were welcomed by Alain Mérieux. So we will do everything possible for my team and myself, you know, to create this best working environment for you to share knowledge, to engage with each other, and to be inspired by this beautiful nature. So I wish you a very pleasant stay with us and a great congress, a great and fruitful congress. Thank you so much for your attention. And now I'm giving the floor to Professor Salisbury, whom we know very well.
Well, good morning, Benedict. Thank you. I think this is my third visit here in about 6 weeks. So I seem to be coming here more than I'm going anywhere else. But it's always a pleasure to be here. So my thanks to you. I also thought that the students looked very old in that. I think it was time they matured into proper jobs instead of being students. They clearly were doing endless PhDs. Anyway. The issue that we're going to be discussing this morning in 2 sessions is about the interplay between vaccination and older people. And clearly the focus is preventing infectious disease in older people. And we have to acknowledge that there are two peaks of burden of infectious disease. And the first that has gathered so much attention over so many years, of course, is in young children. And the second that has gathered much less attention is the burden of infectious disease in older people. And clearly that is a consequence of immunosenescence, but nevertheless there is a shift, and a very palpable shift, that is happening to the investment in the prevention of infectious disease in older people. And that's what our 2 sessions this morning are going to be concentrating on. Yesterday afternoon, early evening, I think we established some really important issues that are going to be relevant in the discussions that we'll be having this morning. I sat thinking, I was going to say that. I was going to say that. And all the things I was going to say were sort of evaporating in front of me. But then I started to think, well, what are the real issues? What are the core issues here that I think we should carry into today and afterwards when we leave here? There was a lot of discussion and a lot of points were being raised that I view somewhat negatively in terms of what didn't we do right in the course of the pandemic. And that's really important. We have to do that analysis. We have to work out what didn't we do right so that we don't do it again. We have to do that. But there are 2 elements that I think we have to look at much more prospectively and much more positively. And those 2 elements are opportunity and economics. And the opportunity, I think, is huge. And we have to build on the opportunity and not lose the opportunity in our negativity about self-criticism. Because the opportunity aspects, I think, are what will live after the criticisms have been sort of put away. And the opportunities are huge. And the opportunities that came and will stay with us from the pandemic must be built on. And they range from surveillance, it was brought up yesterday, that we have put in place surveillance of a capacity and magnitude that we had never done before. We have got individual-based and population-based surveillance, laboratory-based surveillance, clinical surveillance, adverse effect surveillance. All of these elements we need to be able to do better and build on what we've learnt before. We developed vaccines in an extraordinarily short period of time. I led a public-private partnership quite a few years ago to develop Group C meningococcal conjugate vaccine. And we did that in what felt like a record period of time, and it was 4 years between having nothing and implementing a vaccine program. And that was viewed as extraordinarily fast, because the normal period to develop a vaccine and have it ready to use is sort of 10 years, with a very high rate of failure, because great ideas don't necessarily get to a product that is safe and effective. Here we were talking about a year. We have to learn and build on the ability to use new technologies to get our vaccines much faster. And not just the technologies, and RNA, clearly was part of that. And there's so much discussion now about adapting the mRNA technology to some of our other existing vaccines and ones that have proved particularly difficult. We were able to license vaccines in such a short period of time without cutting corners, with the same numbers of individuals having been studied for safety and efficacy as would normally have been done. In fact, probably larger clinical trials than would have normally been done. And we were able to see the regulators doing their work not in series, one piece followed by the next piece, followed by the next piece, but they did their work in parallel. And so they were prepared. Well, it was a mixture, actually, because some things they had to do in series, so they had to go from one to the next. But other things were being done in parallel. So instead of doing your phase 1, your phase 2, your phase 3 clinical trials, each of which was consequential on the other, so much of the work was done at the same time. Regulators were also prepared to work as the data emerged. And so instead of saying, you will submit to us a data package that is complete, and we will then take 1 year, and that was fast track, we will take a year to get back to you with an answer as to whether you get a product license. They were prepared to look at the material that came off sequentially, so that as soon as the data was available on the manufacturing and the quality aspects, they would look at it. And then as soon as the clinical trial data became available, they would look at it. And so all of these elements we have to incorporate in our efficiency for the future. So opportunity is one of the two aspects that I think we have to look at much more positively and do better. And I think that if I can contextualize my vision of the vaccine stuff, it's how we do it better. And opportunity is one of the pieces of that. And the second is the economics. And if you look at how vaccine economics have been done, again, traditionally, we have, for the greater part, a narrow view that is necessary to persuade governments to make investment in vaccine. And the narrow view is what's the cost and what's the benefit. So what does it cost me to do this vaccine program? And that's the direct costs. And what are the direct benefits? So how many lives will I save? How many direct hospital costs will I avert? And it's kept pretty narrow to the individual. Where it gets a bit more flexible is that in infectious diseases, if you prevent one person catching the disease, you may be lucky and actually indirectly prevent another person catching it because of impact on transmission. So you can put in some of the indirect benefits, particularly through an impact on transmission. The problem is you don't know that until after you've done it, because you've no idea when you introduce a new vaccine if there will be a transmission blocking effect. You can model that, but you haven't got anything other than, your best guess as to what it might do. So for the greater part, we've looked at just direct costs and direct benefits. There is a move, and I think it's probably right, but it brings some problems with it, about taking a broader view and looking at some of the indirect benefits in particular. Coming from the pandemic, one of those impacts that really was transformative was the appreciation of the macroeconomic costs of the pandemic. We did not shut down societies without thinking about, and for our political leaders to be thinking about, the macroeconomic impacts of our infectious diseases. And it was the impact on productivity, the impact of social distancing, the impact of lockdowns on the country's economy. And we had not really given due appreciation, even in pandemic planning for influenza, about some of these macroeconomic effects. And so I think we have to be smarter at looking at the wider attributes that come from prevention of infectious disease beyond the direct costs and benefits. That's not going to be easy when you have governments that use fixed criteria for how to assign resources. Because if you say you have to be below a QALY threshold, you can't start putting in a whole lot of things that normally don't get included, because that's moving the goalposts. So it's easy for me to say it's not going to be terribly easy necessarily to get that flexibility about changing what we can include. The reason I'm bringing this up comes from some of the discussion yesterday about some of the economic consequences of disease or ill health rather than good health in older people. And I think what we've got to be able to do is have better metrics for what those economic impacts are, because it's the Treasury actually that makes the decisions rather than the health minister. The health minister may say, this is fantastic, I'm really behind it, but actually if the health minister hasn't got a budget, you don't get anywhere, and that budget comes from the Treasury. And the Treasury looks at the hard economic opportunities and costs. So we've got to be more creative, we've got to be better able to defend our desire for resources. And it's all very well saying, this will be a wonderful thing, we really must do this, but actually that's not going to get you any traction. The traction comes from the hard economics. And so we have to be better at translating the emotional need into an economic reality of what we will gain. So I hope that some of these aspects are going to come up in our discussions today. Maybe that's just me wanting to hear my own prejudices being reinforced. But I think that opportunity and economics have to be brought into our discussion. Lists of vaccines existing, lists of vaccines future, fascinating, but that's not where the change comes from. The change comes, I believe, from building on opportunity and being better at doing the economics. So that's my background that I think is hopefully going to come through our discussions today. We've got two great sessions. The first is healthy aging and adult immunization, and we've got three great speakers. But Lois is, I think, going to start us off. Please. Hopefully you did get a good night's sleep last night after a poor one the night before travelling.
So thank you. Okay, I think we're on the right topic. So I'm going to talk a little bit about the situation of adult vaccination on a global level. And one of the things that we had done is taken a look several years ago at why do adult vaccines vary so much from country to country. So we did a study that involved 34 different countries, and we did a combination of a desk review, taking a look at a variety of different factors. We had scoured the literature, looking at a variety of different frameworks to understand the factors that influence both uptake and decision-making. So we looked at a couple of different elements and a variety of factors that go into them, and I'll talk about those in just a moment. But what we saw was quite a bit of variability. And what I'm just going to do is I'm going to start off with the conclusion. And this is a slide that shows the results of our work that we did. And what you'll see, and just to ground our discussion, this is for adult vaccination, which includes a variety of different vaccines. So influenza vaccines, pneumococcal vaccines. This was pre-COVID vaccines. And I think what we'll see today is quite a very different picture. So what you'll see on the bottom across the x-axis is an implementation score, and I'll explain in a minute what we meant by that. And on the y-axis, decision making, because it's one thing to be able to make a recommendation about a vaccine and have a country that has availability of a vaccine, and another thing for a country to be able to implement a vaccine program. So what you'll find up in the top right-hand quadrant probably won't surprise most people. Those are the countries that have performed highest on both decision-making and implementation. So US, UK, Australia, Italy, Canada. Those are also countries that have performed well with COVID-19 vaccination. Now, some countries do very well on implementing vaccines for older adults, and some countries less well. But what we've seen with COVID-19 is quite a bit of opportunity. Okay. So what you'll find here is that some of the countries have done some things to implement different strategies to increase the rates of adult vaccination. And I'm going to switch to explaining this in a little bit more detail. So some of the things that we took a look at, the question is, what are the things that actually drive decision-making and drive implementation? So there's a lot of things, and it will vary country by country. But some of the things that we looked at in terms of decision-making as an indicator for a strong decision-making country are things like whether a country is an early or late adopter, considering whether they have certain manufacturing requirements, because sometimes when you have products, if they're required, in other words, to come from the host country, an example there would be India or Japan, where that might influence whether vaccines are available and the timing of whether vaccines are available. Whether a country relies on surveillance and has their own surveillance, and you'll see quite a bit of variability from country to country. Whether they have, and this is an interesting one because I think we've seen a lot of changes from 2017 when we originally conducted the study to now, whether there's a health security emphasis and whether that drove decisions about adult vaccination or not. The other thing I want to draw your attention to is whether countries have NITAGs. So NITAG is a National Technical Immunization Advisory Group. So for vaccines, we do find that most countries do have NITAGs, but very few have adult immunization working groups, or at least at the time that we did this study. I think that's changed a lot with the pandemic, and something that's important that we see going forward is the engagement of a variety of different stakeholders, not just the experts in vaccination, but the experts in various subject areas. Because, we do need people that have an understanding of the needs of older adults, the needs of various marginalized populations, etc. From a policy standpoint, the other indicator that we saw that was very important is whether countries had a national immunization policy. And what we're hoping is with the pandemic that this will drive a specific policy for older adults. Many of them have policies around pediatric vaccination, but we're seeing right now with the pandemic a lot more countries that are starting to look at the recommendations as a whole. So looking across a variety of different populations. Now, the one thing that I do want to acknowledge is that this does happen with the wealthier countries. So we're not yet seeing the same type of changes in some of the lower middle income countries or even low income countries, although there is a shift towards more of a life course estimate or approach. And we hope that at some point in the future, there will be a lot more that is going on. So what are some of the things that our countries are doing best? So some of the things that we found is when countries have clear recommendations, that is an important driver. Now, all countries were pretty clear, or the vast majority of countries were pretty clear on COVID-19, but that doesn't necessarily translate into pneumococcal vaccines or even influenza vaccines. And so this is another area of opportunity. The trend that we're also seeing is an increased choice of providers. So many countries have allowed pharmacists to vaccinate where that previously wasn't an opportunity in countries, something that we hope that will continue. Even in some places like the US, they're going even further and taking pharmacists outside of the pharmacies and using them in community-based ways. So we have pharmacies that are regularly going to churches and vaccinating at places where people trust and people gather. And that element of trust can be, absolutely crucial. The other thing that we've seen is that use of data, either through registries, use of monitoring and evaluation, things like that, can also be an important driver of whether there is good uptake or not, or recommendations or not. The one thing that we have seen, though, is there's quite a bit of inconsistency as far as how far do the data go. So oftentimes we'll see data reported, if they're reported, on a national level, but very few times is it disaggregated. And it's that use of disaggregated data that can really make the difference in adult vaccination, or vaccination as a whole. That's not something that's necessarily unique to older adults, but the use of data and the use of being able to put those data out publicly can really make a difference, because then what that enables to happen is it enables the media to hold policymakers and politicians accountable. It enables community organizations to be able to really drive and make calls for what needs to be happening in the community. And when you have good data, that's something that really can help you in your planning for older adult vaccinations. The other things that we see are centralization of vaccine programs. Now, that doesn't necessarily mean a centralized health system, but what it does mean is consistency in messaging, consistency in targets, ensuring that each community is working towards certain vaccination rates. And finally, recommendations from health providers. So in terms of challenges, so the question at hand is, what are some of the biggest challenges that are posed in terms of uptake? And we talked about this last night, but it's not about the people that have good knowledge of vaccination and the importance of vaccination. It's about the communities that are left behind. It's about the people that may not have trust in the health system and probably aren't seeing the health system, because in terms of costs and economics, that's where a large portion of the economic costs are coming. They're coming from a workforce that really does need to work and doesn't necessarily have the opportunity to seek care, which then in turn puts higher costs on the community as a whole. Trust is a major factor, and I think one of the things that this pandemic has really uncovered all over the world, no matter which country that you're living in, is that there is quite a bit of distrust in certain pockets, and we need to do better to really build back that trust. Now, one of the challenges that we also see is that by talking about COVID-19 and really being singularly focused, we may have in some cases unintended consequences of reinforcing that distrust by talking about things that maybe that community doesn't care about as much. So, going back to the social determinants of health becomes really important. Feelings of government intrusion is a challenge, and I think this is something that, at least in the US and in many other places around the world, we're really seeing quite a bit right now, and seeing the consequences of what different people feel. And what that's doing is that's taking the eye off the ball, in that we're debating things about personal freedoms and the need to really get past the idea about this is healthcare for everybody, and we're really working towards the same goal. So there will need to be more efforts to really bring people together on some of those things. And then finally, in terms of how do we achieve better vaccination rates in older adults? So first, I think it's important to recognize the variability from country to country and the variability within a country. Because, when we talk about older adults, I think it was said yesterday that it's not a homogeneous population. So it's not homogeneous between countries, and it's not homogeneous within countries. And recognizing that fact is important, because we need to really address people where they are and start to address the needs. The positive is what we're starting to see is more of an emphasis on a life course approach, versus the traditional pediatric conversations. We need to have messages that are focused on the impact on the whole family and not just an individual population. We talked about, I think, yesterday, many of these ideas came up yesterday already. So the idea of checklists, we do see quite a few missed opportunities. So oftentimes when we speak about missed opportunities, we speak about those opportunities in terms of children and pediatric vaccinations, but there's a lot of missed opportunities with older adults. And not all older adults seek care. So, oftentimes our paradigm is that, older adults are going in to see a provider about the problem that they might have, that's an opportunity. Well, the bigger concern is those that never even get into that office until it's too late. So thinking about those opportunities. Increased focus on convenience. Oftentimes we forget to think about, how are older adults going to actually get to the offices where they can get vaccinations? Can we bring vaccinations closer to them? In other words, homebound programs, transportation programs, or other places that they might be going elsewise. So finally, vaccination is really local, and that's the message that I want to leave, that when we look across the globe, it's easy to say that you need this factor, and this factor, and it's really a matter of being able to understand what is going to need to happen in each community. And so it's the responsibility of communities to be able to design programs that fit the needs of their communities. And it may be that the base is not vaccination. It may be that the opportunity is through other programs that exist, and vaccines are added on top of this. Now, I'm a vaccines person. I've been that for a lot of years already. But I think, the one big revelation that I've had is that, the more and more that we have that singular focus in certain communities, the more and more we sow distrust. So thinking about, what the tailored approach is going to be for those communities is going to be crucial. So that's all I have, and thank you.
Thank you. Great starting insight into some of the issues that are clearly germane to the success of bringing immunization to older groups, and that the tables are of great help to us all. No questions have come in yet, but let's take some from the audience, please.
Except for him.
No, we've got 1, 2.
Oh, there we go. Yeah, thanks so much for a really fascinating talk. I was just interested to get your thoughts. There's been a lot of discussion around vaccine hesitancy as one of the reasons that there's poor vaccine uptake in certain areas, but it seemed from what you presented that there's quite a lot of practical low-hanging fruit around things like transportation, data, etc. So I was wondering to what extent you feel sometimes that the discussion around vaccine hesitancy is a bit of a distraction from the more practical things that can be done to improve vaccine uptake.
Yeah, that's a really great point. So vaccine hesitancy and the definition of vaccine hesitancy, I think, also causes a lot of confusion, because hesitancy can also be influenced by things like convenience or some of the factors that I spoke about here. But when we're talking about either vaccine refusals or misinformation or rumors that are circulating, those are real issues in certain areas. But oftentimes when you dig down deep, and I'll again use the example of Baltimore, where I do most of my work right now, is that hesitancy or misinformation or rumors is the easy thing for people to cite. We see it all on surveys. We saw the rumors circulating about DNA, but when you start to really talk to people, the story is about populations that have other issues, whether it's an underlying distrust of the government, or that nobody really took the time to explain things, or that they don't have that trusted person in front of them to really explain. So I think the trick is to not dismiss hesitancy, but to go back and really understand that we're dealing with people, and that we need to have conversations about what's going on in their life and figure out how those concerns weigh into our approach going forward.
Thanks.
Mark?
So, Lois, I think this is all pre-COVID data,
Yes.
right, the ranking. Do you have any sense that some of the surprising countries, like Switzerland in the bottom left there, I was really shocked. Do you have any sense that they've maybe moved?
Yes.
Okay.
Yeah, no, it's a great question. And I think what we're starting to see is a shift up and to the right. The question is whether that shift is going to be sustained or not. And, that's the $1 million question. Because, clearly there's been a lot of improvements because of the pandemic. The idea is, though, that is that funding and is that sustained effort going to continue? Right now, there's a lot of COVID fatigue out there. So, once people start to get back to what they consider their normal, what is the impact on the immunization system? What is the impact on the health system as a whole? Hopefully we don't see a shift that's going further back than we were before. I don't think so, but that is always a risk.
Yes, please. I have 2 points. One for David. My impression is that for the development of COVID vaccines, there were billions immediately in the research and development. That is not always the case for those casual, preventable disease. And it was a very strong difference. I would like you to say your word about that. And the next comment is my own country, that is France. I see it rather on the top. We have quite good ideas and recommendations. We lack logistics. So once the recommendation is made on the paper, it is accessible to all doctors, but all don't go. And there is no incentive. It's not backed by public health authorities. I'm thinking especially of elderly vaccines. I'm quite sure a lot of adults don't have their boosters, and even less in elderly. So there is a major point here, and truly, COVID vaccines have demonstrated that the state is able, when it is supported by political issues and economic issues, they are totally able to promote vaccination. Yet, only 55% of the population has received a booster, for example. So I do agree that there is this COVID fatigue and everything should go back to normal. And this is a real issue, not to worry much the population, but then to still encourage them to get vaccines.
Yeah, and I also like the point that you brought up about incentives, because that becomes it's going to vary country by country. You know, in some places we've seen that penalties work better. In some cases it's incentives that work better. They look different in each setting, but it's that idea that you have to motivate the system in some way that becomes important.
The point you make about the investment in the COVID vaccines is valid, of course. I mean, it would be wonderful if we had the same resources put into the vaccines that we've been waiting for quite a long time as were put very rapidly into the COVID vaccines. I have nothing to say other than, I note your observation. One thing I would like people to do, and I think it picks up something that you've been saying, is to look at how well they did with their COVID vaccines and ask why haven't they been able to do that with their flu vaccines for all those years gone by? Because they're the same people, and and it's all about data. It's all about knowing who they are and knowing how to access them. Because we did it for COVID.
I have a more severe estimation for flu. It was accepted by governments and public health authorities, so why to move on?
Well, as an exercise, why can't we do as well with flu vaccine as we did in country by country for COVID?
Yeah, and I think the very first start on the point of data is, all countries are reporting on their pediatric vaccination program. It's more of the exception than the rule for adult vaccines. And you really do have to dig deep to be able to find any data, which makes it very difficult to manage, more or less manage on a subnational level, which is really what's needed.
I mean, I get a text message every October time telling me to come at 10:42, not 10:41 or 10:43, but at 10:42, and it's a Saturday morning. But that means that whoever is providing my flu vaccine knows how to get to me, knows that Saturday is a easier time for people who are still working to come to be vaccinated. And I'm sure so much of this is data driven. And it's not just data after the event, it's data before the event that I think makes a big difference. David?
Yeah, I was just going to add about sort of that. I think a really important point, David, if you look at places like particularly Latvia, I think Lithuania as well, had very, very low flu vaccine uptake amongst over 65, but actually have done extraordinarily well with COVID. And yet other bits of Central and Eastern Europe have done pretty terribly with uptake of COVID as well. But actually, what can we learn from Latvia and Lithuania, I think could be really, really interesting for going forward. Yeah.
What can they learn to then make their flu vaccine better because they're the same people? I think we're done.
Great.
Lois,
Thank
you for a great presentation.
Thank you.
Patrick, I think you're next because we're now going on our tour of countries. And Patrick comes from a sort of alphabet spaghetti of ILCI and currently.
Thank you very much, David. Thank you, everyone, for being here. It's great to be here. Just on the point of the wonderful acronyms of C's, L's and I's, I think I describe it as two hats. So I've been working as a research and projects officer for ILC since August 2020, but since November 2021 I've been working on a secondment for CLCI, which is a European-based coalition. We have a lovely stand at the back, and Daphne is our chair, who is with us as well, so do ask us any questions about the organisation. I'll be talking a bit later about our CLCI work, but for this morning I'm going to be talking a bit more about an ILC project that we've been working on. Specifically, as David said, we're going around the world now, so we're going to go over to Japan to talk about healthy aging and adult vaccination in the country. So ILC has been working on a program of work over the past year, or getting on nearly a year and a half now, with a London-based ethnographic research company called Stripe Partners, who are a consultancy. And this project we've been working on effectively is going to be looking at how to increase or find solutions to increase vaccination or adult vaccination in older adults in Japan. And this project has been somewhat delayed because of COVID-19, so David and Lily will be going to Japan next month to conduct our ethnographic research with Stripe. But meanwhile, when we're back at home, we've been collating some evidence, producing some materials, including a fact pack, which I'd like to present to you today. So, first off, a bit of context about Japan. So, we all know that Japan has a quite large population. It's one of the largest in the world, about 125 million people or thereabouts. But it also has a very large aging population. So, with that in mind, it has a declining population or population growth. And this is really important actually when we're talking about the context of adult vaccination, because as we know, as you age, your immunity starts to wane. So it's incredibly important that older adults in Japan get their seasonal vaccinations to, protect them, to offer better protection against vaccine preventable diseases such as flu, pneumococcal disease, shingles, amongst many others. Obviously in this context in the world at the moment, COVID-19. So when we're looking at healthy aging in Japan, though, life expectancy is very high, 85 years for the average life expectancy in Japan. And of that healthy life expectancy, so years spent in good health, is 72 years for a male and 75 years for a female. And with that, as I said, it has an aging population. It's also expected to grow. So the population of over 65s in Japan is expected to increase by 10% or so over the next 40 or so years. And when we break down that population, over a quarter of people in Japan are over 65, of which 13.8% are 65 to 74, and over 75s accounts for 14.7% of the population. So when we're thinking about Japan and its demographic, we know that it is an aging society, and that is very important when it comes to things like immunization and making sure that older adults do get their routine immunization. So with an aging population, but obviously the burden of disease is also more prevalent in places such as Japan. When we look at the data here, these are disability adjusted life years, so 1 daily equals 1 year lost in healthy life. And the global trend really is that they've almost doubled in over 70s, and it's more than doubled in Japan, obviously the total number of dailies lost in over 70s. But as a proportion of overall dailies, it has significantly increased in Japan. So 31% of dailies were just in over 70s in 1990, but over the past 3 decades this has increased by 23%. And when we compare this to global trends, which is only around 6% increase in the total number of dailies as a proportion of overall numbers, this is quite big. So we're seeing that as Japan's population is aging, the amount of disability adjusted life years is also increasing. So more and more people over the age of 70 in Japan are losing healthy life years. I see Mark has taken a picture. Before I click on, I will let you take a photo of that. But all of these slides, just to say as well, actually are available on our website. So this fact pack was around 40 slides long, but I didn't want you all sleeping in the morning, so I thought I will shorten it and keep it sweet. But moving on, so when we're looking at things like healthcare spending in Japan, how does it compare to the rest of the world? So looking at OECD data, we can see that actually Japan has a really good and strong healthcare budget. It spends about 11% of its GDP on health, which is higher than the average for the OECD. But when it comes to things like prevention, Japan is lower than the rest of the OECD. It spends about 2% of its health budget on prevention. So whilst it is good overall, and it does spend more on long-term care, obviously to meet that ageing population, it is 2% on prevention, which it spends, which is obviously lower than our 6% that ILC are calling for. But nonetheless, what does this mean in terms when you dive deep into immunization policy, and what does that look like as a part of its prevention program? So as you can see on the screen here, working with our colleagues in ILC Japan, we kind of did a bit of digging and a bit of a background into what it looks like. And vaccinations for flu and pneumococcal disease are recommended for older Japanese adults, specifically those who are over 65 or those aged 60 to 64 with underlying medical conditions. And local government is responsible for issuing the vaccination. So local municipalities will be responsible for the vaccination programs in Japan. But the national government subsidises about 30% of that cost. And for those receiving welfare payments, vaccination is free. And I think an important thing to note, and a particular barrier for vaccination in Japan, is the fact that it has to be carried out under the direction of a medical doctor. So it cannot be given in a pharmacy like it is in the UK or places like France, like here. But it has to be given in a place where there's a medical doctor present. And if it isn't, then it can't happen. So there's a particular barrier at the moment we're seeing in Japan because of that structural barrier and that access barrier there. So just looking at data from Nishizawa here, again, our colleagues in ILC Japan, it's quite hard to find the data, but they found this report from Nishizawa, who kind of, as you can see the graph on the screen here, from 2011 to 2016, looked at the preventative healthcare budget in Japan, and as you can see, as a proportion of that budget, immunization programs only really accounts for about 0.1%, which is tiny. And whilst it has increased, the prevention budget has increased in Japan since 2011 to 2016. It's not really increased much for immunizations. And now, obviously, in the context of COVID, this will probably have increased. And obviously, we'd like to see that probably has happened. But in the same report, Nishizawa also highlights that actually the flu vaccine probably costs a lot more than they're letting on in Japan. Because, again, pre-COVID data, but around 17 million adults in Japan got the flu. Older adults got the flu vaccine in 2017 at a cost of around 4,000 yen. So when you translate it in today's money, that's about 433 million for that, per head, that is. I mean, if you compare that per head to England, or say England, and you take rough estimates of about, if you say a flu vaccine in England costs around £10, and you take that by the amount of older adults who got the flu vaccine in the most recent flu season, which was 2021 to 2022, which was about 8.7 million older adults, you could say it was around 86 to 87 million pounds per head in England. So really, Japan actually does probably spend a lot more on each person on things like the flu vaccine compared to places like England. But that's, again, because they have a larger population and a bigger aging population. But when we look at things like flu vaccination in Japan, and again, this is pre-COVID data from 2019, we can see only, around less than half of older adults in Japan got the flu vaccine, which is, compared to the OECD average, was around 46%. Obviously, this is just higher, but it really does fall behind other Asian counterparts like South Korea. In countries like the UK, obviously has a much higher uptake, but it is higher than other European countries such as Turkey or the EU average for that year. So yeah, Japan, whilst its population is aging, it's not necessarily translating into high uptake amongst over 65s. However, since COVID-19, could we say that attitudes have shifted in older Japanese adults? I think we've just spoken now about some countries. They've seen a real shift in vaccination uptake for things like COVID-19. And could the same be said for Japan, despite its low flu vaccine uptake? COVID-19 double vaccination rate stands at around 81%, and we're starting to see that booster numbers are plateauing around 60% in the country. So compared to the flu vaccine, obviously there has been a good response to the COVID vaccine. And what are the lessons that we can learn from this when trying to improve uptake in other programs like flu or pneumococcal disease? So I just want to conclude with the lessons that we can learn from COVID-19 and what can happen next. And I think there's three key areas to improve adult vaccination in Japan. I think it comes down to reducing the cost. It comes down to expanding access, and it's about raising awareness and keeping the momentum from the COVID-19 vaccination program, and applying this to other programs in Japan. So, for example, cost. The COVID vaccine is, like in many countries, it's universal. It's universally covered. It's free. However, the flu and pneumococcal vaccination, although it's partly covered by the national government there, it's not free of charge for older adults. So how do we encourage uptake? Well, could making vaccines free help? There's a lot of debate around whether cost incursion discourages vaccination uptake, but that could be one potential pillar that we could look at. I think, secondly, expanding access is really, really crucial in a country like Japan. I spoke at the start, or nearer the start of this presentation, about the fact that a doctor or a medical doctor has to be present when a vaccination is administered. But maybe it's something for a policy change for the Japanese government to really reduce these barriers and reduce that requirement, and making it more accessible by giving vaccination in places like pharmacies. And that can really help to allow older adults to access vaccination in more local areas and more local communities in places like pharmacies. And finally, as well, I think raising awareness is absolutely critical when it comes to trying to encourage and sustain vaccination uptake in older Japanese adults. We need to continue with the debate on vaccination and making sure that they become an essential part of healthy aging in Japan. And I'm sure David and Lily, when they're out in Japan next month, we'll find out more when we interview older adults and get the attitudes of older people there. So that's really just more about Japan and older adult vaccination there. But do visit our program page. It's on the IRC website if you want to see the full 40 slides. And again, feel free to get in contact with me by emailing me with the email on screen. Thank you very much.
Patrick, thank you. Japan is not the easiest of places to create change in immunization policy. And a whole lot of the lack of progress, I fear, comes from the government. And it's how to influence the government that I think is perhaps, to me, needing to be top of your list. And the Japanese government is extraordinarily risk-averse about vaccines. And there are a number of examples where they have simply collapsed vaccine programs because of real, rarely, or perceived adverse events. And the HPV program was known as a disaster. So, and trying to get explanations of why some of those actions got taken has been really difficult. But where do you see the opportunities for changing that government attitude towards vaccines? And the proportion of money invested in vaccines, I think, tells you a lot. How much appetite do you think there is for change, not from the population, but from the government?
Shall I respond
to
your question? Yeah, I think that's a really, really important point. And just to contextualize it a bit more, Japan has, it does have a kind of a marred history with some vaccination programs, and it has changed its recommendations and its guidelines for different populations over the years because of these, like you say, rare but adverse effects on some populations. I think talking to the Japanese government directly about this, like you say, they're very risk averse. It will be a challenge. I think for us, when we work with people like Strike Partners, they're an ethnographic research company, so trying to find out more from people and trying to come up with like people-based solutions and applying those to kind of policy recommendations is going to be key. If you can, back it up with the empirics, I think it'll be more valuable for someone like a Japanese policymaker to understand the reason why there is need to encourage uptake and to increase it. But I think as well we're looking to speak with big companies and organisations in Japan that could potentially implement some of these changes as well through the networks of older people there.
I have a comment. For different reasons, I went to Japan quite numerous times. At the time, a few years ago, surveillance was very poor. Epidemiologic surveillance or surveillance of anything. So if it's not done, then emotional impacts are much higher because you have no counter to that. So is it still the case about surveillance, epidemiological data, or something very strong implemented in the country? I think it would be a basis.
Yeah, I think I'm going to talk a bit more later for another presentation about uptake in Europe, but I think it applies to anywhere really. I think surveillance up until COVID-19 has been very poor when it comes to not only the disease itself, but also vaccination uptake. And without the numbers and the figures to highlight about how poor uptake is in a certain vaccination program, you're never going to be able to make that change. And I think backing it up with the data and making sure that it's collected year on year or at least bi-yearly is really, really important and something that countries should do more. So I think one of the things we could recommend in Japan, at least to a more, a macro level for policymakers, is to really try and increase surveillance and increase how they track vaccine uptake, because I think then it really reaffirms where the gaps are lying. Specifically at a local level, if you can do it at a national sort of level, that's fine, but recording locally where there's low uptake, you're more able to have an impact and go out to those places and really try and understand what the issues and the barriers are, and then come up with those local driven solutions.
Yeah, it's really interesting, Patrick, and I agree, David. I think the Japanese government is incredibly risk averse, but as we look at the uptake of COVID vaccine, I wonder if there's a real opportunity here in terms of shifting government attitudes for vaccination, specifically in older people, because it's a fairly logical argument to say that, you're giving the COVID vaccine, we now need to include, et cetera, and they're sort of primed to take it up. I think also in Japan there is a unique opportunity in that they have a mandatory long-term care insurance scheme, and what that requires is a comprehensive assessment of individuals as they sort of start to enter or transition into the program. And I can't remember, I actually think there may be an annual assessment that's undertaken on every older person in Japan, and ensuring that vaccination status is a part of that assessment, which I doubt it is at the moment. And again, using COVID as the entry point, I think there is a window of opportunity. Now is the time to try and shift those attitudes.
Yeah, I completely agree with that. I think just to add to that, and then talking about the attitudes, that IRC Japan actually did do some kind of qualitative analysis and some interviews with older Japanese adults ranging from 65 up to like 95. So a real breadth of older adults and their attitudes on COVID vaccines, and they're in the full facts back on our website. But some of those people said, interestingly, we hear a lot in the news about COVID. I'm not really sure I want to get the vaccine, but if I'm being told I need to get it, then I will. If my doctor says I need it, then I will. But they relate it back to flu, and they say, well, I don't ever get the flu vaccine, I don't need that, I don't want that. But with COVID, something has shifted, and I think there has been a real sort of, something has changed, obviously, with how it's obviously had an impact on older people. In a lot of older Japanese people's minds, at least from the research from IRC Japan, it was like this, I'll get it if I have to sort of attitude. But maybe that does need to be integrated further, and using that sort of, making the same case with flu vaccination and why that's important for when you get older. And, those health checkups, yearly checkups, is something, a key area, where you could integrate that. Paul, did you have?
Yeah, building upon that, I mean, like when they were leading the G20, you were able to get together to get some kind of statement there on adult immunization, I think, in their recommendation. And they've got G7 next year in June, and being on the forefront of aging societies and what you just said, doing pretty well on COVID, could there also be some kind of leadership sort of role there in terms of immunization and taking the G7 as an opportunity again to try to see
if Japan wants to come more to the forefront in this particular field as well. So it's just a question if there's an opportunity. If you're talking anyway in Japan, it could be something to raise.
And when they were the previous leaders of the G7, they actually did try and provide some leadership on older people.
Yeah,
so I think they're really open to that.
No, definitely. I think key opportunity there is like in 2019 when we were able to influence that memorandum or whatever, the piece of documentation which was published, it was very clear that there was more of a focus on older adults. But I think immunisation really needs to be a part of that focus as well, amongst many other things as well to do with prevention. One more.
If we go back to Lewis's missed opportunities, to actually have an annual appointment and you don't include your immunisation checkup in that annual appointment, that is the ultimate missed opportunity. And yes, we had a hand. Yeah, please.
Thanks. I was just interested in why is the cost of, I think it was a flu vaccine, 2.5 times more in Japan than England? Is that because of that requirement to have a medical doctor supervising administration?
If anyone knows the answer, do let me know, because I would love to know that as well. But I was thinking this actually when I was looking up through my slides. I did think that, and I wonder, maybe it's because of the healthcare setup. I think with the NHS, you probably have. You would probably be able to evaluate more on this.
Is it price or cost? Because if it's the price of the vaccine, that's a negotiation.
Yeah.
If it's the cost, then it may include the provision, which may in itself be expensive. But you need to be comparing, apples and apples.
Yeah.
So it would be helpful to know if that was price or cost.
Yeah, I'll find that out.
Okay. We're now going to get on our aeroplane and fly from Japan. And I'm not sure if the first stop is Hong Kong or the second stop, but we're going to hear from David on Hong Kong and Singapore.
And actually, I think I'm just going to focus on Hong Kong because it's particularly given the COVID context is particularly interesting. Just to finish on the project we're doing with Stripe, and please do have a look. The Stripe are a really interesting ethnographic consultancy who do these design workshops, and their normal clients are people like Spotify and Google and Facebook. So ultimately what we're really looking for there is really interesting solutions that might actually be tech solutions. They might be, and what we want to do, so a bit of an appeal here is to be, we're going, we know, I'm sure Japan will be a perfectly easy place for us to run a design workshop. Culturally, it's going to be fine, but clearly we have to get over that barrier. But once we've done that, actually what we want to do is get hold of people like Mercer and people like Uber and people in private pharmacies so we'll actually be looking at developing not just policy solutions but potentially products, which we'll then want to go and say, look, actually, does someone want to go and prototype this? Does someone want to turn this into a product that could increase uptake? So if there's anyone in the room who's interested in helping us out with that, that would be great. And then also, or online, we've got a plan in June to go and do an event in the British Embassy, and we're working with the Japanese government in relation to that, and then another one later in the year. So we do want to engage policymakers clearly, and G7 is a very useful opportunity because also there's a big, the regional IAGG is in Japan next year as well, so there's some big opportunities there, I think. So Hong Kong's really, and I'm going to focus on Hong Kong for a couple of reasons, but partly, clearly really, really interesting in the context of COVID. Hong Kong, like Singapore, like Korea, aging relatively rapidly compared to Europe and North America, where we aged over about 300 years. In places in these countries, they're aging at the same rate over maybe 30 or 40 years, which actually creates a degree of political pressure potentially that we haven't seen in Europe. It's always been possible in Europe to just put it off because, aging's actually been remarkably slow. Now, actually, these governments are going to have very, very significant challenges, perhaps more so, but they also potentially have stronger policy levers than you have in Europe and North America. So actually, I think there's a good chance on the aging policy agenda over the next decade or so, we'll be looking to places like Hong Kong and Korea Singapore as potential leaders in this space because they have they're wealthy, they have significant investment in tech, and they have the political ability to deliver. Just the small graph on the front's worth noting, actually, of course, in China, Singapore, Hong Kong, the what is traditional working age population is already starting to fall, and some of you will be aware that there was a big study published in Lancet 3 or 4 years ago that talked about China's population starting to fall from 2050. Some of you will have seen that China's population has started falling. So there's a really interesting thing that actually clearly part of this is COVID related. We've seen extraordinarily low migration across the global migration compare over the last sort of couple of years, which has had significant impacts on demographic projections. But actually the China population, so that the Chinese population seems to be starting to decline way earlier than predicted, is in some ways slightly surprising. Data is clearly an interesting question. So of course the context of Hong Kong is really interesting. You've had the zero COVID approach, but actually you've also had a real challenge with engaging older people with vaccines, with the COVID vaccine. As of this March, so only a few months ago, only 15% of older people in care homes had their COVID vaccine. So you still have very, very low rates amongst older people who may be particularly vulnerable. Whereas in places like France, being told that you couldn't go into a cafe led to lots of people going and having their vaccine. That has not happened in Hong Kong. Actually, there was a story in Telegraph a month ago that said, had a quote from an older guy in Hong Kong that said, I haven't been out to a restaurant for 2.5 years because basically I'm not going to get the COVID pass. So you've got very, very significant sort of issues in Hong Kong. So I'll sort of tease out. And it was very clear, it was entirely predictable. So I did this work in spring 2019, and pretty much all the issues that came up were issues that have come up for Hong Kong over the last few years. So essentially, and this perhaps leads into this afternoon session, you have a system where which is fundamentally built on curing rather than preventing. I think fundamentally one of the biggest challenges you have in Hong Kong is the really poor access to primary care, particularly outside the private sector. So if you don't have a private GP, you essentially, there's very, very low access to primary care. So, and the quotes I've got are from some of the people I interviewed. So some of the headings are from people I interviewed during the time. When I first started looking after older people, they weren't so old. But really, really, really interesting group of people I spoke to. And I'm going to try and do this as a bit of a story, really, if I can. So first context is, and there's, clearly I'm not an ethnographer, but clearly as part of my ethnographic research, I decided I need to go to the horse racing in Hong Kong. But actually, Hong Kong, extraordinarily wealthy place on the one hand, and this was, I paid my $1 and went in on the cheap bit at the bottom and did a bit of watching. What you see is people spending quite a lot of money in the racing, and then the racing's finished, and you have people in there, actually sometimes 70s, 80s, 90s, fixing the holes in the, you have extraordinary issues with pensioner poverty in places like Hong Kong, despite the wealth in the area as a whole. And as one of the interviews said, it's actually still not very easy to die in Hong Kong. 15% of the population was 65 and over, life expectancy very, very high, and low levels of fertility. So actually you have the part of the world where people are living longer than anywhere else. But like we saw in Japan, we're starting to see a group of that older population who are aging perhaps less well than previous cohorts. So chronic conditions potentially increasing. They've been experienced at an earlier age than in the past, and of course dementia, extraordinarily important issue. This, by the way, is also the racetrack that I went for a jog round in the morning, and they had some older men playing football. So there's a bit of healthy aging, a bit of active lifestyles over there, which is interesting. Clearly, healthcare extraordinarily good, one of the most efficient in the world. So slight, in some ways, I don't know if it's good or not, but the sort of slight obsession with, aging tech is interesting. The extent to which we know whether some of this really works is interesting, but actually, clearly, you go into, and actually, I was took by, so I went over to Macau whilst I was there, and they decided that the tour they wanted to take me on involved me basically just going and showing me every casino. But he worked for the government, so he wasn't allowed to go in. So he basically stood at the door and said, go and have a look at the casino. But actually, one of the things about the casino was even in the casino, they had these aging hubs in Macau as well. They had these places where they were selling age tech and healthcare tech in places. So you see this quite a lot. But what you are seeing is aging population, the healthcare system coming under increasing strain, and clearly preventative health is an area where there is very significant issues, as indeed, and I won't say very much about it, but actually you see this nice and clear night in Hong Kong. Hong Kong has massive issues now with pollution, which makes it particularly unpleasant and is likely to have long-term health impacts, which are going to impact upon the population. So focus on cure. Across the whole of Hong Kong, there is only 73 public general outpatient clinics to provide primary care to 7.5 million people. What this does is puts extraordinary pressure on A&E departments. It's basically, if you don't have access to your primary care, you go into the A&E instead. As Sophia mentioned yesterday, ILC's work showed that in the UK we're facing significant shortages of people over the next decade, and clearly it's also the case with healthcare workers. But then Hong Kong faces an extraordinary challenge in terms of particularly doctors. So very, very low levels of doctors numbers of doctors compared to similar countries. And one of the real challenges they've got is that they can't import doctors in the same way because of the language requirements around. So you have to be able to speak Cantonese, isn't it? Not Mandarin, Cantonese as well. So potentially a real challenge that they're going to struggle with for a long time. Clearly, very, very strong private healthcare systems, high levels of out of pocket spending, and again issues particularly for that 30% of older people who are very poor around actually how you can afford to pay for some of these out of pocket payments. Sort of stepping back a bit, it's really interesting that you do see you've got an area with real wealth, and they seem to, everyone I spoke to said, we do all these pilot projects, and they really do pilot projects on everything, and actually put quite a lot of money into it. This is a really, really interesting initiative that they have had from 2009 that they called the Elderly Healthcare Voucher Scheme, and essentially you've got a voucher for £200 to spend on preventative services. Really, really interesting. The evaluations have not been particularly positive in terms of low enrolment by the private sector, schemes being abused. One of the best things was that almost everyone we spoke to about this went on about sunglasses, or designer glasses, and I was just, and it's become a thing that basically what people, and I don't know if it's because the newspapers have started writing stories about this, and I don't even know if it's true, but everyone talked about the fact that what people were doing is using this money, saving it for 2 years, and then using it to pay for designer glasses. And as I say, I don't know if it's true, but actually it's obviously a story that is going around the newspapers in Hong Kong to try and encourage. So there is a really interesting idea here around actually, can you provide a bit of cash for people to invest in certain preventative services, but actually at this stage it doesn't seem to be working as well as it could be. You had these what you had just as we were there was a plan to launch these district health centres, which I think were really interesting and offered a lot of opportunities. The plan was you had one in every of the 17 Hong Kong districts, and I think it is being pushed out still. And the idea was, in the absence of actually having, access to a GP directly, you have these centres which would do all sorts of things, including access to GPs and other preventative care. So it will be interesting to see how those develop over the next sort of few years. Healthy ageing is certainly on the agenda there. Government talks about healthy ageing a lot, and when the people we talk to in government sort of really saw it as being a real focus. So there was a sense that people sort of, the both government, the voluntary sector, the private sector, universities saw it as being extraordinarily important. But actually, at the same time, it's a really great quote from someone: everyone's doing something, but not in a concerted manner to have the best impact. So real sort of a bit like the impact of the issue around all of the trials and the testing. Actually a scattergun approach, fairly sort of random approach to doing a new trial on X or Y. And there was this elderly services program plan in 2014, but actually again it had become a bit more like a checklist rather than a real strategy for preventative care. In terms of adult vaccination, clearly really, and I think this is where the COVID issues really is clearly very interesting in Hong Kong. You had at the time, and I suspect still do, very low levels of uptake of flu and pneumococcal vaccination, despite it being potentially free amongst older people in Hong Kong. And part of the reason for the low levels of uptake was the limited network of public GPs. Partly that GPs were not financially incentivized enough to do it, so actually there wasn't enough of a case for GPs to actually do this. If actually with this £200 voucher or whatever, they don't even want that because it's not enough of a financial incentive. You see why there isn't the financial incentive. And whilst what they had done, just before I was there, was developed an initiative to subsidise private provision of vaccines, but patients still had to pay the difference. So there was still a bit of a barrier there. Why? All sorts of reasons, and this was raised. I think was this the one raised yesterday? Sorry, I'm going the wrong way. Let me go back. I'll get used to the tech eventually. I've only been doing it for 20 years. Low awareness was a massive issue within the area. Also, some really interesting issues with ethnic differences in terms of uptake. As we've heard earlier from other places, data extraordinarily weak. Really, really hard to get information about uptake in Hong Kong. And as we've heard in other places, one of the interviewees said, "Why should I get vaccinated if the doctor doesn't?" So, 2012. And looking at data, this was the most up to date I could find in 2019. 2012, 2013, seasonal flu uptake by healthcare workers varied 28 to 44%. Only half of GPs would recommend the pneumococcal vaccines to those over 65. One of the things that came out from some of the voluntary sector people we talked to was they felt that actually there was a role for a bit more by campaigny social marketing work in this space. Also, and this was the bit that came up I think yesterday, there are some cultural and cohort barriers. So one person said, well, older people just don't have a positive impact of vaccination. They say it's intrusive and makes them sick. As someone mentioned, I think it might have been Catherine yesterday, actually because people in Hong Kong have lived an extraordinarily long time, older people may not have had a children's. They actually, there wasn't a children's program in place when some of them were young. So actually, they just didn't have the experience of vaccination. There's a question around whether older people may see traditional Chinese medicine as an alternative, and actually very low levels of literacy amongst the oldest old as well. So actually, this is often underplayed. That actually, amongst those sort of in their 70s and 80s, actually they didn't even go to school. Some of the old, so very very low levels of health and financial literacy. we met a few people from pharmacies who said, well, actually, clearly we could do something more, and there was a plan for a bit more, and of course they would say that, but actually I think they could, but actually at the time pharmacists weren't even allowed to dispense. So, you know, you had this sort of real issue where with community pharmacy, potentially extraordinarily well trained, but actually not able to do even fairly basic preventative services. So I think when you then think of COVID and look at where COVID has been in you know, actually, I think some of these things we found in 2019 highlighted the challenges that Hong Kong was going to face, with particularly the hesitancy amongst the oldest, and we still see sort of uptake amongst COVID being relatively low. So just to finish, you know, clearly for me the big messages were data collection, extraordinarily difficult to get access to information. The voluntary sector people we met really talked about campaigns that had been run with older ambassadors and that they had appeared to be successful, and there's a case for doing a bit more about that. And as I think thinking particularly a bit more about the role of pharmacy, but also the role of these district health centres, and whether some of those could provide a greater role, not just in terms of vaccination, but other preventative conditions. So at that point, I'm going to stop. And there's all the very nice people who met me. So thank you.
Wait and see if there are any questions or challenges.
Thanks, David. Really interesting. Could I just ask, where do you think this legacy of a sort of cure rather than prevention approach to health there? It seems like there's a non-existent public health philosophy there.
It's really weird, isn't it? And actually, of course, yeah, it's very strange. And I think particularly, you know, and I think it's worth particularly in a place where people live extraordinarily long lives. And actually, I showed the football, but actually the reality is people do active travel. They don't really do sport. You know, they go for a walk, but actually it's really interesting that active travel is an extraordinary important way for people to get around. But I don't know. Just people said, you know, they don't do it. And I think a bit of it is that, you know, the private versus public delivery. They're actually in the private sector. Does that mean knocking those things? No. So yeah, I don't know why. But interestingly, I didn't talk about Singapore exactly the same. So Singapore message is almost completely consistent with Hong Kong, and they never like being in the same presentation. So that's another reason for me taking it out. But very, very similar issues in Singapore as well.
I want to take just two because we're running in arrears. No, we're going to take maybe later.
I will be very quick.
But one and then two.
In Asia, people are working very late. I wondered if they have a basic retirement pay, and it's one point to get medicine, any kind, prevention. And the second is not political question, but what is the imprint of China on health in the very past few years, because they are increasing their role.
Yeah. Do you want to do yours, Daphne, and then I'll come both? Yeah.
I was just going to ask whether you spoke to the ordinary man in the street, whether you went into the markets and spoke to the people there, because it struck me when I've been there and when I've had any conversations with people that you spoke about education. Their major thing is educating their children, so they do work extraordinarily long hours, as Catherine has said. And their money, they're not necessarily poor because they send all their money abroad to Canada and places where their children are. So I just wondered if you'd had any conversations with ordinary people.
No, so we didn't as part of this. We mainly spoke to sort of individuals who had direct contact with older people. But yeah, I'm sure you're right that's that's true. I think there is absolutely linking into Catherine's, but there is an issue around the issue around poverty, and it is an extraordinarily important issue, and the relatively and across the whole, lots of, you see in Japan as well, you see a lot of older people continuing to work well into their 80s and 90s, actually, in places like Japan. So it does happen, and it's partly people are forced into it. And that's in some ways why it's slightly surprising that actually the sort of, in Hong Kong in particular, you don't have the high levels of uptake. In terms of the China impact, I suspect it's changed since 2019, and I suspect it will continue to. But actually, at the time, there was still a sense that, that I didn't really pick that up from anyone. I think actually one thing I haven't sort of spoken about is that actually the Hong Kong government, and I don't know if this is down to the Chinese influence, but like to show that they were doing things. So there's loads of things that people talked about which actually had completely no impact at all, but was just about proving they were doing something. So there was a really interesting thing about, apparently they're massively running out of graves. They've got nowhere to bury people, and everyone wants to be buried facing the sea and things like that. So the solution that the government's introduced has basically been to put up some posters advertising green funerals, and it's just, so there is something about the government wanting to show that they are doing things, but I the efficacy is questionable, I think, of some of them. Anyway,
thank you.
Thank you.
We need to move on, please. We are running in arrears on time, so the coffee break is going to have to be shorter because we've got some people who are going to be phoning in later, so we need to catch up some time. Jean-Pierre, please. Situation in France.
So thank you very much for asking me to speak about France. In fact, I am a geriatrician. I was trained in France. I am now working in Geneva. I have been working in Geneva for 35 years. And I was very impressed by the round tour that you have now about vaccination all around the world. You started by US, then we went to Japan, and then to UK, and I will go to France. But I will be very concrete, and I decided not to use any slide. So the first thing that I would like to tell you is that I try to have a panorama of vaccination in France. And in France, for COVID, the 78% of the population got a complete COVID vaccination. And what was very surprising during this period that we spoke of a lot this morning and yesterday is that, in fact, in September 15, the mandatory vaccination was obliged for the healthcare professional. And I think that it is something that was really an event in France and also in other European countries, and particularly in Switzerland. I think that it's a very important point. The second thing is that in France, pharmacists had a very, very important role in the providing vaccines, and their role was really very useful. They started doing vaccination in 2 or 3 years before with flu, and then they were able to do the COVID vaccination, and I will speak of pharmacists later to know what is happening now in France. The second point that I would like to raise concerns the flu vaccination. And what was very surprising since 2009 is to have a very deep decrease in the uptake of flu vaccination in France. And this decrease was so important that only 24% of the whole population get flu vaccine. And concerning the population over the age of 65, only 50% of the population get the whole population get the flu vaccine, which is quite surprising. And what I have to linking COVID vaccine and flu vaccine, the government advertised a lot concerning the two vaccination together, and it was not a success. And the pharmacists and the medical doctors found a lot of difficulties to provide two vaccinations at the same time for the whole population and for the whole population. So, which is something that we have to mention. Third point for me, which is quite important and impressed me a lot, is the problem of pneumococcal vaccine. So we know that the intake of pneumococcal vaccine is very low, but what surprised me a lot is to find that chronic disease patients did not get the vaccine. Less than 5% of the chronic patients with either COPD, diabetes mellitus, or heart failure did not get the pneumococcal vaccine. Less than 5%. And I think that it's something that we have to focus on, because it's probably one problem with not only the GPs, with the medical specialists who are not aware of the benefit of pneumococcal vaccine and flu vaccine in this kind of patient. Concerning the other vaccine, those vaccines are not at all used in the whole population. Less than 1% of the whole population gets the vaccine in France. And concerning the TAP vaccine, they said, and I found data saying that 1/3 of the whole population had this kind of vaccine to prevent this kind of disease, which is probably very low. You asked me another question concerning the comparison between the uptake of vaccine, flu vaccine and pneumococcal vaccine. And I was shocked by something that, in fact, the coverage rate with COVID was much more important than with the flu vaccine. And when we are looking at the different countries, we were quite surprised to see that, for example, the COVID vaccine was mainly distributed in Spain, then in France, and at a lower level in Switzerland, Netherlands, UK, and Austria, which is also very surprising because it's not the ranking of the flu vaccine. In the flu vaccine, you can see that one of the two best countries for years and years are UK and the Netherlands. And you asked me to know why it is so different and why UK and the Netherlands are always at the head of this vaccination rate. Personally, I think that you have more incentive in UK, but you know better than I, than in other parts of Europe. But I don't know why there is a very high vaccination rate in the Netherlands. Concerning the main challenges that we have to face, I will take, I think that I will repeat what I said yesterday. I think that there are two challenges. For me, one of the biggest challenges is the life course education and also health literacy. I'm very sorry to repeat it again, but I think that people are not able to access true sources of information, valid sources of information, and then to understand this kind of information. And really, I think that this point of getting valid information, understanding this information, appraise the information, and decide is something that is very important. But after that, there is, as it was stressed very well this morning, the trust in the healthcare system, the trust, the access also to vaccine center. I think that there are two things, education in one part and also the trust in the government, trust in the system, and access to the delivery system, and it was very well stressed this morning. In France, I think that two very important initiatives were taken in the last few years, and I would like to stress them. The first thing is that now patients can be vaccinated by a lot of different kinds of healthcare professionals, which is quite new. Nurses, midwives, pharmacists indeed, and MDs can vaccinate all people and all the population, which is something very important. Another thing which is crucial is that school doctors and occupational physicians can now order the vaccine and vaccinate the population that they are taking care. So I think that these two measures could be very useful to increase the vaccination uptake. The last question concerns how to have an increase and how we can better vaccinate. So now I will speak really personally about what I am thinking. The first thing that I'm thinking is we and people all around the world probably forgot too much the history of vaccine. And I think that it would be very good to remember that the progress in vaccine were extremely useful to decrease the mortality first, but also to increase longevity. And I think that we need to remember this kind of history of vaccine. And I am sure that if we have the chance now not to have smallpox, it is only because the vaccination rate was 100%. And if we have less polio and only actually today polio in Bangladesh, it is because the rate of vaccination is not 100%. And I think that this kind of data needs to be repeated and repeated and repeated to understand how vaccine change completely the aspect of life in the world. The second point is indeed, I believe in life course vaccination, but I have to speak of it later, so I will not insist on it today, now. But I think that life course vaccination is probably one of the best things to promote and to act in it. The third point is something that was stressed by Professor Salisbury this morning, is that we forgot too much about the problem of vaccine-preventable disease. We are always speaking of vaccine-preventable disease in children, but you have to know that the number of vaccine-preventable disease in old age is multiplied by 10 in old age compared to children. So we have to focus on adult vaccination to prevent this vaccination-preventable disease. And it is something that we have to focus on to be aware of. Another point which I believe in is that we did not speak until now about the non-infectious effect of vaccine. And I think that in adults, we have to stress the fact that vaccines are really important to prevent all causes of death in old adults. And it is in 2006 that the American Heart Association said that flu vaccine prevent atherosclerosis and prevent coronary disease. And in fact, nobody knows that and nobody stresses that, and I will insist on it. There is not only the problem of flu vaccine, which prevent death, all cause of death in heart failure patients, in coronary heart disease, etc., but there is also pneumococcal vaccine, which is not less efficacious than the flu vaccine, but which is also one preventive cause, but also herpes zoster, which decrease the number of stroke. So I think that herpes zoster vaccine who prevent strokes. So I think that this kind of aspect will be very important to consider. Another point which is emerging, but not really well established until now, but I think that we have to think of it when you are thinking about life course vaccination, is the fact that children vaccination can also act on the life course approach or health of the old people. And I was very impressed by two studies coming from Australia and US saying that rotavirus vaccine in children decrease the incidence of diabetes type 1 by more than 20%. Can you imagine rotavirus vaccine in children protecting the diabetes type 1? And now, more and more, we are thinking about the problem of infectious disease and dementia. This topic was discussed for more than 30 years, and nothing was affirmed on this domain. But there is one nice study by Vigneault in 2010 who was impressive because he analyzed one cohort of Canadian demented patients, and he tried to look at retrospectively if they got or not the children vaccination. And he finds that there is one relationship between the children vaccination and the dementia incidence. So it is one study, we have not to say about it, but you have to be alert to know that perhaps there is a link between the action of the anti-inflammatory action of vaccine and also the preventable activities. To last, I have to remember that yesterday, I always stress it, I stressed the problem of One Health. And I think that really the problem of One Health has to be approached in a very nice way. Because it is one way of approaching at the same time human health, animal health, and natural health. And I think that it's a good way to approach this kind of different activities and to think about the emergence of antimicrobial resistance and to decrease with vaccine the antimicrobial resistance. So, and to last, I would like to say that I personally did a lot of effort to try to convince my colleagues and also authorities around me since many years to try to build European recommendation for vaccination of adults. And I am now at the third attempt. The last one was with the European Federation of Academy of Medicine. We published in April last year a document which was now available for you too, but I don't know if we will have any impact trying to harmonize the different guidelines in Europe concerning adult vaccination. So I would like to thank you for your attention, and I will be pleased to answer your question if you have any of them. Thank you.
A lot of really insightful commentary that you have given us, Jean-Pierre. One point that resonated with me, and it's about healthy aging. And if you want to be successful in having healthy aging, the people who are perhaps younger than 65, who are not in good health, are going to have a considerable impact on when they do become older. And you talked about the difficulties with pneumococcal vaccine for people with risk factors. And so the same is true, but actually worse for influenza. And if in many of our countries you are 65 and over, actually there's a pretty high chance you'll get flu vaccine. 75% in a number of countries. Not all, but a reasonable chance in some. But if you now look at the people less than 65 years with risk factors, you just can't get the same figures. And yet they have higher chances of dying from flu than do the people without the risk factors. And if you look at the risk of dying from flu by risk factor, you are 10 times more likely to die from flu if you have any risk factor than if you don't. If you have diabetes, you are 6 times more likely to die from flu than if you didn't have diabetes. If you have immunosuppression or liver disease, you are 50 times more likely to die from flu. And these are the people who we know are at risk of flu, and we can't get them to be vaccinated. And as they mature, they're going to become increasing burdens to themselves and to society because we weren't able to protect them. And so your point about pneumococcal vaccine, I think, transcends many of the problems of trying to vaccinate people with risk factors.
May I add something?
Of course.
You speak about death, but I was also speaking about disability.
Yes.
And we forget too often that, in fact, infectious disease provoke disabilities. Yeah. And I think that it is also very important. Yeah, there is death, but people also were disabled before the death.
But the death is often easier to measure.
Exactly.
It's the absolute measurement.
But I think that it's also more costly to be disabled.
You are right. You're right. We've only got a short time for questions, but please, let's get a few done and then stop for coffee.
Yeah, knowing everybody wants to get to coffee, I'll be very brief. I really like this last point of yours, Jean-Pierre. And it touches on what you said earlier, David, which is if we're going to look at the impact of vaccination, we need to think much more broadly than prevention of a disease. Yes. Because it's actually all the other consequences which may occur afterwards. I mean, and so it may be that relatively minor infections such as cytomegalovirus or things like that have a significant impact on subsequent immune senescence, inflammation, and some of the things we see in older age. But we're not actually thinking about the link between the infectious disease and later consequences. We're thinking just about how do we prevent the disease. So I think as we look at the impact of the of vaccination, we actually need to broaden our thinking, just as Jean-Pierre is saying, to think about morbidity, but not just morbidity from the condition, morbidity from a whole range of other conditions which will be consequent on these chronic inflammations which start with these infections.
May I add something? I think that which is very important to have in mind is if a person of 80 years is lying during 3 days in the hospital, he will lose 1 kilogram of muscles. So he had already sarcopenia, and now he will have acute sarcopenia, and his mobility problems will increase a lot. So by preventing this kind of disease, we'll prevent a lot of things behind. You're completely right, John. Thanks.
I mean, if you look at the impact of norovirus in older people on their ability to return to the same health state that they were before they had an acute episode of norovirus, it's very hard to get back to where you were before. And it just resets that line on, between the X and the Y axes of when actually you hit the X axis.
And it is a problem of frailty because they are not able to recover. They are recovering very slowly and never at the same level.
Yep. Okay, coffee. And try to come back in about 15 minutes.
Thank you.
Thank you. or if it's advanced.
This year I did it.
I will check.
It looks like it's available. So
Let me.
if he can change, then I don't care about that.
Okay, let me see what I can do.
Half an hour of lunch. But if he can't, we'll go with the two.
I know him.
Once the sort of vaccines became established and were being implemented, that thankfully quietened down. And what's happened recently is all the sort of non-COVID vaccines that was not being given attention for 18 months is now all sort of surging again. So now you've done quite a bit of background discussion in the first session. Now we're going to be looking at reaching adults. And we're going to start with Sophia Dimitriadis on deprived communities. Sophia, please.
Thank you. So I'm just going to talk about a project we did this year funded by the Vaccine Confidence Fund, which is a bit of a different project for us, essentially exploring how we can use social media to improve vaccination rates among people living in deprived communities in the UK. So just to give you a bit of context here, so essentially what we're kind of seeing is obviously that, we know that rates of people living in deprived areas are far lower, routine vaccination rates among older adults living in deprived areas are far lower than those in less deprived areas, and that's for flu, shingles and pneumococcal. And also we know they're more likely to be hospitalised if they contract diseases, so it's kind of, it's more effective we can target people from these communities. But we're also seeing another phenomenon that older adults, but including people from those marginalised groups, to increasingly taking to social media. And we're thinking, is there an opportunity to use this platform to increase rates among these groups? But there is a key challenge, and essentially, particularly when thinking about older adults and social media, there's still definite evidence that younger people are still far more likely to use social media despite this kind of change in rates and engage with its content as well. So they're more likely to post more. And emerging evidence does suggest that, I say limited emerging evidence base, but there are some interesting studies coming out that younger people can influence the health behaviour of older adults. So to give an example, there's a study in China talking about younger people living with their grandparents over the pandemic and talking about how they actually influence their health behaviours in a positive way, and vice versa. There's also some studies around kind of using children at school to influence smoking rates of their parents, and actually that was actually very successful because of using that kind of intergenerational relationship. So we're thinking about that, and another kind of phenomenon we're noticing in the research is that older people do tend to use social media mainly to keep up with friends and family, often distant relatives. And so there's a key kind of family aspect to why they're using social media. So kind of bearing all this in mind, we're asking, can younger users be part of the solution in terms of thinking about how we can use social media to address inequalities in vaccine uptake among older adults? So kind of two key research questions. Firstly, can we use social media to effectively increase routine vaccination uptake among older people from deprived communities? And secondly, key question really, is it more effective to engage older social users directly, or is it more effective to use kind of younger users as a conduit to persuade older relatives to get vaccinated? And even the first question we haven't really seen much evidence of using social media directly to improve vaccine uptake. But that second question hasn't been tested online, even though there have been a number of kind of studies offline in terms of health and intergenerational focus. And so to kind of answer these questions, first we did some preliminary research. We did a national representative survey, as well as 4 focus groups of people from our target communities of different age groups. So 2 focus groups of younger people from those that aren't eligible for vaccines, the pneumococcal and flu vaccine, and 2 focus groups with the older adults that are. And then we use this information to design campaigns, which we then tested on Facebook and Instagram, which we'll talk about in a second. So just very quickly, in terms of our preliminary research findings, some key points that came out is firstly that when thinking about the pneumococcal and shingles vaccines, the key barriers to people from our target communities, and these are the people living in the most deprived quintile of the UK, were that they just aren't aware of this. So probably no surprises there, but very, very high rates of lack of awareness. While in terms of the flu vaccine, we've seen the barriers are more varied. So, not wanting to see the doctor, which might have been an issue during the pandemic, beliefs that the flu isn't dangerous, that people that they're healthy, not needing the kind of flu vaccine, and a lack of time. So access is a key issue. And the key points about when thinking about what messaging we need, what will kind of resonate with these groups. And a key point that came out is that messaging mustn't be coercive, and that's particularly among those aged 50 to 65. Where we saw this particularly high kind of anti-vaccine sentiment among that group, a real suspicion of coercion, and really kind of much more positive about factual information. Interestingly, those aged 65 and over didn't seem to be as prone to that anti-vax sentiment, and that kind of warm emotive messages seem to resonate as well, not kind of too negative emotive, different kind of warm emotive messages. And those under 50, kind of similar points to the above. Interestingly, they were kind of quite worried about feeling that they lacked knowledge. There's a lack of, not sure what kind of knowledge is kind of misinformation on social media, and they were really worried about passing that. So ways to break down that, so making sure the messages gave them enough information to feel confident to be that messenger. They also didn't want to kind of tell their loved ones what to do. They wanted to give them the information, so that was quite clear. So using these findings, we kind of settled on creating adverts that were trustworthy, conversational, open, family-oriented and warm emotive, as well as, really importantly, informative. And we worked with a social media agency to create these campaigns. And so what we did is we created 3 campaigns for the flu vaccine and 3 for the pneumococcal vaccine. We didn't actually test for the shingles vaccine, just to keep this kind of study quite tight, with some interesting implications for that vaccine as well, across a month in December, and Facebook and Instagram. So this was quite late in the flu season as well, where we were hoping that most people who would have got the vaccine would have already got it, so hopefully trying to target those who wouldn't have wouldn't be thinking about getting the vaccine typically. And the key, we kind of did 3 different types of adverts. So we had like a single image, a GIF, as you can see in the centre, and then a video. And we had kind of a mix of those warm intergenerational images of people from different ethnicities, and a kind of mix of factual information about where you can get it. Also kind of, what are the impacts of not getting the vaccine, to kind of that, using what we learned, and quite soft informative language. Pop down to your pharmacist rather than, have a chat kind of things. And two kind of main point is that we had 2 audience groups, an older audience group who are eligible for these vaccines and those who aren't. And so we had slightly different messaging for those targeted at older adults and those targeted at younger adults, to try and either encourage them directly to get vaccinated or to encourage their loved ones to. And if you clicked on these adverts, you'd then end up on this landing page, and that essentially allows people to have a button to click to actually book their vaccine. Now in the UK, we don't have a kind of, you can actually just book the vaccine straight away, but with the pharmacy you kind of can, but with your GP you'd have to contact them directly, but it goes to the NHS page to do so if you click on that link. So that was a kind of proxy for booking, as close as we could get to really. And we also had the opportunity to share it, and obviously for younger generations that was kind of upfront to pass it on to their loved ones. But we gave that option to both younger and older adults. And we also offered us a chance to a survey to get more information from those participating in the study, or users online. So what did we find? So kind of key findings overall, our campaigns resonated with people from deprived areas. We had initially wanted to also look at people from kind of ethnic minorities, particularly from black communities, because we know uptake is low, but it was very difficult to actually test this on social media. I can talk about this at the end. But they did clearly resonate with people from deprived areas. So we're quite interested. We weren't sure whether we'd find this. So we found that we reached about 1 million people, and about over 1 million people, and about 1 million, we had 1 million forms of, around 1 million forms of post-engagement. So about 76% of those who saw the ads engaged, which we're told is relatively high for a campaign like this. And the click-through rate was about 2.5 times better than the click-through rate for healthcare ads at that kind of year. Just to mention, we were looking for proxies of kind of vaccine campaigns, and it was very difficult to find that information to compare, so that's something I'll talk about at the end. But kind of relative to other click-through rates, that's quite high. But the key finding, and that's the most important for us, is that it did seem that the campaigns effectively increased uptake if we use that booking link as a proxy for vaccine bookings. So we found that flu vaccine ads targeted older adults actually likely increased uptake effectively, so the incremental cost effectiveness ratio per quali, I know this is a narrow measure as we talked about earlier, but that was far under the kind of NICE threshold. We couldn't actually do the same in the time period, because this study time period is quite tight for the pneumococcal ads. It's a bit longer to calculate this. But we actually found that the rate, the kind of impact was more high for the pneumococcal vaccine, which I think is interesting given what we found is that there's far greater lack of awareness of the pneumococcal vaccine compared to the flu. So we had greater booking links and at a lower cost. And again, is it that because uptake is lower among deprived communities, lesser known? These are probably factors there. And so if you look at the cost per vaccine booking click, you can see that overall is about £35.50. For the flu ads targeted older adults, it's about £45, and those targeted, the pneumococcal ads targeted older adults is £12.50. So significantly cheaper than everything else. So that's interesting. Now going into our key question, is it better to target older adults directly or to target the younger generations? And at the outset, the key finding is actually better to target older adults audiences directly. So we saw far greater engagement and booking links from the ads that kind of went to older adults initially. And interestingly, we actually saw more shares and saves among ads targeted at those generations as well, which was something that kind of contradicted what we were thinking initially based on the initial evidence of kind of sharing engagement. And the cost per booking links were evidently then a lot cheaper for older audiences and younger audiences. But there is a big but, and I think there is an issue here that we couldn't track all the impact among younger audiences. So firstly, what we saw is that younger audiences are actually more likely to click onto that landing page, so to click on those ads and go to the landing page than older audiences. But once they're on the landing page, and you can see that in this graph on the right, they're actually less likely to act and share the ads or kind of do something with it. So we weren't seeing much evidence of kind of, actions on that page. What could be what could be the reason for this? Of course, it might be that page didn't resonate with those audiences, and maybe we could be doing more there. But also, there is some evidence that actually maybe they didn't act directly. They didn't. They might have actually spoken to people, spoken to their loved ones offline, and so the survey that we used on that page actually indicated there's some evidence that that's what many young people were doing. They were thinking about it. They were planning to have conversations, but they hadn't kind of shared it yet. We were seeing that young audiences were visiting the landing pages more times than they saw the ad. So they're clearly going back to the landing page. They're quite interested in it. So we just don't have the evidence of what they did. But I think it is worth still exploring that question. The cost of reaching young audiences on social media is actually far cheaper than reaching older audiences because they're more likely to use social media. So is it worth still exploring that question further? And a final point is we've kind of bringing some information from the survey, but also comment analysis. We've got hundreds of comments on these ads, which were quite interesting from a research perspective to see kind of what people were saying. And as mentioned, we're seeing that many follow-up actions weren't immediate. This is among older and younger audiences. So, for instance, in the survey, about 60% of older pneumococcal respondents said they're planning to or thinking about getting the jab. So clearly our results might have been even more cost-effective. We could take into account that. It would likely require working with maybe the NHS if we were doing that to track kind of what was happening. We also saw that some people didn't book the vaccine even after seeing the ads, and they'd kind of told us why. And kind of some of the key issues that came out were GP-related barriers, or kind of health practice-related barriers. So that lack of recommendation from their GP, they still wanted to have that. They're still worried without that. Struggling to book via GP, so access there, especially for the pneumococcal vaccine, which in the UK isn't offered in pharmacies, generally speaking. So that clearly came out as a top point. You can see that from that Loch Ness quote, which I found quite funny. We also saw, interestingly, that most of the survey responses were actually quite positive and reactions. So we had very positive reactions, like love buttons on the kind of Facebook post, for instance. But the ad comments were largely negative. And what we saw is lots of really strong anti-vax sentiment coming out. You can see a quote at the bottom showing that. But then also people responding with positive, this vaccine actually was really good. I haven't had any negative effects. So we had this kind of largely negative reactions with positive feedback. And, one thing that we're kind of wondering, did that actually increase engagement for our ads? And the social media company were wondering as well, were we actually attracting those kind of undecided people to then kind of click on the ads? And it's something worth exploring potentially. And it's definitely worth noting it was the undecided users, I think, that we were kind of persuading to book, not the staunch anti-vaxxers. I think they were writing comments, but probably not the ones that were clicking. Now, as mentioned earlier, there are a small group, and those kind of undecided, the people who lack that knowledge, are potentially the ones that there's a low-hanging fruit, and I think that's who we were influencing. So kind of key recommendations based on this. So firstly, we were saying health policymakers should build the evidence base and scale up findings. Really what we're seeing is that there is real potential for social media to influence the uptake of routine vaccinations among older adults in deprived areas, so to reduce health inequalities and to influence older adults. And there were kind of assumptions that were kind of, interestingly, we saw in the data that this seems to be effective. It seems to be the case that it's likely that it's going to be more effective with the pneumococcal and potentially shingles vaccine. We need more evidence. Again, we couldn't test cost effectiveness, but I think the evidence suggests that these are where we need to focus more. There's really low-hanging fruit. And looking at France, I think there's potential in many other countries as well. Secondly, we need to measure the impact and cost effectiveness of future social health campaigns. We found it quite difficult to kind of benchmark our campaign with other campaigns just because of the lack of benchmarks out there. I think it would be quite interesting for NICE, they do an excellent job already on guidance, but maybe making it easier to test for cost effectiveness. We know it probably would be different for marginalised groups who are more likely to get hospitalised if they actually are not vaccinated relative to other people. So, make that easier to get those benchmarks in place. So I think that's really important going forward so we can learn from best practice. Secondly, address that kind of knowledge and accessibility barriers to vaccination. They really came out, those who aren't kind of expressing really strong anti-vax sentiments. There's a really big group of low-hanging fruit there, I think. So we think it's important to offer the NHS pneumococcal vaccine community pharmacies, and I think it's great what we're seeing in other countries right now. I think we could use COVID as opportunity for this. Secondly, ensure that all GP practices send reminders. A lot of people wanted that confirmation from their GP, and constantly consistently discuss the pneumococcal vaccination with eligible patients. We don't see that, and we think there was kind of geographical differences in our data. I haven't had a chance to go through this, but that was quite interesting. I think that needs to be more consistent. And finally, a key issue is that booking the vaccine. That's an access issue, just making it easy as possible to book the vaccine. We did it with COVID. Why can't we do it with these vaccines? Because that came up in so many comments. If you can look at that quote at the bottom. This site is pointless if you just get bumped to a GP site where it's not possible to book an appointment. How can we make it easy for people to do it? We've done it for COVID. We can do it for other vaccines. Final kind of recommendations is exploring ways to use social media data for public good. And I'll just quickly mention that point about we really were interested in kind of the point around ethnic minorities as well as people from living in deprived areas. But it's very difficult, and for very good reasons actually, to target ads to people from different ethnic backgrounds and to test, kind of get the data on, booking clicks and things like that based on differences in ethnicity. But is there scope to potentially mitigate those risks, the acute risks of having that data public, but using that for the public good in terms of thinking about health campaigns going forward? So, should we have more conversations about how that data can be shared with health systems and governments in a very kind of, way to mitigate the potential risks? And finally, testing and answer questions from our study. So, we really think it is important to explore whether using social media to engage younger family members can be cost effective. To kind of build on that, there is some evidence that it might be, but we need to do more of that and work with governments, I think, to do that. And maybe explore that kind of comments point, do those, keeping those anti-vax comments, could they actually be driving engagement and supporting future campaigns? That's something worth noting. And I finally want to note that the Vaccine Confidence Fund are kind of thinking about, following on from this and doing further work. So I'd be really interested in your ideas of what we could be doing going forward. I think there's a really exciting potential to continue to use social media for this area. Thank you.
Well, many thanks indeed. Many years ago, we did an analysis of the sort of cost effectiveness of different ways of doing communication. And we were able to look at the cost per percentage point of awareness. And you got pretty good impact from television, but it was very expensive. The cheapest, best value for money, was putting the messages on pharmacy bags. Because, you go to the pharmacy, you pick up your prescription, and it comes in a white paper bag, and if you print the messaging on there, it's really cheap. And of course, you're targeting at the very people that you want to get the message to. And so, looking at some of your results, which I think are very, very important about the cost of getting some of these messages through, was really good stuff. The one thing I would always caution is that there's a huge gulf between raising awareness and changing behavior. And I think you are able to start to get some better insights into changing behavior by not just looking to see how much people were taking from information, but what they're actually doing afterwards once they had got that. So I think that there's an important bit in there about not just raising awareness, but changing behavior. And I hope that you'll continue to push on that aspect. 1 and then 2, and then I think we've got to keep moving.
Yeah.
Pete.
Thanks so much, Sophia. When I saw that it was social media, one of my first thoughts was, oh my goodness, how on earth are you going to deal with some of the anti-vax sentiments going to come up on some of those comments? Do you bother to engage with any of those comments, or you just leave it open for other people to sort of respond? Because I know that for myself, being part of the COVID-19 actuarial research group, we have a Twitter account, and we just made a philosophy not to respond in the end, because for every bit of robust evidence we presented, they plucked something quite shall we say, almost imaginary out of the air, which created an awful lot of interest and support. And we found it better to just don't get involved with that kind of rhetoric.
Yeah, no, that's a really interesting question. Actually, we decided not to, just because we didn't want to influence the study. If we, some comments, essentially there's hundreds and hundreds of comments, so I think it would have taken us all December to answer them, but also that could influence the study because we had so many different ads. So I think that was quite interesting for us, and we deleted those that were really, that shouldn't be there, that were kind of, just simply very, very rude, extremely rude. But generally it was just quite interesting to see what came in place. And actually there were responses, and that came from other people, and that was quite interesting. So we had, generally nearly every negative comment did see some positive responses, in which, so I think that was that dialogue between users that was interesting that we saw. It wasn't just the anti-vax comments alone. No.
I was really interested in you talking about younger people. We did a project a few years ago where we, as you probably know, in much of Europe, older women have terrible trouble getting their osteoporosis diagnosed. So the way governments reduce the cost of treating osteoporosis is by refusing to diagnose it. So we tried to mobilize the children of older women to get their mothers into the doctor and to be quite demanding and forceful, which for older patients in many European countries is culturally a bit uncomfortable. So we thought, well, if we could get the daughters. That didn't work terribly well, but the granddaughters worked brilliantly. So we'd clearly misunderstood the mother-daughter dynamic. The mother didn't want to be told, do this by the daughter, but didn't mind at all being pestered by the granddaughter. And so I think that is actually a really fascinating possibility.
That's really interesting, actually, because actually with ours we were seeing, and this also came out in the qual, that it was all of our younger audiences, it was kind of 30 to 40 group that seemed more likely to pass on the messages. So they were more likely to want to do it, maybe because they were more aware of kind of their parent mortality and things like that. And we did see that on social media. We think from this, we couldn't see it tracking on social media, but we could track it on the survey. But that's interesting whether the impact actually would have been greater from the granddaughter approach. So I think, it's definitely, that's a really interesting point. And the study from China was about that grandparents' relationships that kind of helped influence, this decision. So that's really interesting.
We once did work that asked, do you take advice from do you seek advice from family and friends? The answer was yes. Do you follow advice from family and friends? And the answer was no. Okay, let's move on. Patrick, I think you're next.
This is the issue, sitting furthest away from the lectern there. You have to basically walk a mile. Cool, thank you very much. Okay, so this morning I presented on Japan. Now we're heading over a bit closer to home, to Europe, to discuss this report, which I'm now shamelessly promoting, which is available over there, on increasing uptake in patients with chronic conditions in Europe. But I think David and Jean-Pierre briefly spoke about this towards the end of the first session this morning. So it's really good kind of to talk about this now. So this report is called Hitting New Heights. We published this in February of this year, and this was a joint research piece between CLCI and ILC. And essentially what we did is last October we organised a working lunch with a group of experts to discuss routine vaccination in those with underlying health conditions across the continent. So we had an MEP, we had chief executives from patient charities, and people from health policy and advocacy. We all got around a table and we discussed the issues and the challenges and the barriers, but also the opportunities with routine vaccination in those with underlying health conditions. And some of the key findings we also did from our research in this piece was that less than half of adults with an underlying health condition are vaccinated against flu across the EU and EEA, and very sort of, because we've mentioned there's not a lot of data on it, but the data that we do have from around the 2010s suggest that only between 20 and 30% of those have been covered with pneumococcal vaccination. But also as well, that I think we've discussed today and yesterday, there is clear opportunity to incentivize better uptake and to really promote vaccination in light of COVID-19, and looking at the successes from the COVID-19 vaccination rollout and program, and what we can do to increase awareness and improve uptake. So as I mentioned, routine recommended vaccination uptake in Europeans with chronic conditions is suboptimal. Looking at OECD data from 2014, around 1 in 4 Europeans aged 15 to 64 have 2 or more chronic conditions. Most of the countries recommend that these people should get the flu vaccine and the pneumococcal vaccination. But only around 45% of those people received the flu vaccine in 2018, and as I've said, coverage for pneumococcal was between 20 and 30%. And this is concerning, and why is that? Well, we know that people with underlying health conditions, as David mentioned earlier, are 10 times more likely to die from the flu than those who do not have an underlying health condition, and are more susceptible to the severe disease posed by vaccine-preventable diseases like flu and pneumococcal, to name a few. So understanding these barriers is really, really important in order to increase and encourage uptake and to prevent severe disease in those with underlying health conditions. So just looking at the screen here, as you can see, that OECD data suggesting that around 25% on average across Europe of people aged 15 to 64 have 2 or more chronic conditions. And then when we look at the chart on the right of the screen, we can see that of the member states across the EU, EEA in the 2017-18 flu season that recommended the flu vaccination for people with these conditions. So you can see that try and do my maths here, the top 5, I need to get my eyes tested. The top 5 there are for chronic cardiovascular, chronic kidney disease, CRD, immunosuppression, and metabolic disorders. All countries recommended that those groups should get the flu vaccine. But when it comes to other underlying health conditions such as people with HIV/AIDS, chronic liver disease, morbid obesity, or long-term aspirin use, there is divergence and there is a slight differentiation on recommendations in some EU, EEA countries. So through our discussions with our experts and talking to people in this field, we looked at the barriers, and I can say that there are 4 that we kind of came up with, and we discussed these somewhat so far during this conference, but we found that communication issues, a lack of political cohesion, structural barriers, and personal reluctance are kind of the 4 key things that will stop people with underlying health conditions from getting vaccinated or prevent them from accessing vaccination that's recommended to them. So communication issues, Sophia highlighted just now, things like misinformation and fake news can damage confidence, or at least dissuade people from wanting to get a vaccine. But there's also a lack of communication that is targeted specifically at people with underlying health conditions. And a lack of cohesion as well. There's differences in policies, as we saw on the previous slide. Not all people are recommended the vaccines. There's differences in cultural attitudes and in health infrastructure across Europe. But importantly as well, as something that we will keep saying, there's a lack of data and data sharing and spending. That makes it harder to achieve consistent levels of routine vaccination. Thirdly, I think there's structural barriers. So inaccessibility, cost, and poor engagement with healthcare professionals can all have an impact on uptake. That's at least what we found in our discussions. And finally, personal reluctance, so things to do with vaccine hesitancy, efficacy concerns, complacency, and mistrust in vaccination can also, lead to some people with chronic conditions choosing not to get vaccinated. So firstly, when we look at the communication issues, these are some of the quotes that we had from our lunch and from our discussion with the people around the table. We found that communication is key to encouraging and incentivizing somebody with an underlying health condition in Europe to get vaccinated. So a lot of this, if you look here on the screen, these quotes kind of point to the fact that before COVID, there wasn't really a lot of information. Now we have more information and we have more awareness, but it's still not specific enough. So it has to be transparent, it has to be high quality, data driven. That's kind of, almost in layman's terms, that it can be relatable to people with underlying health conditions and encourage them to get vaccinated. But at the moment, that's missing. It's not there. It's not. clinical enough to suggest to people why it's important to get vaccinated if they're more at risk. Secondly, we also spoke on the lack of cohesion, and interestingly, this is from MEP Tomislav Sokol of Croatia, who as a European policymaker himself, says he thinks that Europe lacks in a systematic approach because they have ad hoc solutions to solve a problem that emerges. But when push comes to shove, I think things like COVID-19 has somewhat, to most extent, helped Europe to come together and kind of try and find a solution, and it's had a good vaccine rollout. But he also spoke about as well that, you know, nowadays everybody is talking about vaccination in terms of their human rights, their bodies. It's an individual choice, and nobody really thinks about the collective responsibility of vaccination. And the chart on the right here is from May, so last month. And whilst this is in the general population, not in clinical risk groups, it shows that across the EU and EEA, uptake has been relatively good, very strong in Western Europe. But when it comes to countries in Eastern Europe like Poland, Romania, and Bulgaria, the uptake is lower, and there is that divide between East and West when it comes to vaccination. So that lack of cohesion means that uptake isn't always strong across the continent. And also as well, a lack of spending. This is a lovely quote here, which really elaborates on, you know, that less than 0.5% on average is spent across the EU on vaccination programs. And I think it's 77% of EU countries spend less than 0.5% on their vaccination programs. And that doesn't just include vaccination itself, that goes everything within the programs that comes with it. And this surely is not enough when about 20 infectious diseases can be prevented with vaccination. So sustainable immunization financing is critically needed. And again, this covers all vaccination programs. It's not specifically relating to those with chronic conditions, but the data from 2015 to 2019 suggests that, as I say, 77% of European countries spend less than 0.5%. And the only country to spend over 2.5% was Luxembourg. As you can see, the tiny dark blue dot in the middle of the chart there. My eyes are working okay. So yeah, really, that's the one country that has spent more on immunisation than others. Thirdly, we saw structural barriers in our conversations as well. So again, up until COVID-19, where there have been changes perhaps to things like the flu vaccination in those with chronic conditions in places like Belgium. Prior to the pandemic, you might have had to go to the pharmacy, to then go back to the doctor, to then go back to the pharmacy, so forth and so on, in order to get your prescription to then be administered the vaccination. And also things like cost as well as stigma might be an issue, but also, again, that organisational aspects of having to go out somewhere to get a vaccination and not having clear access to it. But interestingly, that quote at the bottom of the screen was from an Italian person who said that when it comes to COVID-19 vaccination in some patients with chronic conditions, doctors were saying, don't get the vaccine because they didn't trust it. And if that person is supposed to be of, you know, medical knowledge and expertise, and they're the person telling you don't get it, then what does that really mean for future vaccine programs, or what does that really mean for the patient if they're the one relaying that information? So quite a dangerous sort of a thing there if you've got somebody from medical power telling you don't get the vaccine. I think complacency is also a big issue that we came across. I think people with chronic conditions, as you can see here on screen, found out that people with respiratory conditions, for example, they don't always think that flu is going to be that dangerous. It's not going to have an impact on them, or that flu is not seen as a major public health issue, even though it kills between 40 and 70,000 people across Europe each year. And then you see on the graph on the right here, so this is from a finding from Zucks and Müller in 2005, which says that people with underlying health conditions across 5 European countries, they were asked, why aren't you vaccinated against the flu? And 2 in 5 of those people said they don't think they're very likely to catch it. And then 1 in 5 are thinking it's not that serious. So yeah, and again there as well, nearly over a quarter of people said that the doctors never recommended it to them. So clearly there's communication issues. There's also a complacency issue here, and just a lack of understanding about the impact that it can have on people with underlying health conditions. So hesitancy, efficacy concerns, and mistrust was also something that came up. So we're talking, somebody interestingly said about vaccination always comes with a risk, but it's always a very low risk. And I think in the context of COVID-19, you can see those severely adverse but very rare effects from some of the vaccines that were rolled out. The people, I think, are aware of those and they are concerned by those, so they might choose not to get vaccinated because of it. And also somebody from Romania said that sometimes when the politicians are involved, it's not very good because people don't trust them. So the way it's communicated from certain people means they might be less likely to believe it. And another interesting study from Lubé in 2015 here, they interviewed immunodeficient patients in France. And while 73% said they had favourable or very favourable opinions of vaccines, 27% said they had rather not favourable or not favourable opinions of vaccination. This was for flu and pneumococcal. And if you break down that 27%, 24% said it was because of arguments on the internet. Then 23% said differing opinions from people around them. And then 21% of those people said that it was personal negative experiences with vaccination. So clearly there is a lot of hesitancy and concern around vaccinations in people with underlying health conditions. So despite all this doom and gloom, what are the opportunities to improve vaccination uptake? Well, for us, I think it's improving the information. It's increasing that engagement with healthcare professionals and increasing education. And finally, enhancing access. So again, going back to data, we need better data sharing across the EU. We need to create specific information about vaccination that is tailored to the individual and therefore create more effective communication. We also need to work at a local level to improve awareness and education amongst patients, as well as ensuring that there's better engagement between some healthcare professionals on vaccination. And finally, I think we need to enhance access. So removing the structural barriers, such as cost, physical inaccessibility, and that feeling of mistrust between healthcare professionals and public institutions in order to try and incentivize better uptake. So firstly, improving data. So we see here that the ECDC, for example, has found it difficult to mandate states to provide data, but with COVID-19, things have changed. You know, Europe has started to be more aware of the need to share data, and that graph with in green earlier with the map of Europe was from the ECDC's COVID-19 vaccine tracker, which is a very good tool and something that really should be used beyond the pandemic to track other vaccination programs like flu and pneumococcal disease. But also as well, it's about really trying to engage in people and reaffirm that message that, you know, getting a vaccine as somebody who's at risk is important because you'll be protecting yourself as well as your community and those other people with chronic conditions. You're doing your part. So it's really important, the kind of message that we want to relate to people. Secondly, increasing engagement and education. If we want to build trust, it is essential to have clear and univocal communication at all levels. And I think what we need to do is work locally with local activists and local people who are using these health systems to really be connecting. So working from the grassroots, the bottom up, to try and really reaffirm the need to get vaccinated, and working with local delivery partners and really increasing engagement and education is very important. And finally, enhancing access. So we spoke a bit about pay. So some people might argue that payment is a barrier. So not everyone is able to pay. This is a social aspect that we need to fix. And as you can see on the chart on the right here, again in the 2017-18 flu season, cost incursion either through national insurance scheme or out-of-pocket costs was for about 30% of countries across Europe. So potentially removing that barrier, we may see better uptake. But just on a final quote here, so this is actually from another report that preceded Hitting New Heights, and it focused on people with underlying health conditions in the UK. So this was called Reducing the Risk. And this is a really nice quote, I think, from a patient with COPD, who said it's about having the ease of access, just to either go to your GP or your pharmacy and having a vaccine with ease. The last time I was there, the doctor did it and said, "Shall we do your flu jab?" And I was like, "Oh yeah, go on then." And of course, I got the reminder, but I'd already had it. So the idea that really if we engage with healthcare professionals and ensure that they are the ones who are reminding patients to get vaccinated, that access is better. It makes it far more accessible from a sort of geographical point of view and physical point of view. People who are already there getting vaccinated on the spot, this is really important. So yeah, I think that is it. That is all I have to say. But yeah, do get in touch. Thank you very much.
Patrick, thank you. I think the access point issue is really important. The more severe your at-risk condition, the less likely you are to get your care from your primary care provider, the more likely you are to get it from secondary and tertiary care providers who are not set up to give you vaccines. And so the more at risk you are, the less well you're served to be protected. One question, all right, take two, but we are really heading for timing problems. It's got to be so quick.
Okay. Okay. Number one, I couldn't agree more with your point around hospitals. I think you have a pre-selected population in CKD clinics, heart failure clinics. Why are we not giving a vaccine to everybody that goes to those clinics in the clinic? Number two, and I appreciate many of the people are over 65, so it may be less relevant, but what's the role of employers in the private sector in meeting people where they are to deliver vaccination in the workplace? Do you think that has...
Come back to that one. So private sector provision. Eke.
Yeah, thank you. It's along the lines of the first question, because sometimes specialists have DRGs codes which they can get reimbursed, but vaccines are not covered. Was that discussed, how that can be changed? Because, I mean, if the national system anyway reimburses, why can it not be on the list of specialists, right? Yeah. Or hospitals?
Yeah, very quickly to come back to that. Yeah, so yeah, in the Reducing the Risk report, we spoke about that more in the UK context, and we actually found that patients, say, we're on dialysis or with chronic kidney disease, they find it much easier if somewhere like a hospital where they're getting that treatment, if they can just receive the vaccine on the spot whilst they're having their dialysis treatment, that's going to be far more accessible for them. I'm not too sure about the payments.
That's not UK specific. It's in some European countries that you cannot, basically, you don't have a DRG code to get reimbursed as a specialist if you give the vaccine, which may block that.
Yeah, no. Yeah, I'm not too sure on payments like that, but I did speak to Dr. George Cassianos, who's very clued up on that, so probably speak to him. Cause
I think there's a more fundamental problem, and it's not. And the fundamental problem is that hospitals are by and large not set up to provide the routine vaccinations for some of the patients.
Mm-hmm.
Right, Patrick, great, thank you, but we have got an awful lot more to get through. Chopin, please.
I have only one slide, which will go relatively quickly. So COVID-19 indeed has shown the true value of adult vaccination for the first time, and the vulnerability of all the adults to infectious diseases due to age-related immune decline in their immune system, as well as the existing comorbidities. And when you look at the vaccine coverage rates in adults across different vaccine preventable diseases, you can see that in countries from different parts of the world, the uptake rates remain suboptimal and requires lots of work for further improvement. So I wanted to share to use this opportunity and share the high-level findings of the research work we did at GSK to identify interventions which have an impact on increasing uptake of adult vaccination rates. And I would share just a few of them so that I wouldn't take lots of time. So what we did is we took like 12 countries from different parts of the world and looked at coverage rates. And I should admit it was hard to get the data because as most of the people mentioned, there was no proper tracking systems or immunization registries which could give this up-to-date data. And the data was actually either outdated, and there was also, when you look at the age groups, it wasn't that much consistent. Like some countries, of course, depending on the recommendations, covered the rates for adults 50 plus, and some countries covered for rates for adults 65 plus years old. So coming back to the interventions I have mentioned. So first of the interventions I wanted to mention is, and which was also highlighted by a couple of speakers today, it's having immunization registries in countries, whether it's national or regional level, and especially if the systems have track and recall kind of systems. Those countries had a kind of higher adult immunization coverage rates than the countries which didn't have any sort of immunization kind of registries, and the tracking was based on the individual cards, like to put that you have got a certain vaccine, but not in the shared kind of registry. And the second intervention, again, as was highlighted, I think, by most of the speakers, it's expanded points of vaccination. So as number of research and surveys among all the adults shows that the access to vaccination, the healthcare system is seen by all the adults as cumbersome, and they find getting vaccination from traditional vaccinators difficult. That's why when you compare again across 12 countries, the availability of alternative points of vaccination, like pharmacy-based vaccination or vaccination delivered by nurses, you can see that the coverage rates are actually higher than those countries where such kind of alternative points of vaccination do not exist. And the third point is a really interesting area, which I think requires further kind of research work to be done. It's the healthcare provider incentives. And these incentives could be the payment for dose administration, or it could be bonuses for meeting certain vaccination target. And then when you look, for example, countries like UK and South Korea, we know that there are some kind of healthcare professional incentives in place, and then the coverage rates are actually higher than those countries where such incentives do not exist. So I think it's interesting area for governments to look and explore the introduction. And the last area is actually, which is also tied with the incentives partially, it's the setting vaccination coverage targets. We know that for pediatric vaccination, there are in most of the countries, strict coverage targets exist, more than 90%. But when you look at the adult vaccines, there is a vaccination coverage target for flu vaccination, which is in most of the countries, which is 75%. And of course, we say that look at the flu vaccination targets and then coverage rates, and then you can see that not all the countries are achieving, but still, when you compare flu vaccination coverage target with other vaccine-preventable diseases such as pneumococcal, pneumonia, or shingles vaccination, you can see that the coverage rates for flu are a bit higher, much higher than other vaccine-preventable diseases. And I think this kind of leads us to the conclusion that actually setting such targets for healthcare by the government makes healthcare professionals to prioritize and really advocate vaccination to the target population. So these are 4 points I wanted to mention today, and we know that COVID-19 indeed offers good opportunities and have accelerated some of these interventions. Like we know that for COVID-19 vaccines, immunization registers were set up, and they had also recall and reminder options. And when you look at the vaccination coverage rates for COVID, we can see that it's much higher than other adult vaccines. And then also expanded points of vaccination were offered to deliver COVID-19 vaccination. And I think there is right now it's a really good time for us to advocate for the maintenance of these interventions and really use it for other adult vaccines, recognizing the value of adult vaccines and push the uptake rates higher. So that's what I wanted to mention today, and to save also some little bit of time.
Thank you. What we're going to do is take the questions afterwards for the next lot of speakers to try and catch up a bit of time. But we're not going to have a presentation from Gonzalo because he's suffering from a sore throat. So I've got to left my key prompt.
Thank you.
We are going to have a presentation from Lena Bader, and we're very grateful to her for stepping in to give Gonzalo's presentation. Okay.
Thank you so much. I hope you can hear me well. And we are very honored to be here as FIP. And on behalf of Gonzalo, I thank you so much for the invitation and the opportunity. Truly well-organized conference. And I'm watching from New York here and really enjoying all of the very informative presentations. I know that we're behind schedule, so I'll actually try and trim down some of what I want to share. And I'm very happy to provide the slides later for more info. So I'm just going to go ahead and start with the next slide, please. Very quickly, if you're not familiar with FIP, FIP stands for the International Pharmaceutical Federation. Founded in 1912, we are the global federation representing millions of pharmacists, pharmaceutical scientists, and pharmacy educators around the world. And I was very pleased to hear pharmacy being mentioned by a number of you as an important factor or enabler to prevention through aging. FIP is a non-governmental organization, and we've been in official relations with the WHO since 1948. Sorry, I just want to focus on the vision very quickly because it really is a commonality among most of the organizations here with us today. We envision a world where everyone benefits from access to safe, effective, quality, and affordable medicines and pharmaceutical care, and that includes, of course, vaccination. And our mission is to improve global health by advancing practice, science, and education of pharmacy. Next slide, thank you. So, maybe this is a very obvious question, but why community pharmacy? And we, of course, believe that this is an optimal structure and pathway that already exists within the health system. And there's a number of reasons why. So we are highly skilled, trained healthcare professionals, and I'm really referring to the entire pharmacy team here, not just pharmacists. We are very accessible. We are considered one of the most accessible healthcare professionals in many countries. Opening hours is another access factor. We have excellent logistics, cold chain management, support access to vaccines, for example, and other medicines. We have, through pharmacies and community, the spatial requirements for delivery of services with appropriate privacy and clinical adequacy. And we allowing pharmacy vaccination or pharmacy-based vaccination services definitely improves efficiency and increases vaccination rates and coverage. Next, please. We are able, in our position, to also identify high-risk patients based on their medication and other risk factors, identify individuals who are also vaccine hesitant and help educate them and help them build trust in vaccines. We can gain the public's trust and their acceptance. All of our practice is guided, of course, by nationally adopted standards and guidelines and evidence. And our role generally improves access to healthcare, also in rural and medically underserved areas. So really, in summary, pharmacies are increasingly a gateway to care with the provision of primary healthcare services primarily. Next, please. You'll see here data from FIP. This is the result of a global survey we conducted in 2016 across our members. Back then, 16 countries reported that they provide or deliver pharmacy-based vaccinations. And the next slide will show you the upgrade. If we go to the next slide, please. One before, there we go. 2020, you'll see that that number has increased to 36. And not surprisingly, the third slide, please. We'll see that in 2025, based on these projections, based on these numbers and data we have, we project that this will increase to 52, possibly more. And the pandemic has, of course, accelerated this increased rate. Next, please. I just wanted to talk us through very briefly about our toolkit. So building vaccine confidence and communicating vaccine value, a toolkit for pharmacists. This details approaches for communicating and eliciting change and addressing misinformation directly with individuals. In addition, it also provides examples of successful immunization campaigns that have been delivered, guidance and advice for different types of vaccines, such as influenza, shingles, is also provided. If we go to the next slide, please. You'll see on there how the toolkit aims to support development in vaccine hesitancy and complacency as well. As the arrow indicates, this toolkit focuses on different aspects of vaccine hesitancy, starting from understanding the reasons for vaccine hesitancy and how to tackle that. And it follows through practical tips and approaches to address hesitant individuals. Information as well on pharmacy-led campaigns and how they can be delivered, and specific vaccine information that could be relevant to pharmacists specifically. Some practical tools are also included, such as 5 conversation examples addressing different patient profiles, more examples and links to campaigns from around the world, and specific vaccine information for different vaccines that countries can adopt and adapt to their local context. And the next and final slide actually just really summarizes here the 4 broad themes that can support pharmacists' roles in increasing vaccine uptake. That includes, of course, adults and all other populations. So 4 main themes include regulation and policy development, and you'll see in the yellow boxes some breakdown of these. I won't go through them, but you can have a look. Also, stakeholder engagement, acceptance, and recognition is crucial in this. Logistics support for pharmacy-based vaccination services is, of course, important to ensure access to vaccinations themselves. And finally, education and training support for pharmacists to ensure that they are prepared to deliver vaccination services to their patients. I'm going to pause here and thank you so much. And maybe the next slide just direct you to feel free to visit our website, prevention.fip.org, that really sums up all of our vaccination work and all we do, including prevention for all diseases as well, and for all age groups. Thank you so much.
Lena, thank you for a great presentation. While I've got you, just in case it's going to be difficult for you to stay on later on, but while I've got you, one thing that you didn't mention and that has always worried me about pharmacy provision of immunization is how to get the information back from the pharmacy, both to the primary care provider who sort of owns the patient, but also to the government system that is monitoring the performance. How do you see that working?
Absolutely, David. That's such a good point. And I think the issue here is how this varies across countries. And this requires a systems approach, and it really relies on the health system. So I think that we do have different country examples of this. Some countries have better integrated records between primary healthcare, secondary healthcare, etc. Some less adequate, and they also have to work with that. And I think the pandemic maybe has provided us with some lessons of how we can centralize some of this information. The COVID vaccine, maybe using some of those lessons to simplify record keeping could be used for other vaccination services as well.
Okay, thank you very much indeed for a great presentation. Right, we're sort of moving quite nicely. Arunima, please, on I think the last, and then we'll have a summing up from Catherine.
All right. Great to be up in front of you all again today. And so my session is essentially looking at how can we reach those who are harder to reach groups in society. And I'm really excited to be talking about this piece of research that I'm currently undertaking, which is looking at how we can reach marginalized and underserved groups in terms of adult pneumococcal vaccine uptake. Essentially, it's a qualitative piece of research, and we're speaking to 42 experts in public health and immunization and organizations that work directly with marginalized groups. And our research covers the following countries, so quite a lot in there. And what I should say is these are interim findings, so we haven't spoken to everybody yet, but I think there's still lots that can be learned. And we sort of have three research objectives to understand what inequalities exist in adult pneumococcal vaccine uptake and why do these exist. Understanding country approaches to address barriers and improve the vaccine uptake in marginalized groups. So what is going on at the national level, and identifying solutions to address these barriers, specifically drawing on examples of what works and what still needs to happen. So lots of content, hopefully, when we finally publish our report, which will be later on in the year. So why does this matter? I mean, if we all know why it matters. The vaccines are one of the most important and effective forms of primary prevention. And in an aging world, investing in vaccination can significantly improve health outcomes. But what we're seeing is that across the countries that we've studied, governments are still missing the mark, and we're not investing enough in routine adult immunization. This specific piece of research can obviously give us more insight into how can we increase uptake across the board, and especially for those who are least likely to interact with healthcare systems. And it can also give us some useful insights to health inequalities more generally, those arising from other health conditions as well. So what do we know so far? So globally, in the last 2 decades, we've seen deaths from pneumonia among older adults aged 70 and over increase by 60%. And studies also suggest that only 29% of adults in Europe are aware it is possible to be vaccinated against pneumonia, and only 16 of those at higher risk have been vaccinated. And I think this has been a common point of conversation so far in the presentations that we've had. What we know is that in all countries studied, the pneumococcal vaccine is recommended for older adults. So, there's at least that there, but there's still much more that we need to do to address inequalities. A significant theme, however, is that the data on inequalities and uptake is limited, and little is really being done to improve uptake rates. Of the countries that we're focused on, the US probably has the most significant literature on inequalities in uptake, and what they found is inequalities based on education level, whether someone's from an ethnic minority background. The starkest differences relate to income. So there's a 20% percentage point difference in uptake rates between the highest and lowest income deciles. Probably not surprising, given that individuals have to pay for the vaccine in the country. Other countries have focused specifically on indigenous groups, so Australia and Canada in particular have focused on that. But in Europe, there is still very little on inequalities and uptake, and I'll speak a bit more about what people have said as to why that is the case. So what have we found so far? So what do we know about the inequalities in uptake? Like I said, most of the people that I spoke to said that, we really don't know what inequalities exist, but we can probably make some estimates by looking at flu and the pandemic as well as also wider inequalities in health to give us an indication as to whether there might be inequalities for the adult pneumococcal vaccine uptake. So the key groups at risk were unsurprisingly ethnic minorities, and again, COVID has demonstrated this, particularly in Europe. People mentioned migrants being at particular risk of low uptake, also low income as well. This was particularly a point stressed by our US respondents. Those with a proclivity to hold conservative political attitudes. This was noted by people from Germany, where they found that a stark divide between West and East Germany in uptake rates, and also as well in the US. These can be sort of demarcated by along geographical lines as well. indigenous communities, again here, Australia and Canada, we're most likely to highlight these groups, as well as those living in areas with poor healthcare infrastructure and or access. So this interesting point about urban-rural, so we had countries like Australia and Canada talk about rural communities being particularly at risk of low uptake. However, in Europe, the conversation went slightly differently. In fact, in some communities, they found that rural areas were better equipped to deal with immunization because everyone was able to access their health facilities in one place, and everything was quite easily, people could easily access that. So interesting that we can't just say blanket statement that rural communities are less likely to have vaccine uptake. We actually have to understand this at the local level. So yeah, understanding that is really important. Oh yeah, I also wanted to mention something quickly on migrants in Germany, which was, I thought, quite interesting. During the COVID pandemic, but also when it comes to routine immunization, they found that the Turkish population there, specifically first-generation who are now older women, were less likely to receive a vaccination. And this is particularly because of language barriers, that they live alone. And so really accessing that group has become quite difficult, and engaging in that group has been something of, I guess, greater importance now given COVID, but they're still struggling in terms of understanding how they can actually reach that population group. One thing I wanted to highlight was that there's a number of different barriers when it comes to engaging marginalized and undeserved populations. But what's quite interesting is a lot of these have to do with the structural and system barriers. Now, this affects the whole entire adult population, not just marginalized groups. But of course, this will have an impact on these groups as well. So it's interesting to see that actually there's a lot that we need to be doing really at the basic level to improve uptake of adult pneumococcal vaccination. So the first thing is that there's no concerted effort by policymakers to educate the public and healthcare professionals as well on the importance of the pneumococcal vaccine. So there's no public health outreach, there's no campaigns, there's no call and recall, which was mentioned previously, and this is unlike the flu vaccine. So without having this infrastructure in place, people are unaware of the vaccine, they're unaware that they could be eligible for the vaccine. So there's this clear communication issue here, and without having this, it's unlikely that people are ever going to go in and actually ask for the vaccine. There's also little knowledge of where to get the vaccine. So in Canada, for instance, in some provinces it is available in pharmacies, but there's a concern that few know about this. There's also lack of awareness on the importance of the pneumococcal vaccine on behalf of healthcare professionals, which also contributes to low uptake. And there's a lot of reasons for this, but I'll just give you one example. So in the UK, GPs are not incentivized as much as they are with the flu vaccine, so this is also an issue. They also have in each GP surgery an immunization lead, and they keep up with reminders and make sure that people who are due the vaccine know about this. However, the lead is not necessarily an expert in immunization and vaccination, so they could just be a member of staff. So they really need to be supported by a clinician, and this is currently not happening. So there's a missed opportunity here to actually have a healthcare professional who understands and recognizes the value of routine immunization. So we also have an issue here with unclear adult pneumococcal vaccine recommendations and changes to the recommendations. So respondents from both the US and Australia mentioned that recent changes to the adult pneumococcal recommendation, as well as ambiguity in the recommendation itself, means that healthcare professionals aren't equipped to provide patients with that right information. And whether they should receive the vaccine. So in the US, the CDC recommends that all older adults get the 20-valent pneumococcal conjugate vaccine or the 15-valent plus the 23-valent pneumococcal polysaccharide vaccine, but they don't give any further information about which one that they recommend. Of course, this is to ensure that they don't favor one vaccine manufacturer over the other, but what this means is that a lot of the work rests on the individual to make that decision as to which vaccine that they should get. And actually, we were talking yesterday about this idea, this illusion of choice, and often the case here is while people it might seem like they have choice, it really just boils down to often what the providers have in stock. So this could clearly be a barrier for people, but we need to think a little bit more about how we're actually getting that information out. In the UK, we also found that low pneumococcal uptake was partly the fault of the JCVI, as in the past they've taken the decision to stop offering the pneumococcal vaccine, and so this could lead to sort of miscommunications, particularly from healthcare professionals in the fact that they're receiving mixed messaging. So the value of vaccination, for pneumococcal vaccination, is certainly of question there. And there's also ambiguity in how often people should receive the vaccine. So some have it every 5 years if they're at risk, but older adults only need it once. So this also makes implementation of pneumococcal programs more difficult. And it's also not clear to the public which one they may need, as the guidelines in many countries, like I said in the US, aren't written in a very accessible way. And another interesting point here is also that anyone over the age of 65 can get the pneumococcal vaccine at any age. So this, unlike flu, where it's annual and people know when they need to get it, this could also be driving low uptake as well. And finally, we also know that the system is not set up to improve uptake in the adult population. So we don't have adequate representation on national immunization advisory groups. So Canada's National Advisory Committee on Immunization, there's no one representing older adults. So this clearly needs to change. And there's no one expert on adult, experts on inequalities in uptake as well. There's not enough of healthcare professionals able to deliver the vaccine as well. So we should be really looking to specialists and what their role could be, particularly for those who are clinically at risk. And one of the other key points is that there's no KPIs in terms of key coverage rates to reach a specific population. So, for instance, Italy, although we're not studying them, they do have very clear recommendations through their life course and immunization program, but this is not the case across other countries. So not having those targets makes it very difficult for for countries to actually put in a plan, an implementation plan, and to actually measure how they're progressing against it. So and then the final point is also that where we do have performance indicators, they're often lower than for those for childhood immunization. So we also have to address this issue around parity of these targets. Great. So my next three barriers are more specific to those for marginalized groups. So one is a clear issue around lack of data. So, sorry. My bad.
We have to go.
Sorry. Okay. All right. So So one clear point is lack of data. Without having data on inequalities in uptake, we're flying blind. There's no way of us knowing which groups are particularly at risk, and there's no programs in place to actually. We can't have programs in place to actually implement that. There's also a lack of targeted messaging. So issues around language is a clear barrier, and this has affected a lot of groups during the pandemic. Particularly in European countries. So there's also a clear issue in terms of actually understanding, not just making sure that the information is available in lots of languages, but also how that language is communicated to engage these groups. And there's also clear issues in terms of cost of the vaccine, again, particularly for the US, but also when it comes to out-of-pocket charges, particularly for those in rural groups in certain countries, but also, again, in urban areas where people may have disabilities and aren't able to actually access the healthcare facilities for their vaccination. So I think I'll probably just end with this final slide, if that's okay, just in the interest of time. I'm happy to talk about this later on. But I think the key messages here is that very little is being done at the national and regional level to improve adult pneumococcal vaccine uptake. There are a few examples where there are targets in terms of reducing pneumonia infection, especially in places like the US. However, these targets, the data is still unavailable for a lot of these for a lot of the targets that they have, so there hasn't been a huge progress in terms of actually addressing this. Because we also don't have data, there's also the targeted approaches to reduce inequalities are virtually non-existent. Interestingly, only Indigenous communities are the ones that have national policies in place to improve their health, but that's because their health is particularly poor compared to the rest of the population. So, in other words, maybe these other groups just don't have as poorer health outcomes to actually warrant specific policy attention at the national level. Interestingly, most respondents highlighted local approaches to tackling inequalities, and there's loads of examples here, particularly around improving trust in marginalized groups. But the main point here is that these are really up to the goodwill of a few in local communities rather than any sort of systematic or regional approach to addressing inequalities. All right, well, I'm going to just end there. And yeah, if you have any other questions, I'm happy to answer them later.
Well, thank you so much for the presentation and also being generous in cutting it down a little bit. Catherine, reactions, please, and then I will very happily hand over to Daphne to chair the last session.
Okay, I will make it brief, and the missing points will be discussed during the lunch. So first, I will utilize mainly key points. Why are we engaged here? First, we saw demography, but it's not only demography and aging people. It's the fact that we have less births in our country and we have much less working force in the country. So the disequilibrium is increasing, and it's a major fact. The second important thing is we all want healthy aging. And so it is not only healthy aging, but letting those people entering this and staying in the social field. It's extremely important. When you utilize retirement, it's going to a monastery, and none of us are going to monasteries. We want to keep in the society. And the third point, I don't like too much inequalities, because quality or equality is a mathematical thing, and we are all humans, so I much better prefer equity. And I think equity is something we have to develop, and for me, vaccination programs are a pivot of this equity in every society. So now, what do we need? We certainly need more data and macro data on each country, but also at the European level. I am a European by essence. I think the more we are, the more strongest we are, and we have to work together. So I would suggest a position paper or white paper on the aging population and the place of vaccination. We need more surveillance, but surveillance not only on efficacy of vaccines, but also on safety of vaccines, because it's something very keen to people to be safe. I think also we need more data on the burden of those chronic diseases. The more you are aging, decade by decade, the more you increase your number of risk factors. We need advocacy, of course, but I let it to Daphne. This advocacy is not only for politics, it's also for all healthcare professionals and the public. And the way to engage in the three fields is totally different. The way you speak to politics is certainly not the way you speak to the public. When one of the questions raised, where do we start? I think it's a continuum. So speaking only on 65 and over is just putting those people in a special category. I don't like it this way.
So we need to have a lifelong perspective, starting very early in life, educating children at school about their health, the way to protect, the role of vaccination program, the boosters they will have later on, and so on. Otherwise, we are missing a point. At least I understand it like that. So I would suggest also a global perspective for all vaccines so far over 65. Because speaking of one vaccine or the other vaccines is to segment the attitude. So it's a sort of global package to speak about vaccination. Where and by whom we have spoken largely of all investment of healthcare professionals, including nurses, midwives, anyone has to go in the vaccination field with education, information, and communication. And how? I think it's a perception of the society, so we need to enter deeper this field. Several studies had been done during pandemics about the feeling of the society and the sociology of the society. But it has to be done also largely and check again during the next decades about the perception. Personally, I have no vaccines against anti-vax. On the contrary, I do really think that the percentage of hesitancy in a population, you just need to take time to listen to them and try to understand their concern and try to move around them. So the role of media societies is extremely important, and we are moving forward to strengthen the real facts. And for many and a long time, it was due to industry to make communication and information. And so this is totally dropped. And so there was a void where anti-vax, fake news, introduced themselves. So we have to create a very sound part with real information, reliable sites, given to healthcare professionals. I could give the example of Infovac France in my country that works very well, nearly 20 years now. And to finish, I would like to ask Professor Michel what he would think about a score dependency at several checkpoints of aging, and trying not to have only a static but also a dynamic point of view in order to promote some actions to prevent the decrease of the score. One of the mantra I have, aging is a reality, but it's not a fatality. And so you have to move forward also in this field. And as I am an aging lady, I'm very keen to speak about that. Do we need medical records? We have some, and we are improving, at least in the country, on the national level about global medical information, individual and collective information. Do we need registries? And the last, we have listened a lot this morning, and we need to enter action. Thank you.
While Daphne gets here, I'm just going to say thank you to all the speakers. Thank you to the people who've provided questions. It's been a really good session, well, two sessions today. We've covered a lot of ground and lots of good material to take away.
Okay, so the first thing I'm going to say is thank you to David for chairing so efficiently this morning. This is called the role of advocacy, this session, and it must now be pretty obvious to all of you sitting here exactly what the role of advocacy is, because we've heard an awful lot of ammunition here this morning. And I'm going to say that a plug for the Coalition for Life Course Immunization. We, in 2019, wrote our manifesto for the then newly elected European Parliament, and we have 7 steps to life course immunisation in Europe. And pretty much they summarise what has been said here this morning. So I'm really pleased that in 2019 we were actually thinking about these. So we have to have strong leadership. And Catherine has said it, we have to have strong leadership at every level, from the community leaders up to the politicians. We have to make vaccination a societal good. Once again, we've heard about people thinking about vaccines being just for me, but they're not. They are for society, and we all have to think about that. We have to mobilise our healthcare workers because they are trusted. We've heard that today completely. They are trusted people. We have to encourage innovative access. And we've already heard from Lena with regard to pharmacists. And I have to say, and maybe Jean-Pierre will agree with me like this, but when pharmacies came here in France to be able to give the vaccine, to give the COVID vaccine, it was a game changer. We have to promote data-driven decisions. We've heard a lot about data this morning, and we do need to do that. We have to build broad coalitions, CLCI is one, and above all, we have to encourage adequate budgeting for prevention. And Patrick has already said, so I don't need to ask you if you know that just 77% of, or 77% of European countries spend less than 0.5% of their health budgets on prevention, with some only spending 0.2%, and this has got to change. So in 2010, the global health community declared a decade of vaccines, and experts developed the World Health Organization's Global Vaccine Action Plan, so 2011 to 2020. So 2020 is now gone, which included a focus on establishing a life course approach to immunisation. Well, we're still trying to establish that approach, and there has been a great deal of success, I have to say. Since that action plan was published, there are now a number of organisations which have life course immunisation on their agendas. The Active Citizenship Network in Italy and in Brussels, the Institute of Excellence in Paediatrics, and the European Public Health Alliance, just to name a few. And many coalitions of experts and organisations have been formed. CLCI, as I've said for an example, DG Santé's Coalition of Vaccination, and the Immunisation for All Ages initiative, which is what we're going to speak about now. And the people who will be speaking about this, I think, are long-term advocates of vaccination into adulthood. Dr. Jane Barrett from the International Federation on Ageing, Professor Jean-Pierre Michel from Geneva University Medical School, and now Dr. Lena Bader from the International Federation on Ageing. And the Immunisation for All Ages initiative, which is working to combat inequity and improve access to immunisation to help promote health throughout life. So, Jane, over to you.
Thanks very much, Daphne, for the warm welcome, and good afternoon to everybody in beautiful France. You know, when I was invited to speak, there were 4 main questions that were given to me. And if you've looked in your papers, these are very complex and wide-ranging questions. So I just want to tackle each of them just with a note. First and foremost, it's important to actually let you know what the Immunisation for All Ages initiative is all about, because it actually responds to one of the first questions. You know, the members of this initiative are COMO, ILC UK, IFA, the World Federation of Public Health Associations, Shot at Life, and FIT. Now, in and of itself, those members actually reflect a life course approach to immunisation. So we are not only talking, but we are acting in the way coming together and developing a common agenda. It's a multi-sectoral discipline approach, multidiscipline approach. So the first question, what do we do? First of all, it's vertical advocacy as well as horizontal advocacy. Vertical advocacy, we actually have to help member states and also WHO to connect the dots between the Decade of Healthy Ageing, the Immunisation Agenda 2030, the Global Roadmap and the General Work Plan, the 13th General Work Plan. Now, Daphne was quite right. There is this life course approach in the Immunisation 2030 agenda, but older people are mentioned twice or three times. Not good enough. Also, the strategic priority 4, which is life course and integration, actually speaks to a very different topic other than life course approach to immunisation. So in fact, the IA 2030, which is now being implemented, does not actually speak to the issue of parity, life course approach, and this tension between and across generations. Horizontal advocacy. This really is where the rubber hits the road. We can talk advocacy, but unless we understand the situational barriers, which starts with an inadequate vaccination schedule for adults, or inadequate access to vaccines, or costs, or inability for a person to get to that administrator, then we've lost the game already. So it really is understanding at a very situational level. The second point, the Immunisation for All Ages initiative was commenced way before the pandemic. There are 3 fundamental pillars: prevention, access, equity. And the calls for action and the manifesto are as alive today as they were 3 years ago, which says something to us. You know, while we've talked a lot about immunisation and adults and COVID, fundamentally our policies have not moved forward. And in fact, the percentage of investment from member states in prevention actually has decreased. So prevention, access, equity is where our whole framework needs to be positioned. NITAG has been mentioned, and Canada and other countries have been mentioned as inadequate representation. It's across the world. There is inadequate representation across the life course on NITAGs, but SAGE is no different. My 4th point is about mechanisms. How do we actually ensure adequate access? That comes back down to what is happening on the ground. You know, inadequate access in Nairobi is very different to inadequate access for older people in Gimli in Manitoba. So I think we actually have to move on from saying we need to expand access to what is it at a situational level we need to deal with. And there's low-hanging fruit. For example, IFA has done a lot of work in terms of understanding the targeted messages, of which there are very few. You know, influenza has more messages to older people, but the absence of messages targeted to older people and those with chronic underlying conditions for pneumococcal pneumonia, pertussis and shingles is vastly inadequate, even if it is in existence. My final point, you know, speaks to equity. We really don't know and understand inequity in the context of adult vaccinations well at all. We talk about ageism, we talk about the social determinants of health, but we really need to understand timely, affordable vaccinations, taking the vaccine to the older people. In Hong Kong, it's a door-to-door proposition with COVID. So every situation is going to be different. And it's not only calling on us as international leaders and national leaders, but also all those organisations where immunisation doesn't fit into their portfolio. Diabetes, heart, respiratory, even the lifestyle organisations within the framework of age friendly need to be part of this collaboration and partnership towards a common agenda. So I'll stop there now. Thank you, Daphne, for the opportunity and for the organisers of this important event.
Brilliant. Thanks, Jane. I'm really sorry you're not here because I really wanted to ask about the puppies, which we could have discussed over dinner.
Daphne, you'll hear the puppies at the background, so my apologies. Thank you.
I'll take questions and we'll have a discussion at the end, I think, with regards to the timing. So, Professor Michel, could I ask you to give your contribution? Oh, shall I go straight to Lena? Okay, Lena, if you're ready.
Sure. Thank you so much, Daphne. Really hard to follow Jane there because she really hit all of the points, but I hope some of the key messages we've captured complement and support some of what she said. And actually, a lot of this has come out of work we've done with Daphne and Jane through lots of events and interviews. So it's really a summary of learnings from them. So very, very humble to share those. Again, with the 4 questions, really tackled one about advocacy. So, and really drawing on the last point to Jane about inequities, understanding those inequities is really important, and understanding the impact of them, and that the fact that they're not confined to one stage of an individual's life, although of course we're talking about adults, but rather remain and affect all of the years afterwards. In addition, the impacts are not restricted to only that individual, but also the lives of those around him or her. Therefore, we think that highlighting the burden on the healthcare system, the economy, etc., that health and vaccine inequities leave behind can help set the steps to ensure that life course immunization becomes a key pillar of prevention strategies. So again, understanding the inequities is key to this. So I really agree on that last point that Jane highlighted. In terms of also ensuring that the barriers are removed, there's obviously a lot of ways to do this, but maybe 2 or 3 points that have come out of some of the discussions and the work we've done is, one is the importance of having a political will to set policies in place to make the changes required to achieve equity. The value, of course, of the different communication strategies and messaging, and we've heard so many examples of these in the conference today. These should be used to reach out to the different groups, including social media, and the different, cater to different personal needs of the groups we really are targeting. A third one would be taking into consideration all the factors that may enable or stand in the way of achieving an equity. So of course, there's a lot, but one of them could include environmental factors, things like transportation, supply chain, operations, etc., that may inhibit accessibility of older adults to pharmacies or vaccination-based centers, as well as the marginalization of certain age groups as well. And we've seen that with older adults during the pandemic. So in terms of what we can do more to reduce vaccine inequity, again, a lot of what was mentioned already feed into that, but a few policy changes that can take place to transform vaccination and maybe close a little bit the vaccine inequity gaps include standardization of vaccine schedules for all ages, with a centralized system that shows patient records, and we've mentioned that earlier through David's question, of what vaccines have been received, and maybe using the learnings of the pandemic to sort of simplify record keeping and cater to the different capacities of health systems in different countries. This would allow, of course, all healthcare providers to keep track of what's going on. In addition, national immunization plans that are comprehensive and fully funded are essential. So adequate financing and strengthening of supply chain is really essential here. This also highlights the importance of strengthening the demand for vaccines by addressing also, of course, vaccine hesitancy and the health literacy. And this is a very important actually issue for us at FIP, and we're going to be focusing on this in a lot of work this year, focusing on health literacy and the role of that in health inclusivity. And of course, keeping in consideration communication strategy. I love the last question. I really liked so much that I actually went to a couple of our younger staff members who have joined some of our programs and really focused on working with myself and my colleague Gonzalo on vaccination inequity. And I asked them, if you could wave a magic advocacy wand, what would you change? And I really wanted to know what they said. So one of them, Noor, said, I think erase vaccine hesitancy. It would be useless to make vaccines accessible to all if people are hesitant to get them. And Ruben agreed and said, especially for healthcare professionals that are hesitant, those are quite problematic. Another superpower could be, and of course, as FIP, I would say this could be to empower all pharmacists, but of course, all healthcare providers to perform different vaccinations role, facilitating access as well as administering vaccines. This would for sure increase coverage rates. Thank you so much again for having me today. It's been a pleasure.
Great. Thanks, Lena. That was super. Professor Michel.
Hello. Hello, James. Hello, Lina. It was a pleasure. I missed you today with me. So I'm working with both of them, so I knew quite well what they were saying. So I will approach another aspect. I will approach two things. The first one is that we have to clearly have in mind that people are not convinced that vaccine is very useful. And I found data which alarmed me. Young parents, do not believe in vaccine for their children in 25% of the case, which is when we are speaking about life course approach. As parents do not believe in vaccine, but children has to take the vaccine, I think that it's main problem at the beginning of life. Then, concerning life course vaccine, we have now more and more data at different steps of life that we have data, very strong data, to promote this kind of vaccine approach. I will speak mainly about access. And for me, there are different ways of approaching access. I spoke about the problem of parents, but I think that we have a good model of approaching the cocooning approach of vaccines in Brazil. When parents come with their children to be vaccinated, generally they ask all the family, are you vaccinated? Did you get any vaccine? So I think that it is not only for children, but also for all the family to be involved, from the parents and grandparents. And I think that this cocooning approach is something that perhaps we have to go to have in mind and to go with that. The second point is that I spoke, and several people spoke about chronic disease. And I think that there is a lack, a very good lack. I think that we don't focus about the risk factors of chronic disease. But more than that, I think that, and it was stressed already a few minutes ago, at the end of hospitalization in diabetic ward, respiratory ward, cancer ward, there is no vaccination. And I think that it is a pity, because probably it will be the good time to involve the patients and also the medical specialists in vaccination their patients before they leave the hospital. The third point concerning the delivery is the problem of nursing home. And when people arrive in nursing home, there is no check of the vaccination. And I think it's another point which can be indeed very important to stress off. A last point is probably and for me, I'm convinced that healthcare profession has to be vaccinated. It has to be a mandatory vaccination, and we need to impose this kind of healthcare professional vaccination when they get their contract. And I think that it is something which is very, very important. And then, indeed, as it was said several times today, to increase the number of possible vaccinators. So, to last, I would like to say that probably we need also, indeed, to have the government involvement. We have to have free vaccination. We have to have more education, and perhaps also to change the image of vaccine. And we are when we are speaking about vaccine, we see always needles. Why having a kind of change in this approach and having vaccine without needles, and how we can also think that this new approach will be another way for getting delivering more positive message on vaccines. So it's all, and indeed, as was said just before, campaigns, vaccine campaigns would be useful. I think that in France we had a few years ago a lot of antibiotics campaigns which were acting very well. So why not having this kind of campaign also to promote vaccine, perhaps in presenting vaccine in another way with other arguments? I think that it will be good. Thank you very much, Jane and Lena, and so for me.
Thank you very much, Jean-Pierre. So let's have some discussion. I know we haven't got much time, but advocacy is so important, and we have some very good long-term advocates here. So questions, please. Yes.
I'm Julia Tanieke from the World Medical Association. Yes, hesitancy is a huge problem in increasing the uptake of vaccines. Being a GP, family physician as well, it's not easy how to address a patient with hesitancy. And WMA did for many years a campaign on increasing communication skills of physicians, a social media campaign, and it's very important. I don't know who said it before as well. So we need to increase the awareness among health professionals, on one hand, to be vaccinated, be a role model, and give them tools how to address this with patients and give them ideas how to do this. And I think COVID showed us as well that not access is a problem, hesitancy is the problem, and communicating, hear this from many different health professionals, from many different sources, in social media, in journals, and everything. I think there is where we can address hesitancy and with patients together. And we need to face it as well. The health professionals are the same group of people than everyone else, and there's hesitancy, unfortunately, among health professionals as well, which is a big problem for us, because as we have heard it before, if a doctor says, I'm not vaccinated and I don't recommend you the vaccination, it's honestly a disaster. And someone spoke before about the extreme anti-vaccine movement. So when we did our social media campaign, we had some research there as well and analyzed where does it come from. And it's very interesting. There are some main sources who are the main drivers getting a lot of money, and they are pushing out this information. So it's kind of a real campaign to get the message out from them. And the more you feed them with facts, the more they turn the word into your minds around, and it's impossible to, well, we don't see any strategy to address anti-vaccine movements.
The $64,000 question, that how do you address anti-vaccine campaigns? Just one point that I'd like to make before I turn to our speakers is we tend to forget that doctors are humans too, that they're all part of the community with the same issues in terms of vaccine hesitancy, etc., as we all have. So they are seen to be the givers of information, but we forget that we need to give them the information too. And I think the Coalition for Vaccination that DG Santé has set up, that is designed to face that problem. We wait to see whether it has any effect. Lena, Jane, do you have any further comments on this? And Jean-Pierre also.
Go, Lena. I'll follow you.
Thanks, Jane. I'll be brief because I touched on this, but this is such an important issue, and you know, it would be amazing to have a magic wand to erase hesitancy that would solve the problem, but of course we can't do that. So at FIP, we acknowledge this and the role of pharmacy in this. So the toolkit that I mentioned in the earlier presentation on vaccine confidence presents a number of tools that pharmacists can use in practice. And one of them is understanding vaccine hesitancy and the different patient profiles and how to address each one of them, because it does present itself in different forms and there's different acceptance levels depending on the patient. Of course, there is the big issue of vaccine hesitancy within healthcare professionals. I think there's more work to be done. It does still feel like the elephant in the room. We do need to find a way to have an honest conversation without excluding them. And that's, I think, one of the things we still need to tackle.
Thanks, Lena. Just a few comments. The nature and form of vaccine hesitancy changes. You know, let's not actually, you know, consider that vaccine hesitancy is in a box. It's not. And I think it's really underpinned by social determinants of health, but also there is a narrative that older people are vaccine hesitant. And I think we've really got to unpack that, because in many circumstances they're not hesitant, they lack awareness, they can't get to administrator. So I think this whole vaccine hesitancy box is dynamic and it's very situational once again. Trusted sources, you know, pharmacists, doctors, etc., you know, it's also about acknowledging that some people have chosen not to be vaccinated regardless. And I think, you know, that population, you know, cannot be classified as vaccine hesitant. So I think it's much more complex, but the nature and form is changing and changing in the midst of the pandemic. So I think it's about being up to date, but also asking the questions and acknowledging some tools work for some groups, some tools don't. Thanks.
Yes, I would like to answer your question, Daphne, because I think that it's very important. We did not discuss it before until now, but I think that in a nursing study or in medical study, vaccines are not a priority. We teach only vaccine after one disease, and at the end of the teaching activities, we said there is vaccine to prevent the disease, but there is no formal vaccine courses within the medical study. And I was thinking that I would like to do a survey about the medical schools over the world to know how long is the time span to explain what is a vaccine, how it can act. And I'm sure that I will be completely surprised by the low involvement of this medical school with vaccine. So I think that vaccine hesitancy is also a problem of education.
Yes, and I think you'll find that your survey will probably be quite short, because the amount of time that is given to medical students is minuscule in terms of vaccination and prevention. But that's a real point. Yes, please.
So I'd love to propose that we stop using the term vaccine hesitancy and turn to vaccine confidence, because I think it's about building confidence. There were some very good points about trusted messengers, and I think putting taking a look at what the real problem is, rather than placing the onus on the patient that may have questions or may have concerns with getting access, could make a difference. The other thing that I'd also like to see us address is who we define as health professionals, because particularly with older adults, there's a lot of home health aides or others that provide care that maybe lack confidence themselves, and focusing on the people within the communities that are delivering messages and helping people make their own decisions, I think is a really critical role. So I'd love to hear what the thoughts are about how we can start to expand who we define as those that are providing care.
Absolutely. I couldn't agree with you more. Please, Jane, Lena, Jean-Pierre.
Look, Lois, I agree. Vaccine confidence is certainly a term that we advocate for. I think the challenge is that both terms are used, so we actually need to actually make the connection, and almost it's an inverse relationship, isn't it? I think that's one thing. The second point is around healthcare professionals, and I want to, perhaps be a little bit provocative here, because we know in low and middle income countries, qualified vaccinators, can range in terms of, the credentials that they've got. And so, I think we've actually got to think more broadly about who is the administrator, who administers the vaccine. In some countries, it's been the dentist. I wonder whether that kind of trend is going to continue. And does it make a difference if we define healthcare professional? I'm not sure whether it does make the task any less difficult or easy.
Well, thank you very much. I've just had the nod that we need to bring this to the end. I'm just going to add another controversial point in here. Stop calling us old. That's the first thing. And to thank everybody for their contribution in this last session. It's been great, and it's something that we can talk about all the time through lunch, because advocacy is so important. And I know this is being streamed live, and we don't have any policymakers in the room. But if anyone out there is a policymaker or the assistant of a politician who wishes to engage with this, then please get in touch with us. Thank you very much.
Ladies and gents, lunch is basically ready. However, as David mentioned yesterday, we would like to get a photograph of everybody before we go to lunch. So if I could ask everyone to just make their way to the terrace, that would be fabulous. We'll have a photograph done, and then we'll go ahead and eat, conscious of time. So I think if we can all be back seated again by 2:15, and then we'll try and sort of catch up a little bit of the time this afternoon, that would be ideal.
First session, I'm Mark Chataway, by the way, so if I haven't met some of you. The first session this afternoon is on delivering prevention. We have a number of presentations. We have a number of questions that have already been kind of skirted around this morning, that have already been slightly addressed. So I hope that we'll be able to come up with some new insights and some new approaches in our panel this afternoon. And what we're going to do is we're going to have the 4 people with slides present up front, and then we're going to try and make the panel a bit more discursive and involve you in that discussion as well. So what I'm going to do in just a second is ask the panelists, you don't have to come up front, but ask the panelists to introduce themselves so we can all see who's going to be in the panel, and then we'll go into the slides. It occurred to me this morning that there were 2 things that occurred to me. One is that I think we've touched on a big theme. So let me come to that in a second. But the second thing that occurred to me, and we were discussing it over lunch as well, is the kind of power of the attitude of healthcare professionals. And I remember I must have been 24, 25, living in New York, and I had one of the few GPs left in New York, I think. He'd grown up in Nebraska. And I walked into him one day, and he said to me, "So you're doing postgraduate psychology, right?" So I said, "Yes." He said, "And you smoke?" So I said, "Yes." So he said, "So you must know why." So he picks up his prescribing pad, and he said, "Right, so if it's because it keeps you awake, I'll give you a prescription for amphetamines. If it's because it helps you relax, I'll give you benzodiazepines." He said, "And if it's because it makes you sleep, I'll give you hypnotics. I'll give you all of them if you want." He said, "So just tell me, what do you want?" So I said, "Well, nothing really." He said, "Okay." And I gave up smoking. And he said, "So are you going to?" And I said, "Yes." He said, "Okay, we'll have an appointment in 2 weeks. Tell me how you're getting on." And I've never smoked again. And, you know, that is the power of a good doctor to push somebody in the direction of a healthy behavior. And there's power to do it the wrong way as well. I think the big issue we sort of touched on this morning, that I hope we'll touch on a bit more this afternoon, is a bit of a struggle that's going to come up with doctors, and a bit of a struggle that's already come up. Because in a lot of countries, we heard over and over this morning, and I think because we're talking about delivery this afternoon, there are doctors who are very threatened by the idea that pharmacists, that nurses, that even vaccine volunteers are giving immunization, and that's become a major barrier to immunization and to some other prevention technologies. So there's a fascinating piece of work that was done by the Novartis Foundation in 3 cities, where they used big data to try and identify the most vulnerable and the most at risk. And they then mobilized hairdressers and barbers and bus conductors to get people to have their blood pressure tested. And over, I'll get this figure wrong, but over a period of about 2 years, they were able to reduce the incidence of cardiovascular mortality by a third. But of course, that's very threatening. If they did this in Dakar, in Sao Paulo, and in Ulaanbaatar, if you're a GP in Sao Paulo, that's not an unmixed piece of good news. So I think one of the things we'll touch on this afternoon is this tension between different parts of the public health system and different parts of the professionals. And I'd be very interested in hearing your views on that, because we are entering a period of revolutionary change with health technology, with the power of big data, with the transformation of diagnostics, and indeed with new vaccines. So I'd be really interested to hear your views on that. Lovely. With all of that, let me get the panel to introduce themselves. So if you're comfortable, panel, doing this from where you're sitting, rather than make you all come up and sit in the front while the slides are presented, I'll ask you to just introduce yourself. So I think, Lily, you're going to be the first to speak. Do you want to just say quickly who you are, for anybody who hasn't met you, and what your interest is in this?
Yes, hello everyone. I'm Lily Parsi. I'm the Global Policy and Influencing Manager at ILC. I wasn't here yesterday, so hello to some of you I haven't said hello to yet. And together with Aaron, I've really been working on our delivering prevention program, sort of looking at how we can move from, look, we all know it's a good idea, to actually sort of delivering it. And so I've been working on the sort of policy engagement side.
Lovely. Aaron, most of us saw you yesterday afternoon, but...
Yes, I don't know if I really need to introduce myself, but I will just in case. I'm Aaron Himmelwan. I'm a research fellow at ILC, and I lead on a number of our global health projects, also alongside Lily with the prevention program. And yeah, excited to talk about this really big project that we've spent a lot of time on, actually. And yeah, looking forward to hearing the Q&A discussion, people's thoughts.
And Julia, I think, again...
Hello, I'm Julia Taniaki. I'm from the World Medical Association. We represent physicians worldwide, and I'm a physician and do now health advocacy.
Great. And you have some slides for us, right?
I can have slides, or we start in the discussion.
No, if you have them, it would be great. Lovely. Okay. Perfect. Edward.
Hi, I'm Ed Mail, so I'm a consultant at Sprink. We're a consultancy that focuses on patient-centered value-based healthcare and also food in healthcare systems, which I'm going to speak a bit more about. The other half of my job is also being a GP. So just to your point, Mark, certainly in London, we're absolutely desperate for help. So we don't feel threatened at all by more the merrier, basically, because we're totally overwhelmed. So as many pharmacists and physiotherapists, ambulance technicians, whoever wants to help is very welcome. So.
No, and that's actually a really good point, Ed, that it does differ very much between countries with overstretched healthcare systems, Portugal, UK, many middle-income countries, and countries with lots of spare provision. Tilly. There you are.
So as well as being 25, I also work for a Scottish charity called Food Train, and Food Train was started by an older lady called Jean Mundell 25 years ago as well, who recognised the barriers to accessing food and the kind of wider social model of health. So we've since expanded across Scotland, and I particularly work on our Eat Well, Age Well project, which is quite an innovative model around tackling malnutrition, which is as undernutrition amongst older people living at home in Scotland. So I lead on our policy and influencing work, and we work closely with Scottish Government and are funded by Scottish Government around this. So it's kind of this wider social recognition of health and also how food and the health system are interconnected.
Lovely. And you don't have slides for us, right? And Ed does. Great. Good. Okay, lovely. And then I think Professor Esposito has not joined us. She was going to join us at a distance, but she hasn't. So if she comes along, we will include her, but if she doesn't, we won't. Meta.
Yes, hi everyone. My name is Meta, and I'm Director of Foresight Global Health, which is a publication focusing on specifically prevention and control of non-communicable diseases. And I've been very excited over this morning to hear all the cases, all the data, all the insights, and really seeing the case for prevention. I think the main thing I would like to focus on today, obviously as a publisher and a comms expert, is really how do we package that message in a good way? How do we really reach the audience beyond the, if I have to be a little bit frank, echo chamber in terms of really getting the message out? And I really think we need to change the narrative in terms of how we talk about prevention when we talk to non-healthcare experts, to make sure that we actually really see the investments we want. So I have a few thoughts on that specifically.
Fantastic, because you're quite right. That is something we didn't spend enough time on, and we didn't spend enough time on the kind of brutal aspect of politics as well. We talked about the nice evidence-driven aspect, but we didn't talk about the reality of politics quite often, so I hope we can get that into. Lovely. Well, with that, I'm going to ask Aaron. No, I'm not. I'm going to ask Lily. Sorry, I was told. But recall problems. Ask Lily to start us off, and we'll have these 4 slide presentations, then we'll go straight into the discussion. So.
Thanks, everyone. And this is, so we're going to briefly sort of split this between Aaron and I, just to talk a bit about our programme of work. Obviously, this morning already we were talking about immunisation, which clearly is a big kind of part of the prevention agenda and so topical, particularly during COVID-19, where we've seen lots of really different approaches to it, innovation and so on. But we do want to talk about prevention a little bit more broadly as well. And immunisation is clearly sort of at the heart of that. So the report we published last month was called A Window of Opportunity, and I think that's the sort of key point I would, thank you, I would like to make today is that, you know, among all the devastation of COVID, we have really seen governments spring into action, step up to the mark, and sort of come up with lots of new ideas of how to tackle health inequalities, how to personalise messaging and sort of really work with communities. And there's a real opportunity for us to build on that, to make sure that, you know, the different COVID-19 apps actually become the app where we have all our health data, that the ways of going into the community, that all the different volunteers and different professions that were involved, for example, in the COVID vaccine rollout, continue to work together and to help to work together better. But at the same time, you know, a window of opportunity also always has a time where it closes, and so we need to make sure that we're acting fast. So broadly, I think, you know, the title of the summit gave it away. I guess we broadly think that prevention is a good idea. I imagine everyone here in the room does. That it's cost effective, it works, it saves lives, and it really helps to, you know, keep disability at bay and make sure that people can live longer and more productively. So this is some of the, you know, data that we've sort of collated over the last few years, really working around this area on prevention, as well as Sophia, I think, highlighted as well yesterday, you know, the real impact that has not just on people's health and the sustainability of health systems, but also our wider economy. So we know that prevention works and that it really pays off. This graph here on the right is also looking at, you know, where that money comes from. So when governments pay for a bigger share of health spending, outcomes seem to be better as well. So clearly there's a big case to invest and for governments to step up. So over the last 2 to 3 years, we've been running this programme of work, initially on prevention in an ageing world, and then this year we rebranded it to Delivering Prevention in an Ageing World. We've been publishing a number of reports that you can see here. We've been speaking to different organisations across the world. I mean, this is just a snapshot, and obviously there's many more in the room today. Really about what works in delivering prevention on the ground. And we know that across all of our work, so when we kicked this off in 2019, we held an event alongside the G20 health ministers in Japan as well. And there was really strong sort of agreement. And actually everyone, you know, clearly knows that this is a good idea. Particularly health ministers know that this is a good idea. The problem is really in implementing it and kind of moving forward. We've seen progress. There are lots of things sort of on the global agenda, such as the UN Decade of Healthy Aging, the immunization agenda that Jane mentioned before. Yes, that's not as far as it should be, but it has got a whole chapter on life course. There are lots of things happening around the world, but you know, we still think of prevention as a nice to have and only something that we can spare time for when there is time. But obviously, particularly now with waiting lists being longer than ever, actually we need to make the time and not just rely on it sort of being there. This is from 2017, but looking kind of broadly at how much countries actually spend on preventative health. Now it's, you know, a hard thing to measure, but on average, if we see that about, you know, just over 2% in OECD countries are spent on prevention, then we know that's just not good enough. And particularly if, you know, if we are aging and people are going to have more and more comorbidities, we need to sort of move that forward and change this around. The highest within these, though, is Canada, and one of the reports we published during this project was looking specifically at what Canada has done since then. So they spend 6%, which has sort of come as a result of lots of different movements, and Canada really sort of, you know, moving forward on the prevention and health promotion agenda very early on. And it shouldn't really come as a surprise that, you know, since spending more in this area, there's been a decrease in avoidable mortality, increase in life expectancy, and so on. And this is really what, throughout our project, we've been calling other countries to start off as. So we know this is an achievable target. We know that it's probably not the be-all and end-all at all, and that, you know, just spending more isn't always the solution. It's also about how we spend it and being more effective. But it is a benchmark that people can start sort of looking forward to. And now COVID, of course, and, you know, we've done this project, not that it was planned that way, but throughout a period where we saw, you know, lots of radical change, lots of new things being tried out all around the world. Really, in some ways, not to sound sort of opportunist, but a hotbed for sort of different ideas and people implementing things very fast. Now, we think there is an opportunity here. Things like the COVID dashboard, for example, that we have there, that were really effective in actually sort of seeing how progress was going across the world and holding governments to account. All the different ways of, delivering immunization, for example, here at a football stadium, to think sort of differently about this, bring new people in and put the sort of prevention puzzle sort of on its head. But, I guess on the left-hand side, this is just more of a warning that we do know that when funds are tight coming out of a crisis, so this is looking at how health spend sort of changed after the austerity years across the OECD. Prevention was the biggest cut that countries saw during that time. And we just need to make sure that we're not sort of making those same mistakes now. And hopefully, COVID has taught us all that we really can't sort of risk that. So let's seize the opportunity. We know that poor health isn't an inevitable consequence of an aging population, but at the moment it seems like we're sort of heading that way. We know that lots of governments agree. We're looking here specifically at G20, but it's really across the board. People have committed to improving population health and to invest more in prevention, but we just need to make sure that we're doing this and that we learn from what we built during COVID. So I'll hand over to Aaron.
I've already done. I can go. Yeah, there it is. Oh, someone else is doing it?
I know I said we were short on time.
Aaron, if you just take it from there.
Can I? Yeah. Okay. Perfect. All right. Sorry about that. Yes. I think what Lily has said is, it's very clear that there's this economic and health case for investing in prevention, and I think we're going to have to continue to make that case to really ensure that governments recognize the importance of prevention. But we also have this other issue. When we're telling people why they need to invest in prevention, we're often not considering the question of how they should be doing it. And so our report really considers how can we actually get healthcare systems across the G20 to reorient themselves so that preventative healthcare is at the heart of what they do. And this requires a lot of a new way of thinking. It's not a simple and easy answer. And of course, from country to country, the context will change. So this hopefully gives you a general understanding of what are the key things that need to happen at the national levels of countries. But of course, really interested to also hear from people's own personal perspectives from their own country, what resonates with them the most. But one of the key things that needs to happen is we need to see systems that are actually designed for prevention. We need to invest in these types of systems. And this starts with G20 countries increasing their spending on prevention to at least 6% of health budgets. Obviously, this is just, like I said, the beginning, and so it needs to be supported by a lot more, like, for instance, developing national preventative health strategies that actually look at health across the spectrum, understanding the relationships between different conditions and how we can actually treat them and prevent them together. And, when we think about 6%, it can sometimes seem like a large number, but actually when we put this into context during the pandemic with the UK, we can actually see that we're not talking about huge amounts of spend here. And, we've certainly seen that when we are faced with crisis, countries are willing to support and address these and tackle these with additional funding. So we can certainly do it if we want to. So in addition to sort of that sort of top level investment, we also need to think about how services run. They need to be more integrated. So we need to move towards more integrated healthcare systems with shared objectives and outcomes across public health, health services, and social care. And this also includes non-traditional providers as well, and especially in sort of middle and lower income countries, it's certainly true that charities actually play a significant role in delivering preventative healthcare, particularly to marginalized and underserved groups. So first of all, there's a job of identifying who these actors are, but also how can we involve them in the conversation, and how can we actually have them as part of an integrated healthcare system. And the other thing is also looking at how we can pool budgets across public health, across health services, as well as social care. And again, the role of NGOs, other community-based services need to be involved in that discussion. And this will really help us address siloization between different professions, to really ensure that they're having that conversation, and we're thinking about the individual across the life course, and how they may, be in poor health at times, how they might be in good health, and how that interrelates with one another, and how they interrelate with the healthcare system as well. And we also need to be moving away from a fee-for-service model, which essentially reimburses healthcare systems to do more, such as procedures, tests, to more of a value-based payment model, which actually incentivizes healthcare professionals and providers to improve health outcomes. And this is crucial because oftentimes it can mean that actually doing less is more in terms of keeping people well for longer. So it's really important that we think about how our services are reimbursed, and actually thinking about actually thinking about how can we improve health outcomes, and how can we actually ensure that people are living not just for longer but also in better health. And there's a lot that we also need to do in terms of inspiring, engaging at various levels, at the policymaker level, at the healthcare system level, and also at the individual level. But starting at the policy level, first we need to hold national governments to account and incentivize action. The WHO has a number of targets, both for immunization, both for NCDs. There's clearly a commitment there to from governments to invest in preventative health, but what we're really lacking is a ranking system, a way in which we can actually hold countries to account, governments to account, and to actually track their progress. And without some sort of mechanism like that, it's far too easy for countries to de-emphasize, deprioritize prevention. So we really need to be thinking about how we can hold countries more to account. We also need to encourage policymakers to take action. The health arena is quite crowded with lots of people saying lots of really important things, and unfortunately sometimes that means that some voices aren't heard enough. The voices that maybe shouldn't be heard are heard too much. But actually what we need to recognize is all prevention advocates, healthcare advocates actually agree on a lot of things. And how can we use that and leverage that? Maybe we can bring everyone together under sort of this umbrella coalition and actually think about what are the sort of big aims when it comes to global health, and use that together as a platform to then engage with policymakers to actually get them to agree to some very specific but really important asks. Right. Thinking about how we might inspire and engage healthcare professionals, one of the key things is that we need to make time and we need to address healthcare workforce shortages. I think David was mentioning this earlier in his presentation, but the WHO estimates a shortfall of 18 million healthcare professionals by 2030. So we really need to address that. If we're asking healthcare professionals to do more around prevention, we actually need to ensure that they're supported and there's a strong workforce to actually do the work. And we also need to think about improving working conditions and retention, and this is something I think that's been brought to light, especially during the pandemic. But we also have to recognize that those that are particularly at risk of burnout, women who make 70% of the global workforce, healthcare workforce, those from ethnic minorities are particularly at risk of burnout and of poor working conditions. And how can we actually address that? There needs to be more focus on that. And we also need to ensure that the full range of healthcare professionals are involved in delivering preventative interventions and developing and delivering national health strategies. Everyone needs to be in part of the conversation here. And it's really important that we think about, who's at the table and what they're saying and how they're saying it, and that needs a lot more careful consideration. But, obviously involving healthcare professionals and the wider sort of healthcare ecosystem, that's part of the solution. The other thing is we have to support that through proper training. So we need to ensure that healthcare professionals are trained, that they're equipped, and that they're incentivized to promote preventative efforts. And we need to think again about the ways in which different healthcare professionals interact. We need to give them space to actually discuss and have discussions with different people, different actors working in the healthcare system, to understand what their priorities are, to understand how their profession might relate to someone else's profession, and to also sort of build a sort of mutual respect as well, which is going to be really important if we want to deliver prevention. And the other point is we also need to think about how we're inspiring and engaging individuals. And one very clear way that we can do that is by improving trust. And I think, we've mentioned this many, many times today, so I'll hopefully go through this very quickly. But I think we can agree that, there's been so many examples of communities working together during the pandemic to improve trust for many marginalized groups. But these are dotted throughout countries. There's no sort of coherent way in which we're doing that. So we really need to ensure that these links between healthcare providers and various trusted community actors are actually established, and that we have that sort of formalized communication pathway between the two, so that whenever there is whenever we see a health issue that needs to be addressed for a population, we know exactly how we can address that. So moving on to how we can address really inequalities in terms of barriers to access, but also thinking about how we can actively engage different communities. So when we think about barriers to access, geographical barriers, economic barriers, these are all, quite important ones. Knowledge has been something that we've been talking about a bit today as well. These are all barriers for people to accessing vital preventative health care. When we talk about actively engaging communities, again, we know that marginalized groups, various different marginalized groups, can be locked out of preventative health care for a variety of different reasons. But how can we actually engage these? And this is across, social minorities, including ageist perceptions that individuals and healthcare professionals can hold. How do we address these sorts of barriers? And there's a few things that we can do. So first is really removing those cost barriers and ensuring that cost is not a barrier to access to vital preventative services and activities. And this is across, all the various services that are available. This really has to be key to sort of democratizing access to prevention. And we also have to make prevention a life course priority, and we need to implement national life course vaccination and NCD programs and ensure parity of targets across all age groups. This is going to be essential if we want to ensure that at no age will anyone not be supported by their GP, by the healthcare provision in their country. And we also need to think about providing person-centered care, and this really gets to the heart of social determinants of health, because we're not going to understand the specific barriers that people face if we don't actually have a plan that suits their own specific circumstances. So having person-centered care as a central tenet of a healthcare system is really quite crucial into trying to tackle this, as is also co-designing of services as well, to really be able to tackle those barriers. And we also have to think a little bit about targeting interventions. And thinking about how we provide prevention where people are. So supporting healthcare providers to build partnerships with their communities, including NGOs, community-based organizations, also the workplace, and we spoke about this a little bit before. Workplace can be a great place, for instance, for delivering vaccination, but also in terms of NCD screening. Can really help to open the doors for many people who might not be able to access their healthcare system on a regular basis. We also have to think about how can we deliver healthcare, preventative healthcare in people's homes, particularly for those with disability or limited mobility. And of course, delivering these services in the community is going to be really, really important as well. All right, and so finally, I want to talk just a little bit about the use of technology and how can we use it more effectively for us to support preventative health efforts. And there's lots of different things here, but I think the main thing is we know that there's been lots of innovation during the pandemic, so we really need to build on what we've learned. So really thinking about how can we extend and enhance data coordination efforts established in response to the pandemic, and support data sharing across healthcare systems. In the UK, for instance, the NHS app is a great example of how we can use that to actually support people's health moving forward out of the pandemic. We also have to look at how we can enable people better. So investing in technology infrastructure and in building digital skills and literacy among individuals and their healthcare professionals. And there's a lot to unpack here because I think technology does have the potential to reduce inequalities, but we have to be thinking about how can we address things like digital exclusion. And so ensuring that we're investing in infrastructure is going to be really, really important. I mean, I think some data, suggests that infrastructure is not just something that affects low and middle income countries. It even affects developed countries as well. And when it comes to digital skills as well, lots of countries have huge proportions of their population who don't know how to use internet for basic tasks. For instance, an attachment on an email. Many don't know how to do that. So how can we actually support that? And there's a huge opportunity for older adults here because actually, and you take Europe for instance, older adults are, when they do go online, and the proportion of them that are going online is growing, but when they do go online, the number one thing that they look at is services and information about their health. So huge opportunity there. And we also need to be thinking about getting the right solutions working. So implementing a health technology assessment framework for digital solutions. And we can look to Germany here as a prime example of how that really works. And it will really ensure that we're building solutions that actually help to solve an issue. Also solutions that work. Really thinking about that, the user's needs and also the end. What's the point of the intervention? Not just looking to fancy new technologies, but actually what works. And also thinking about how can we accelerate that regulatory path for companies to bring these digital health applications to market is also going to be quite important as well. So I'm just going to leave that there. Lots to think about, and I'm happy to expand during the Q&A. So thank you, everybody.
Lovely. Thank you so much. So Aaron gave us a lot to think about there, and I particularly want to follow up in the Q&A. So I'd like, if you could start, pick up on whatever you want, but the two things I'd love to talk a bit more about are the point on incentives and then the point about how we hold governments to account and what exactly we ask governments to do. Because it's the big lesson of public affairs. If you're going in to see a legislator or a minister, you need to know what you want. And it can't be a long list of utopian suggestions. It has to be, I want you to do this tomorrow. So if we could think about that, and we'll pick up on it. Now, I'm conscious that in all of our discussions yesterday and this morning, we focused on prevention as if it were just a question of vaccinations and diagnostics. And we're now going to do a slight course correction, right, Ed? And we're going to talk a little bit about health and food and diet. So I think Ed and Julia are going to, Ed, you're going to mention a bit about food as well now, which is lovely, and we need to do. By the way, if you were here in Annecy, normally food, access to food, malnutrition, as Tilly was saying earlier, is a cause of poor health. If you were here in Annecy, 250 years ago, it was a cause of likely death, because during the French Revolution they could spot who the aristocrats were, because they tended to be much taller and much better built than the malnourished poor people. So apparently the crowds often targeted anybody who had the misfortune to be tall and well built.
Wrong slides. Shall I cycle through and then we can come back to the... Yeah.
I'm sorry.
I can probably flick through them in a couple of seconds.
Yeah, flick through if it's all right with you, Julie, and then we'll come. Is that okay? Sorry. Me being incapable of following instructions.
All right. Yeah, so my name's Ed Mail. So, as I mentioned, I'm a senior consultant at Sprink and a GP in the NHS. First of all, thank you so much for the ILC for hosting this event, and also giving me the opportunity to present on what must be the biggest screen I've ever seen. So it's very, very kind of them. All right, so I'm just going to start by saying a little bit about Sprink. So we're a consultancy that basically focuses on 3 key areas. So the first area is a global centre for person-centred value-based healthcare, and that's aiming to apply a value-based healthcare approach, but allow people to think about the goals and outcomes which matter most for them, so putting a person-centred spin on that. And then we have the Global Centre for Healthy Food Environments, which I'm going to speak more about now. And then finally we have partnership development, so supporting the development of partnerships between health systems, industry and the third sector with a focus on value. And these are some of the partners we work with, so government and healthcare systems, hospitals and universities, and the life science industry. This is primarily with the focus on the person-centred value-based healthcare work at the moment. Okay, so as I go through this, I'm going to respond to the parts of the ILC's Delivering Prevention report. And so one of the questions was, what are the challenges we're facing in terms of delivering prevention? And so one of the challenges we've identified is that the food environments in our health systems often don't promote health and sometimes actively damage health. And we've spoken a lot today about the importance of our healthcare professionals kind of practicing what they preach in terms of being immunised themselves. But equally, we believe that the healthcare system, so the built environment in terms of the hospital and the clinic, should also be an exemplar of best practice. But so often, unfortunately, you go to a hospital and the food served there to patients, staff and visitors is really poor. And so it's easy to see why a member of the public would think, well, why should I adopt a healthy diet if I go to the hospital and they're serving kind of fizzy drinks and chocolate and burgers, etc. And I think the starkest example of that is there's a very famous cardiac hospital in the UK where there's a very well-known burger chain has an outlet right in the basically in the entrance, which is almost satirical, I think. All right. And so in the context of this, there's also, I think, a broader social movement where people are becoming increasingly attuned to the impact of their dietary choices on climate and the environment. We've spoken about One Health as well. And also the ethical implications of their dietary choices in terms of animal welfare and in terms of labour practices and human rights in food supply chains. And then further context of these changes are occurring against a backdrop of soaring global food prices. And we saw in the ILC's report a aspiration for 6% spending on prevention. And I think thinking about food would potentially be a good way to spend some of that money. And then to focus on the elderly, so under and overnutrition are increasingly prominent in the elderly. So actually, both the highest proportion of people who are malnourished and the highest proportion of people who are overnourished, i.e. overweight or obese, is among the over 65s, and that's increasing. And so in an ageing context, we think that addressing this is a priority. And then finally, health systems are disproportionately accessed by those of lower socioeconomic status. And so in terms of, again, the ILC's call to democratise access to prevention, we think that addressing this will help reduce health inequalities as well. Okay, so what are we trying to do about this? So we've founded something called the Global Centre for Healthy Food Environments, and we have a vision. So our vision is that healthy food environments are those which are underpinned by the latest evidence about what constitutes healthy food. They enable and promote healthy, sustainable and ethical diets, and importantly with food being tasty and affordable, and influenced by different sociocultural and socioeconomic groups across populations. And as I mentioned, we're initially focusing on food environments within healthcare systems, so hospitals and large outpatient clinics. And so how are we going to try and achieve this? Well, first of all, we have 4 broad goals. Firstly, implementation. So supporting the implementation of healthy food environments within healthcare systems. So working with organisations to equip them with the practical goals to improve the food environments. And that's not just making sure that healthy food's available, but it's also making sure that the environment is one which is conducive to people making healthy choices using behavioural science. So again, that's also highlighted in the Delivering Prevention report. Secondly, building a community of health systems and organisations working together to implement healthy food environments with the aim of sharing best practice and mentoring. Research, so performing research to improve the concept of healthy food environments. So the area currently is under-researched and we don't exactly know what best practice and gold standard looks like, so we want to try and grow that evidence base to inform progress. And then finally collaborate, so work with other organisations, whether that's business, third sector, academic organisations, etc., with the same goal in mind. And so what are our practical activities to achieve this? So implementation, programmes to support the implementation of healthy food environments. So we're already working with the NHS in Wales to review their food environment and working with them to improve it. Education, so we're launching a virtual education programme in January 2023, which covers the key principles of healthy food environments and the practical skills needed to improve and implement those. Research, so I mentioned research before, we're planning to publish our first publication in October, which focuses on the definition of a healthy food environment, so really understanding in detail what that looks like. And then networking, so virtual and in-person networking events for mentoring and peer support. Conferences, so having great get-togethers like this to share ideas and best practice. And then services, so bespoke services to support the implementation of healthy food environments in specific organisations. And then in terms of how external organisations can engage with our global centre, so organisations can become members, and members can therefore engage in 4 areas. So they can engage with and shape our research programmes, they can participate in our education programmes, they can work with us on implementation, and there's also networking opportunities. And then we also have bespoke services for individual organisations, so strategic advisory services focused on identifying specific issues within organisations and designing bespoke solutions for those. Tailored education programmes, developing educational programmes for specific issues, and then commissioned research, so answering specific questions within organisations about their food environment and how to improve it. So thank you very much for your time, and happy to chat now or later or online. Thank you.
Thanks, Ed. Well, certainly the vision of the burger chain. So, Julia, I apologise for being incapable of following instructions. Well, the image of the burger chain at the cardiovascular hospital will stick in my mind for a long time, I'm sure. Julia, and then we'll get all our panelists up and reflect.
Do I use this one?
You can.
Okay, perfect. Why does it? Where do I need to point? Okay, perfect. So, thank you very much. Just a brief introduction. The World Medical Association, we are the international organization representing roughly 9 million physicians worldwide. We were founded 1947 in Paris, and our aim is there to ensure the independence of physicians, highest possible standards of medical ethics, best medical practice, and acting on behalf of patients and physicians. In my presentation, I like all this discussion which we have afterwards, so that's why I just go briefly and just give some highlights, and I go rather quicker through these slides than longer. So when we talk about healthy aging, I think we need to think about 2 different groups we have. On one hand, these healthy, fit, older people who want to stay fit, but we need to think as well of these people who need long-term care, palliative care, where we need to make the life easier for them. So the aim is this healthy aging, which WHO defines as the process of developing and maintaining the functional ability that enables well-being in older age. And here the elderly population, I learned yesterday it's older population, I need to change this. they have a huge value, and we need to enable them to give us this value. One point I would like to mention here as well is the multimorbidity, because even if I'm a bit older, but still many of these people have multimorbidity, which means 2 or more chronic conditions. I can be fit and you don't see it, but still 60% of these between 65 to 70 are multimorbidity, and that has an impact as well on prevention, on how do I deliver healthcare, what do I need to offer these patients. Then we need to look as well to the difference between how is healthcare in the developed world and how is healthcare and prevention in the developing world. And I think we heard the report of Hong Kong, but I think it's quite amazing that the difference of the average age, life expectancy, can vary between 30 years in from the highest to the lowest country. And 30 years is a lot. It's really a lot. I think we need to look as well, what can we do in the developing world to help them to have a prosperous life as we in the richer countries have. And especially in the developing world, what we have now, the typical pyramid with just a few elderly people and quite a lot of young people, will change there as well. And this use huge burden of challenges on the society, on the health system. And what we need to think as well is, when I just look of the burden of non-communicable diseases in the developing world, most of them is in the developing world. And the cancer rate, for example, is the highest in the developing world. And the problem there is that prevention is not as good as in the richer countries, so cancer is detected as a far later stage. It doesn't like me. To deliver prevention, we need, as we have heard before, a lot of health professionals, social workers, many people who live, who work for the health system. But these people are aging as well. So WHO estimated that by 2013 we have lack of health professionals of 18 million, but many of them will retire. So this will increase the whole system. We have a bigger need, but we have less supply. And this needs to be, we need to think and discuss this issue as well. We raised this issue as well here as well, to have prevention as a life course approach. And as we all know, if you want to change your behavior, that is difficult. It's hard. You need a lot of energy, effort, and as soon as a little bit more stress comes up, you go back to your behavior before. But if we teach kids early age a healthy behavior, is it from how to eat, how to move, have regularly checkups with the health system? It's inside them, and they don't need to change, and that is far, far easier. Then we see the social and educational gradients of the use of prevention, which is then linked as well to the social determinants of health. So the richer a family is in the society, the better the health status is. And it's already, they are far more aware. They know these things. So we need to do there something with awareness, education, health literacy to shorten there the gap between the richer and the poorer families in a society. And as we have heard before, prevention is not a cost. Prevention is an investment. And WHO did their quite good work on making research on why investment in the health workforce is an investment and not a cost. I think it's worthwhile to have a look there as well and take some of these arguments, what they used. And if we really want to focus on prevention, it's a multi-sectoral approach. It's from healthcare to education to transportation to housing, all these things have to change. They need to work together to have a really sustainable impact in this. Healthcare system historically are focused on curative, on treatment of diseases, not necessarily on prevention. And that is how they are financed as well. Prevention is not really fostered there. So if I'm a GP and I do prevention, I don't get reimbursed for this necessarily. It depends on the country. As well, we need to integrate all this e-health better, because e-health helps us in delivering prevention, in staying in contact with our patients and help them. And historically, many countries have it that the healthcare system and the social system are separated from each other. They are often different ministries. They fight about different budgets. Instead of working together, really link them. So often we have it if a chronically ill patient, the situation decrease, the patient goes to the hospital, which is far too expensive. And it's on top of all this not good for the patient. If they could stay in the nursing home and get treatment there and have it through a strong primary healthcare approach, come healthcare to them, would be much better and cost-effectively. And what counts there for the healthcare system counts as well for the health workforce. So medical education focus more on curative care than on prevention. And here in prevention, the continuity of care is very important, so that different health professionals and social workers work really together as a team. Put the patient in the center and have a look what is the best there, communicate well, and have a plan around the patient. And when we talked about the education of health professionals, we are not taught anything about behavioral change. How do I help a patient to really change their behavior? As Mark said, with his GP who helped him to stop smoking. So we don't learn these things. So just finally, so it's the inability of the society and governments to adapt effectively to population aging. It's not aging itself that's likely to have the greatest impact on socioeconomic development. And most of the health conditions of older age can be prevented or delayed. I'm looking forward to our debate.
Lovely, thanks, Julia.
I stay here?
Yep, stay up. And if the rest of the panelists wouldn't mind coming up, one of you will need to bring a chair over. I apologise. But if you wouldn't mind coming up, and I'll probably come and sit down there. I think that's probably the best way to do it. Just a reminder to those of you watching on YouTube, we are very keen to have your participation on Slido. The full instructions for that are at ILC UK on Twitter. So if you look at the Twitter post at ILC UK, you'll be able to see the full instructions for participation. And it's now on the slide there. So we're very, very keen to have your input and your comments, and they will come up on a little iPad, which I shall go and get in a moment, and I will make sure I include. Actually, I have a helper who's looking at the iPad. So there we go. Oh. Well, get your comments in quickly before the battery goes. That's all I can say. Let me make a start, if I may. I'll just pick on people, if I may. John, can I start with you? Remember, we've got 5 questions that we were asked to address in this session. So I'd like you to reflect on what we've heard in the light of those 5 questions. And do you need a reminder of them, or do you have?
I do need a reminder.
Okay. So the 5 questions are the key health challenges in an ageing society. Something that Julia addressed a lot, what has to happen, and indeed that Aaron addressed, what has to happen at an international and national level to embed prevention across the life course. what needs to happen next to ensure everyone has access to vital preventative health care. The EG we give here is immunization, but as Tilly and Ed will remind us, food matters just as much. How do we adapt health policies so they can better support older adults? And opportunities and barriers for governments to switch towards a greater emphasis on preventative care.
Okay. I mean, first of all, it's great to see this focus on prevention, and it ties in with the evidence. There was a great paper that came out about 6 months ago from the nurses study in the United States, and it showed that people who adopted healthy lifestyles in midlife tended to live around 10 years more than those who did not. There was a report that came out just last week from the National Academies of Medicine on healthy longevity, and it also is emphasising the whole issue of prevention. I have to say, I think an issue is prevention of what? And I was very glad in the presentation, I can't remember which of you used the term, but it was the prevention of poor health, because too much of the focus, I think, on prevention is on primary prevention of non-communicable diseases. That's obviously critically important, but I think as people age, what is also just as important is prevention of age-associated declines in functional ability. And that requires sometimes a different focus, sometimes an emphasis on secondary prevention. So thinking about how, if somebody does develop a condition, how we can mitigate the consequences of that condition, and also how we can create supportive environments that allow people to compensate for and adapt to some of the losses that might be associated with those conditions. So that requires a focus on primary care as well as primary prevention, so I think that's really important. In terms of the broader questions, I think what's also important is understanding the new science which is happening in this field. And you know, in the WHO model, you think about the individual and their intrinsic capacity, and then their functional ability, which is the individual and their environment. I think we're starting to understand much more about intrinsic capacity. And just imagine if we framed our health systems and health systems financing around the impact that they had on intrinsic capacity rather than on throughput. And again, I was glad that people were sort of rather negative about fee-for-service models. So I think in terms of moving forward and trying to get politicians to take this on board, we need to emphasise more than just the focus on NCD prevention. We need to be thinking about integration of primary prevention with primary care, and trying to broaden the focus from disease to really thinking about how we can have an impact in the lives of older people.
Lovely, thank you, John. I mean, I think if I may, I'm going to come to Meta next, because you promised that you would help us to do exactly what John just ended on. So you promised that you would help us think about how we go outside our little circle here to the broader public. I keep saying around here, older people are much more likely to vote than younger people, so this should be easy, right? Mobilizing older people to help them achieve their life goals should, in theory, be easy. So I'm hoping you have a solution for us.
Yeah, I'm not sure it's an easy solution, but I do have some perspectives on it. I think picking up on that, and as well on how we talked about how we encourage policymakers to really take action. I think that what we are missing out on is really to bring the urgency into the conversation around prevention. It is kind of like, I think it was mentioned yesterday as well, that, you know, many policymakers tend to have this feeling of what can I achieve over the next term, and how do I actually measure that very specifically. And prevention is not always on top of that agenda, because that is the fast or the very, very slow moving train that we cannot always measure. So, and I think we could actually go beyond and look to other different types of fields to get some inspiration there. I mean, just look at the climate change movement, how they have really taken a fuzzy, long-term theme, which we didn't really all trust in, and taking that to be a very urgent, clear issue that have huge consequences on us. And we're counting down. They have done an amazing, from a communications perspective, work and advocacy work on really getting that agenda up. So how can we really do the same in terms of changing how we talk about prevention to make it as urgent as some of those issues there? And so I think that's firstly the urgency. Then I think it's around how we convey the messaging. So really making sure that we target our audience. And I was happy to see again that we talked about social media. I mean, that's one thing. Just thinking about how we reach different audiences through different channels. So we also, when we talk about health literacy, we talk about how do we actually not only what we want to communicate, what people need to know, but where do we reach them? So I think it's a really important conversation in terms of both what are the key messages and how do we target those to the right audiences, but also to which channels to reach them most effectively. And then I think, again, I was really happy to see both the healthy eating and the other aspects coming up, because I think we need to not talk about, again, healthcare. We need to talk about healthy societies. And what does a healthy society look like? Well, that's much more than healthcare. It is really about how we build, you also mentioned that, Julia, urbanizations, smart cities. It's about how we build an infrastructure that works well and also is accessible for the older populations. So I hope that that's part of what we can also do. And I think if we actually tap into that, we will also see the co-benefits. So other non-health sector audiences will also see the co-benefits of engaging in the conversation and hopefully pushing in the same direction.
So Mata, I think Julia raised the issue that there are two groups, or maybe it's two aspects to most of our lives, that one of it is managing conditions, John said, mitigating conditions we already have. The other is that issue of wanting to be fit and healthy, older people doing what we want to do. How do we turn that into media-friendly stories, and how do we turn that into asks for policymakers? I mean, what is it because it's that long-term thing of, build a healthier city and have more walking But how do we say to a politician who's facing an election in 2 years' time, this is what you can do, and this is the I know it's not an easy question to ask you, so I apologize for putting you on the spot.
No, that's absolutely fine. No, but I think it really comes down to really for the policymakers to see what's in it for me. How can I actually first of all, benefit in terms of putting this agenda up, to be very cynical. But at the same time, it's also really to see how we can, how that trickles down to other parts of societies. Because I think for most policymakers, even though they might be in a specific area, many local policymakers will need to treat a lot of different thematics. So if we can actually help them see how the co-benefits comes across, I think that's one of the core things that we need to address.
Can I just add to that? Because I think one of the things we have to tackle first is this pervasive ageism, which has policymakers framing any expenditure on older people as basically a bottomless cost with no return. And we really need to help. To start off with, we need to get people to reframe that way of thinking and understand that people contribute across the whole of the life course. They contribute in all sorts of different ways. And I think, as we were talking about yesterday, trying to quantify that and communicate that so people understand that's not just wasted money. That is an investment, and the return has benefits for older people, but also for society more broadly.
And I mean, the kind of nastier side of Julia's slide about the demographic transition that's taking place is we have to have lots of older people who want to keep working either full or part-time, or our societies are going to fall apart because we have this transition happening all over the world. So there is a policymaker interest. The problem is it's exactly what Meta said. It's that long-term, I know I have a problem in 20 years, but I have to get re-elected next year.
The problem with that argument, when you're focusing only on engagement in the formal workforce, is there really is probably an age limit to when most people will want to continue to be formally employed. 70, let's say people decide at 70. What are the next 30 years? Are they a waste? No, they're not, because older people, whether they're in the formal workforce or not, contribute in a whole range of different ways. So we have to, I agree, but we have to make policymakers also understand it's not just about how long can we keep people in the formal workforce. There are broader returns on those investments.
Yeah, I mean that presentation that David made yesterday, right? The value of the voluntary work done by people over 70 and the way that it empowers people in their families to come back.
Can I jump in on that?
You can, and I want you to jump in. Actually, I want you next to jump in. So yes, jump in now.
What did you have a specific question?
Well, no, jump in on this, and then I'll put the question to you later.
In relation to the nature of our organisation is that lots of older people themselves are volunteers, and I think that plays a huge role in this kind of asset basing the opportunities. And Scotland is launching a volunteer framework in a few weeks, and I think that's going to be a huge part in recognition of this. What else can people give? It's not just about that monetary return, and being that really asset based and thinking back to the contribution of a volunteer and how that is really important in relation to the wider social determinants of health and tackling social isolation and loneliness and this kind of wider challenge.
So what I want you to come back in a bit more on is expand on what Ed was talking about there, a bit about the work of the organisation and how we start to look at this question of, I don't know whether I think malnutrition covers both under and over nutrition, right?
Yeah, so but specifically we work to tackle undernutrition. So in the UK we know 1 in 10 older adults are malnourished, and our data suggests that could be higher in Scotland at up to 30%, and particularly individuals who are in receipt of social care. It's got this wider complexity and vulnerability. But also we know at the same time, I think, as we've said, I hate the framing of being really negative. I think we need to be really asset-based and see all the opportunities that food can enable. And food really is this really powerful tool that we don't often frame it in that way. We think of all the challenges rather than opportunities it can give us. So we've done so much work over the past 4 years, but over the past 25 years, and this wider challenge around how food can play a large role in health. But it's not just physical health, it's mental health and well-being. And I think the COVID-19 pandemics really emphasised the social isolation and loneliness challenges that people face when they were told not to leave their houses, and kind of this broader challenge. But most recently, I particularly work in our policy work. So Scotland has been a bill called the Good Food Nation Bill has been going through Scottish Parliament. So we're really working to kind of take this whole system approach, linking food and health, but more broadly than that. So I sit on the Scottish Food Coalition, so that's not just health-based organisations or anti-poverty organisations, it's also environmental organisations, and how we can all work together to transform this system. And that's a real need to shift this thinking to policymakers about how does this all connect. We've got to have these conversations for them to see, actually, this is really valuable and this is really important. It can't just be kind of expecting that to be them. But yeah, I think that's really important. And it's got to be throughout the life course. So we're obviously here talking about healthy aging, but as we've discussed, it's not just about what happens when you're over 65, it's what happens in your school. How do you have that relationship with food, and how is that harnessed as a 5-year-old when you first start education? We've got to have this broader interconnected approach, and really that framing, it comes back to, I think is really critical. So we know that the social value of food, I think, is where we've really got to harness that social opportunities and shift our framing to be more asset-based.
I want to include some other voices, so I think we're going to go to the break. We started a bit late, so is everybody calm if we go to the break a little bit late as well? Yeah, okay, great. Let's get some other voices in on any of the topics we've raised. Daphne. And then
Yes, just on the point that was made there. This is almost back to the future, isn't it? Because when I was at school, they taught us how to cook.
Yeah, me too.
Yeah, exactly. And lots of other things they taught us, but that's all stopped. Also, I suspect it might be cultural, because now I live here in France, but the school meal with 3 courses is very much part of the social activity. So that we need to refocus all our thoughts as to how we can. So education comes in as well as health and everything.
Yeah, I think a large part of it is not just what we eat, but it's how we eat, who we eat with. Yes. It's that wider context, and we really need to be emphasising that. And that school meals is a prime example, but it's like, how can we connect that? How I mentioned yesterday about intergenerational. So is there an opportunity to have intergenerational dining? For instance, Dunbar Grammar School, I mean, if you're not in the UK or even Scotland, you'd have no idea where that is, but they have set up where the students learn to cook and then people in the community come in and they share a meal together. They maybe share recipes, they share stories. It's having opportunities like that. And I think that's really framing that. And that links back to the idea of after you've maybe finished in a formal work capacity, but how else are you contributing to society beyond that formal economic contribution? And that's really important in people maintaining that a sense of independence and wider contribution.
Although the what you eat, I think, matters. And our home economics teacher was nastier than yours, I think, because she made us cook the food, and then you weren't allowed to eat it till you told her, to her satisfaction, what the nutritional value of it was. And then you could eat it.
Yes.
So she'd stand there and make you watch it.
Yes, and also we were obliged, as it were, to cook for a group. And we had the facility to do that. Can I also make another point?
Yeah, and then I'll come.
The idea of what do we tell policymakers? Patrick and I have to we are speaking to a group in the European Parliament at the end of the month. And one of the questions that we've been asked is, what can you do for us? And a lot of what we've heard today is exactly what we need to be telling them, essentially. And it is very much about getting re-elected, that's for sure. But if we want them to take it back to their national parliaments, then we have to have something to tell them. And once again, CLCI went to a meeting in the Irish Parliament, in the Dáil, last month. And the one thing that was picked up on there was the fact that Ireland spends just 0.2% of its healthcare budget on prevention. And we had a senator there, and he went straight back to the Senate and asked for a debate on this. So if you tell them what it is that you want, what you need to do, then they've got something to act on. And it's ammunition. That's all of this is ammunition.
And it's super specific. Yes, and then I'll come back to you if I may, Ed. Sorry.
Julia, I'll be super quick. I'm thinking about the conversation on, how can we frame what we're talking in a way that continues to respect a human rights approach? And I say this because, and it has to do with what you discuss about work. I understand completely the argument about the return of investment and why do we need to make that argument, and that is very important. But I guess my question to the panel is, how do we balance that with the argument that, well, an older person has the right to health and to have a good quality of life, regardless of whether it is contributing officially, whatever that means to our society. And that also relates, when we talk about the right to work among older persons, we also have to think of the right to retire, but we also have to think that around the world, most older persons actually work in the informal market. So retirement ages don't matter, and they just work until they can. So how do we make sure that we balance in our discourse the need to make the point that there's a return in the investment of countries, but also to keep defending the fact that this is a human right. So regardless of whether there is an investment or not, we have to fight
so
for
we
that.
don't mix up the supporting arguments with the principle.
Yes.
Yeah. And John, I know you were trying to come back in, and then I'll come to Ed. Were you trying to come back?
No, I wasn't. But I'll just respond to that
very,
very quickly, because the Decade of Healthy Aging, WHO's Decade of Healthy Aging, and going back to the World Report on Aging and Health, are very much rights-based documents, instruments. So I think they provide a useful model for doing that.
Lovely. Ed, and then I'll get you as the last comment, then we've got two quick wrap-up comments.
So everyone's saying this, but two genuinely, hopefully quick points. So the first one being, I think today is great discussion, but we've spent a lot of time talking about how do we get people to do things. So how do we get people to go for a blood pressure check or accept a vaccination, or how do we get them to cook more healthily? But I think with specific focus on food, we also need to think about how do we get people not to do things, because we live in a profoundly obesogenic environment. So all of the defaults and incentives, I'm mainly speaking about Britain here, but incredibly strongly aligned basically with people putting on weight and being very sedentary. And so what policy interventions are there to stop people making those choices in the first place, often by not even offering them? So it's not even a question of persuasion or empowerment. It's simply that we change the defaults. And I appreciate that's a very high level policy question, but I think we need to think about that. The second point is around advocacy for public health issues. So I wonder whether in the public health community, I think we often say that it's difficult to make the case because the time horizons are so long, but actually there are lots of examples of investment in long time horizons in the public sector. So we're building a very controversial railway in England at the moment, which is going to be operational in about 30 years' time, but it's still being funded. We've got massive funding action on climate change where the dividend will, well, some of it will be now, but some of it will be in many years' time. So I wonder whether there's an element of learned helplessness in the public health community whereby we've convinced ourselves we can't make the case, and so we don't do it. But actually, I think evidence from other areas of public policy shows we can.
And actually, David, I think a footnote for the next time, talk about behavioural economics, because there's a whole set of nudge interventions which have worked really well in food. You know, and people made fun of Mexico when they first started doing it. It's worked really well. Yeah.
And perhaps just to come in on that, I think so one of the things that, you know, when we were going into the office, we had a habit, because we didn't have a meeting room, we were going into Cafe Nero and having a cup of coffee. And we tried to sort of say, well, let's start doing walking meetings. And I think one of the sort of the challenges you need to do both the encouraging, basically there's two actions you need to address. One is you need to encourage me not to want to go for a cup of coffee, and the second one is you need to encourage me to want to go for a walk. So actually the challenge is twofold, not one, that you're actually having to address stopping someone doing something and encouraging them to do something else. So it's actually more complicated than just saying go for a walk, because actually I really want that cup of coffee.
That's not a default, though, if you have to go for a walk. The default is removing the escalator from the tube station to take the stairs. So.
And by the way, one of the rare pieces of unqualified good news, up to 4 cups of coffee a day protect against heart disease and cognitive decline, which I have to say made me more happy than anything in recent times.
Okay, thank you. Following what Matt has said and Julia, I think a question which arises, there's a good reason healthcare systems are set up to treat, right? Because it's our moral obligation to help someone who is in need of treatment. So my question would be, there's also moral obligation to save the planet, right? For climate change. So what is our, maybe the way of thinking, what is the moral obligation to prevent disease, right? And how do we phrase that maybe better?
Yes, and that we start to talk about it as one of those moral imperatives. Look, I think we could keep going for long. Quickly, Matt, come in on that.
Yeah, I just want to jump in on that, and I think we need to go actually on beyond the moral obligation and to look much more on also what's in it for the different sectors who want to engage, right? So it's about, you know, what are the benefits for me to see a healthier society? Well, you know, there is a stronger buying populations. There's other elements. So I think, you know, we need to separate those things. There's human rights, there is, you know, the benefits for different sectors, there's moral obligations, and we can cater different communications to them all, but we need to, I think we actually do need to, attack them all.
And indeed, you know, global heating, of course, everybody sees the green economy, sees opportunities as well. So look, we have a quick wrap up on this session from Kate Pierpoint and Les Mayhew, who are joining us remotely, I hope. I'm waiting and looking. Miraculously, they should appear. They might have given up on us. No, there they are. Great, lovely. You're going to give us a quick wrap-up on the session. We do have to answer it to be quick because we're running late. But let me hand it over to you to give us a few final thoughts. Do you want to start us off, Kate?
Thank you, Mark. Can you all hear me all right?
Yes.
Good. Hi there. My name's Kate. I'm the head of projects at ILC. Joining remotely here today. I can't quite see you all, but I can imagine you're all seeing this. So we've had some really interesting and inspiring presentations about how we can better deliver prevention in the future. But I wanted to just very quickly share with you the ILC's commitment and aspiration for the future and what we think should happen next. We really want to drive forward the policy recommendations that Aaron and Lily have very well and thoroughly gone through this afternoon. We want to encourage more investment into systems designed for prevention, inspiring and engaging policymakers and healthcare professionals, and improving trust and confidence among individuals, democratising access to prevention and using technology more effectively. So I think the ILC team has done very well over the last 2 years to really establish itself at the forefront of this agenda and build strong relationships. So we think that this sets us up nicely with a very exciting programme, which we envisage to be a multi-year programme, to really take forward those recommendations. We want to develop something we're calling the Global Health, Wellbeing and Prevention Index, to track population health, not just through a health lens, but through an economic and environmental lens. We think this offers a holistic and unique perspective not currently offered by existing tools. If you just jump to the next slide. And we have 3 aims really at the heart of this new programme that is
So Kate, you've frozen. We can see your slide.
Yes.
Shall we give Kate 5 seconds more to come back?
We lost Kate. We're going to try and get her back online. Just a second. Oh, she's back.
Okay, Kate, we lost you there.
My apologies. It's been fine all afternoon, and now this is the time that it drops. That's great. So we've got 3 aims of this new programme, and our vision is to really sit at the heart of global policy and political engagement on prevention and vaccination. We want to develop this index to be a catalyst for change at an international and national level. We want it to be recognised. We want to measure progress and good practice. We want to use it as a tool to analyse the data. And we want to build a coalition of the willing to build consensus and hold governments to account and facilitate that tangible change. So today, and this summit really is a sort of first step in achieving those ambitions, really. So I encourage you all, if you haven't already, just to take a look at our Annecy Declaration, to lend your comments, to lend your support, and to also contact me or anyone in the team if you're interested in getting involved and taking part in the next, hopefully, 3 years of this programme. But I'm going to pass over now briefly to Les. The index really is his brainchild, and he's done a tremendous job to develop it to where it is currently. So I'll pass over to you.
Thanks very much, Kate. That was a great overview. Not too much that I can add to what you've just said, but I suppose the motivation for this came about during the first phase of the prevention work, where we were rather inundated with data, lots of detail, and quite difficult to sum it all up and make sense of it, and ask questions like, how does this information change the prevention landscape? What does it mean about healthy lives, active lives, rewarding lives, and whether these lives are sustainable or not? So looking at a bit more detail around the organizations and institutions around the world that are producing this data, they tend to be very focused, either the World Health Organization, obviously on health, the World Bank more on financial security, GDP and inequalities, and so on and so forth. And there seemed to be a gap for something, or crying out actually for something that would summarize what I've just been saying in a few indicators that are easily digested, can be compared against other countries, against themselves, and so on. There's not time to go into a lot of detail about how we interpret all these indicators, but they cover the following 4 dimensions: life expectancy, health expectancy, working life expectancy, income, and the environment. There's scope to add more dimensions to it, and we're looking at other possibilities as well. But it's incredible how much those 4 dimensions provide you with tools to drill down and compare all the sorts of things you want to do. Now, we don't just stop there. This is the top level indicators, which give you a gateway into lower level indicators. So you can, for example, challenge a huge gap in health expectancy and life expectancy in this particular country or group of countries. why is it that working life expectancy always seems to be less than health expectancy? Is health expectancy the real challenge, the real problem here that needs to be unlocked? To what extent does spending more on health, government expenditure on health, improve health expectancy? We saw earlier an interesting chart which showed that increased share of public expenditure does seem to have an important impact on life expectancy. So the aim now is to launch this information, this indicator, as part of the next phase of the prevention work. And what you'll see when you go into it, at least in the early stages, is an overview of this global index, and you'll be able to select different countries and different groups of countries to be able to compare them. And then in subsequent iterations, we'll be developing the next layer of indicators and the next layer of indicators, all the time focused on prevention and on giving clear messages to health agencies and health policymakers around the world.
Lovely. Well, thank you, Kate, and thank you, Les, for that thoughtful summing up and for pointing us in a way forward. And I think we shouldn't underestimate, I'm looking at Meta here, but we shouldn't underestimate the power of indices to motivate policymakers and the public, because people love to be at the top of them and hate to be at the bottom of them. So, yeah. Lovely. Look, we're going to take a break for 15 minutes. If we could be back at 4, that would be lovely. And are we doing the walking shop? Yes. So we have a session and then we have our workshop. So you might want to use this time to grab your shoes or whatever. Yeah.
I think there'll be a short break after.
Short break after that. So okay, lovely, very good. See you at 4. Thank you, and thanks to all the speakers.
whole community of.
The Welsh National Health Service doesn't have a lot that does right, but one of the things that does right is, in theory, if you don't have an imminently life-threatening condition you can't go to A&E, you call up and you talk to a nurse, and the nurse either says, take a paracetamol, drink some antibiotics, you'll be fine, or the nurse sends a doctor around, or the nurse sends you to an urgent primary care centre, or the nurse says, yes, I'm sending an ambulance, you go to A&E. But in theory, you can't walk into A&E unless your arm is hanging off.
So you need the chairs here? Because there is a lot of fan here.
Oh, yeah, let's move them then, because actually we've only got Aaron and Sean, and they can go, yeah, we can move them away now.
Okay. You have more hair. I will do it.
That's okay.
was supposed to be medication
That was
reviews, but
working in as an emergency room.
Surgery, junior health doctor. But it was the only country, the only one, and I have heard from my friends it's not like this anymore. I was working in the golden time with the NHS Europe monitoring system. Amazing. And you know, the cost of this 1 hour meeting was how much we would have spent. So this is an evident case.
All of them. Enjoy them, but you know, it's all presenting all. I rarely ever present all of them in one day. That's never happened. No.
Just like the entire portfolio just being spilled out. I mean, you want me to talk about structural heart disease because I did a report on that too. I might as well just go about that. And who do you feel that? Yeah.
Do you take it in here?
Right here. Sorry.
Yeah, my taking
So yes, we read them ourselves. So yes, I read these reports, and then we have a copy after that. Makes it look nicer. Make sure you know consistency.
Yeah, what about food?
Everybody's going to hear, it's okay. Hello, Clara, you should be able to hear me. Just inform you that we are going to run late, 5 to 10 minutes.
Nice having you.
This is Sean.
You look fantastic for midnight, thank you.
Hi, John, thank you.
Okay, thanks.
Great. I think we've got everyone. So this is our final sort of formal session for the day. We've spoken a lot today about the role of prevention, so be that through things like immunization, through helping people manage conditions and so on. And this session we're really going to look at what happens after after someone has suggested something, after someone's been prescribed a medication. What happens then? How can we make sure that people are actually empowered to use those tools and continue healthy lifestyles? One thing I wanted to quickly mention before we start off, Kate alluded to it in the last session, is we have got over there on that board for everyone who's here in person a short declaration. So what we want to do really is that while we're coming together here and sort of in preparation of next steps and working together, we want to sort of ideally bring us all together under a few kind of common shared aims. One which is around, generally pushing for a more preventative approach to health, tackling health inequalities, helping different healthcare professionals to work together, and using tech better. So do have a look at some point today or tomorrow and see if you want to put your name to it. Obviously, it's not compulsory, but so that's back there. And finally, we've got a little workshop later. So Lake and all its surroundings, do come along, where we'll also be talking a little bit, sort of beyond the sessions here. What does it mean for each and every one of us? What's really tangible actions that we can take? And so we'll take that sort of forward from sort of reflecting a little bit on everything we've learned today, what we can do tangibly. So I will now move straight on to our first speaker, so Aaron Himmelman, who you've heard already today from ILC, is going to share a little bit about the report we published recently with Amgen on essentially, what happens once something has been ordered, prescribed, and how we get people to adhere to that. Over to you, Aaron.
Hi everyone again. It's nice to see you. Great. So really excited to be presenting on this this report on medication adherence. And we've sort of touched on the topic a little bit today already, and I was trying not to say anything too much because I wanted to keep it for this session. But I think, it's really great to hear that people are talking a little bit, at least in this room, about the importance of medication adherence. We tend to focus on, how do we get people through patient doors, GP doors, but what happens afterwards once they are, once they have a treatment plan in place? It's actually a huge part of the prevention program and ensuring people actually can stay healthier for longer by following their treatment plan, their medication plan. That's, a vital part of the sort of prevention puzzle. So today I'm going to run through sort of the top findings from our report, which sort of focused on 3 chronic conditions, but I think the lessons can be expanded to all sorts of medications. I think we spoke to a lot of key people from really across the world to understand why adherence is so important and what can we do. One of the key messages is that we know that medication adherence is good not only for our health but also our economy. As you can see, huge amounts of money being lost each year, for instance, in Europe, due to non-adherence to medication. And when we put this into context, thinking about the fact that nearly half of all adults worldwide have at least one chronic condition, this really lets us get a sense of the scale of the problem. The potential where people are being non-adherent is significant. And like I said, we know that medication adherence is poor for these conditions, and so estimates really sort of range between the under the 80 to under 50%, which is that's really, for me, I found when I was doing this research, really surprising to see that, because in my mind had always thought that this should be the easy part. Once someone's prescribed a medication, they have a treatment plan, that should be the easy part, but actually that's not the case at all. So before I just go into too much, I just want to talk quickly about what do we mean by adherence, and we've essentially taken the WHO definition here, so the extent to which a person's behavior, so taking a medication or following a diet and or executing lifestyle changes corresponds with agreed recommendations from a healthcare provider. And non-adherence is usually defined as taking less than 80% of a prescribed dose of medication. But we should really think about, whenever someone's not taking their medication as prescribed, as that being an issue and of relevance to the adherence, the topic of adherence. So what we know is that when we kind of study adherence, there's a lot of clinical trials that are that exist, but they don't really give us world insight. The barriers that people face usually don't experience those barriers in clinical trials, so we don't necessarily know what's exactly going on. We're not capturing, we don't have that full. We're not capturing all of the experiences of people with taking their medication. We also have issues in terms of measuring adherence. Often it is done through self-reporting, and so people might forget how often they take their medication. They might overestimate how often they take their medication, and that gives us false results in terms of really addressing the issue. And there's also an issue in terms of how do we actually separate the act of taking, of intent of taking medication and actually doing so. For instance, we have technology has now enabled us to have packages where we can see when someone's taken, medication, but just opening the package doesn't mean that they're necessarily actually ingesting the medication. So there's a bit of we're not capturing the full issue again. So these are things that we have to think about, and this doesn't make it easy for us to actually solve the issue of non-adherence. So, like I said, what affects adherence? We tend to focus on the patient rather than the system, but actually there are lots of different system barriers that are in place. So everywhere from sort of the socioeconomic, social determinants of health to the individual patient. And if we're going to address adherence, we need to be tackling every single level of these. And so I think, when we're thinking about adherence more generally, we really just have to make sure, when we're talking about this to policymakers, we have to really sort of demonstrate and emphasize this, the fact that this is a systems issue, not just down to the individual, whether they want to take a medication or whether they don't. We also have to realize that medication adherence is also quite susceptible to the life course of a person, people's experiences, their I guess life events can change. They have various life events during their life course, and this can impact medication adherence. So, if they have a child or if they've lost their job, all of these things can maybe have an impact on adherence. And really understanding how these life events affect people is really important. So moving on to sort of how do we actually improve adherence? So from our stakeholders, one of the key messages was that we needed to take a tailored and a person-centered approach. Individuals must be aware of the condition that they have. They must recognize the important role that adherence plays in maintaining their health for that condition. They also have to recognize the long-term side effects of being of non-adherence for their condition. Without understanding this, it's going to be quite difficult for individuals themselves to even recognize the importance of medication adherence. We also have to think about polypharmacy as well. What we find in the UK is that more than 1 in 10 age 65 or over are prescribed at least 8 different medications, and this goes up to 1 in 4 for those 85 and over. So how do we support medication adherence? And clearly there's a role for healthcare professionals to have that conversation with individuals. I mean, it sounds quite, it's definitely an issue that a lot of people face. But whether these conversations are actually happening, I think that's the big, we know that they're not to the extent that they should be. And we also have to think about things like dosing patterns, whether someone has to take a medication daily, weekly, monthly. All of this can, again, impact adherence. And what we also want to do is not just focus on the medication. We want to look at the person itself. And so some studies have shown that things like gender, socioeconomic status can impact adherence, but also things like how many healthy behaviors that someone can take. And these also seem to be clustered. So for instance, someone who has decided to quit smoking is also likely to adopt healthier eating behaviors. So understanding how many, I guess, lifestyle behaviors people are willing to adhere to, there is a limit to that. And we also have to think about that in the context of asking someone to take another medication or to adopt another healthy behavior. There's actually a limit to what people actually do. So using behavioral science is obviously one way in which we can address adherence. Taking medication, maintaining lifestyle changes obviously involves people's behavior. So ideas from behavioral science can help deliver more sophisticated approaches with better results, but applying behavioral science is not a quick fix, and there's a lack of consensus among experts as to what actually works. And I think one clear thing is that whether it's large-scale population interventions or nudges for individuals, we really just need to understand the issue better. And we also have to think about what kind of framework we're using for behavioral science, because it isn't necessarily just, sending a text message to someone to remind them to take their medication. We need to think about all the different factors, and there's lots of different frameworks that can be employed. One, which is called the COM-B framework, which suggests that people must have the right physical capability, social and physical opportunity, as well as motivation. So whether a desire or need to actually change the behavior, and these all interact. So we need to be thinking about what sort of intervention are we going to use to actually improve adherence, and thinking about these different factors and the way they interplay with each other. So moving quite specific now to incentives, and I think the reason that we included this was obviously because it's quite topical because of the pandemic. And it's really just taken center stage, and there's been so many different types of ways in which we've tried to get people to be vaccinated. But our stakeholders do suggest that while they do work, they may be unethical. So, for instance, lotteries, people tend to overestimate the likelihood of their winning a lottery. So we need to think about this. And there's one clear negative or drawback to incentives is that it does not address the wider issue of co-payments. If someone is taking several medications, the costs to take those medications quickly add up. So we need to think about how can we actually widen access so that people can actually take their medication and cost isn't a barrier. So there's clearly different actors that can be involved to support adherence. And first is the role of healthcare professionals. Unfortunately, adherence isn't really considered a priority for by healthcare providers. And what we know is that healthcare professionals need the requisite skills and knowledge to support people with behavior change. But the problem is that they actually don't receive much training on this, so they're not having these conversations with their patients. And there's also an issue in terms of ensuring that healthcare professionals tend to overestimate the tendency of their patients to actually adhere to their treatment plans. So they really need to be having these conversations with patients. They really need to be educated more on adherence so that they can actually recognize that this might be an issue that's happening with their patient and they can address it. Adherence needs to be tailored to suit each person with the chronic conditions, and so that really should be the focus of the healthcare systems. There's also a special role for pharmacists, and we've talked about pharmacists a little bit today, but they can clearly play a role in adherence. They're in our communities. They're highly accessible. They understand the benefits and side effects of and the risks as well of the medications that they dispense. And there are some examples of good practice in other countries. So, for instance, in Quebec, in Canada, payments for complex medications and medications treating more complex diseases, pharmacists are given more, are incentivized to spend more time with these patients. So that's actually a really great way of actually enabling pharmacists to support patients, because the issue is that oftentimes pharmacists are just not incentivized to do this. So we really need to make sure that it's underpinned by greater investment as well. So the role of the government, there is the role of government and healthcare systems in supporting adherence. And adherence, unfortunately, is overlooked by many governments around the world. And across the OECD, only Sweden measures adherence at the national level. So governments need to really support healthcare professionals through greater funding. And there's clearly a case that needs to be made to governments for them to recognize the importance of adherence. So there's also, finally, the role of technology in supporting adherence. And again, COVID, I think, has really shown how important technology can be in supporting good health. But technology has also shown to support adherence. Opportunities, particularly in terms of online consultations, may open doors to better support medication adherence. It's low cost, and it also opens accessibility barriers for individuals. So people might not want to go see their GP on a regular basis to talk about adherence, but if they can just have an online video consultation, it might make it much easier for them to have these conversations. We cannot forget that access to healthcare records is crucial in supporting adherence, not just for the healthcare professionals involved in actually supporting the patient, but for patients themselves. So both need to really be involved in that. Have access to patient records so that they can, so individuals can take control of their health and healthcare professionals can actually provide the right sort of treatment plan and support that they need. Great, so I'm just going to move on to our recommendations. And so we have quite a few, and as you can imagine, they sort of are for governments, for healthcare providers, universities as well, thinking about how we can reduce inequalities, how we can actually inspire and engage, and how we can use technology more effectively. So the first thing that we want to see from the government level is for them to fund annual medicine reviews to help people with chronic conditions with decision making and any identified gaps in care, and report on the number of medicine reviews conducted every year across different demographic groups. And this is really fundamental. Without these reviews, it's really difficult to have any conversation at the population health management level. We also want to see governments doing more in terms of addressing costs, so preventing co-payments from causing a barrier to adherence. As I said, evidence shows that they can hinder people from taking prescribed medication. We also want to invest in healthcare professional training programs on behavior change to supply workers with the requisite skills and knowledge to support adherence to medication regimes and lifestyle behavior programs. And there's also a role for universities as well to ensure that undergraduate curricula for all healthcare professionals include an adherence topic. So, when it comes to educating healthcare professionals, not just those who are already in the profession, but those who are training need to have that that education in place so that they're able to have these conversations from the beginning with their patients. And there's also things that can be done in terms of inspiring, engaging. At the government level, we need to be promoting and prioritizing adherence as an effective disease management tool by including a national and chronic disease strategies. So, for example, those for CVD, osteoporosis, and diabetes. Adherence is just a topic that's just not included at all. So having that included in these national strategies is really going to be important, just to have it as a priority and just to have it on the agenda. Governments also need to be setting metrics for acceptable adherence rates and measure and report on adherence rates for chronic conditions. So again, including cardiovascular disease and diabetes and osteoporosis at the national as well as subnational level. And in countries where medicines are funded from public money, measures could be implemented to assess divergence from acceptable adherence rates, and appropriate metrics set to ensure value for money is maintained. Without tracking this at the national, subnational level, there's no way for us to actually address the issue. So this is, again, really important. We also have to establish government should also establish behavioral insights teams, and the UK has done this. But there should be a focus on health and research and the effect of using different incentives to encourage people with chronic conditions to adhere to medication and lifestyle changes. Again, like I said, behavioral science is definitely part of adherence, but we need to understand it better and actually identify what works and what doesn't. Government should also expand the role of pharmacists with concomitant resources and funding to allow these professions to support adherence, monitor the signs for non-adherence, and conduct medicine reviews. Again, like I said before, it's really important that the structures are in place and that pharmacists are reimbursed for doing this. We also have to recognize that we can't overburden healthcare professionals without that proper funding. And we also need to fund real-world randomized controlled trials of interventions to improve adherence and ensure that these are formally evaluated. Again, when these are done in the clinical setting, we're missing out a lot when it comes to what is actually impacting people's behavior. And we also, there's also I guess there's also something that can be done at the global level by the WHO. Publishing annual adherence rate results with comparisons between countries. We've been talking a lot about holding governments to account and tracking progress. This is something that should be happening for adherence as well. And healthcare providers should also be using learnings from research on the different adherence trajectories for different groups with chronic conditions to develop tailored interventions for people at greater risk of non-adherence. And explore, as well as also exploring using the COM-B model to develop interventions that support individuals to adhere to their medical directions. When it comes to technology, again, there's quite a lot that can be done. Governments should really be investing in research to test how things like technology, including wearables, can improve adherence. There's lots out there, but we really need to start looking at what works. Invest in the collection and management of electronic health records, including supporting de-identified assessments of patterns of use and care. And we also have to ensure that health records are linked across all healthcare providers, both private and public. Easier said than done, allowing everyone involved in an individual's healthcare delivery to access that person's medication record with appropriate permissions. Hopefully this, and I mean, I think the argument for electronic health records is there's quite a big one. It can help for lots of different things, including adherence. So I think, if anything, us pointing this out can add to the many reasons for why governments should be really investing in electronic health records. And we also have to ensure that people with, chronic conditions can view their health records easily. And also thinking about, how can we expand these health records, including more information and advice that people can use as a tool to help them with medication management and adherence. And then finally, also, healthcare providers should be building on the increased use of online consulting during the pandemic to deliver more regular virtual follow-up reviews to check medication adherence. Again, really important, and I think probably a missed opportunity if we don't leverage on what we've developed during the pandemic. All right, so I'm going to leave that here. Thank you so much, and speak later on the Q&A. Looking forward.
Thank you, Aaron, for a really insightful presentation. And I remember when I read the report for the first time, and I was really shocked that, really as much as 50% of people aren't following their doctor's orders. And I think, Aaron, you made this point really well, that it's not about placing blame, that people should be able to, but actually thinking about how we can make it much easier. And I think, again, this clearly is sort of very low-hanging fruit. So when we're thinking about, all these questions earlier on about where do we get this additional investment from, this is clearly a place where we can save. So brilliant. I'm going to pass over to Clara Marquina from Monash University, who is joining us from Australia today. And I think it's something like 1 a.m. or something. So thanks so much for joining us. Over to you.
Thank you. It's my pleasure to be here. Yes, it's not quite 1 a.m. yet. It's half hour past midnight. I don't know if there is maybe some sound. Okay. So yes, hi everyone. My name is Clara Marquina. I'm a research fellow at Monash University, and I had the privilege to contributing to the adherence report that Aaron just presented. Matteo, can we go to the next slide? Thank you. So for today's talk, I thought that rather than to talk broadly about adherence, I could maybe present some example of the pathway that we see in between adherence or poor adherence and patient outcomes. And I'm going to focus on cardiovascular disease and on cholesterol because we have done a lot of work in that area. But I want to say that the concepts and the ideas that I'm going to present are broadly translatable to other diseases and other risk factors as well. And I hope that, even though it's going to be briefly, but maybe we can get some new ideas about how to talk about adherence and why is it important with patients and clinicians. Next slide, please, Matteo. So the first study that I want to present is a study that we ran in Australia to evaluate adherence to statin therapy. And it's really the study that kicked off the rest of the project in our group. And in this study, next slide. In this study, what we saw was really not surprising, and it really matches what Aaron was saying before. As you can see, 3 years after initiating statin treatment, 40% of the patients, or almost 40% of the patients, were already non-adherent. And within 5 years of initiating statin treatment, 50% of the patients were non-adherent to statins anymore. And while this was not surprising, and it matched our expectation, and it matched what we have seen also in other countries, in Europe, in US, Canada, Japan, for me personally, from this figure and from this data analysis, what was really surprising and what I thought it was really something that we should look into is that in the first 6 months, so that is the very first bars, within that very first half of the year, we had already lost kind of quarter of the patients. So 24% of the patients were non-adherent, even during the first 6 months after initiating treatment. And I think for me and for our group, that was something that tells us we really have to go and dig a little bit deeper into this issue. So the next thing that we wanted to do was to say, okay, we see that we have an issue with adherence, definitely with the statins. Is this something that translates to cholesterol levels and how patients manage their cholesterol levels? Next slide. So after this study, we ran a couple of studies where we evaluated LDL-C cholesterol therapeutic target achievement in patients treated in the first study only with statins, and in the second study, we were lucky enough to have combination therapy data. So we could also evaluate therapeutic target achievement. So basically, we were evaluating these people are treated with lipid-lowering medications. Are they lowering their cholesterol? Are they really achieving therapeutic targets? And I have to say that in Australia, the therapeutic target for lipid lowering for cholesterol is 2 millimole per liter, which is quite higher compared to the new European guidelines. So, I mean, it's not really like a very hard threshold, or it shouldn't be a very hard threshold to reach. But what we saw is that for statin-treated patients, almost 60% of them did not achieve therapeutic targets, and that was even worse if we look into females. And if we look into combination therapy, it was kind of the same. More than half of the patients did not achieve therapeutic targets. And this was relevant because it linked directly to what we saw with adherence. And basically, of course, there were other factors as well, and we discussed that in the papers, the fact that there is some individual response to treatment, and the fact that there is population heterogeneity and different population subgroups may react different to the treatment. But the reality is that 60% of these patients were not lowering their cholesterol. And we know that adherence had a very big role to play into that. And the key message from this paper, or from these 3 papers, is that adherence really translated to poor therapeutic target achievement, which basically means these patients are not lowering their cholesterol levels, which basically means that we are not lowering their cardiovascular risk. Now, once that we had this data, we thought to present different scenarios and to play around with mathematical models to show what would happen. Thank you, Matteo. Before focusing on these graphs, I want to discuss a little bit about the concept of cumulative exposure and cumulative risk. I think intuitively it's a very easy concept to understand. So the longer that you're exposed to a hazard, the longer that you're exposed to a dangerous element, the higher your risk of developing an adverse event in relation to that exposure. And I think we see that very clearly with smoking, or we see that very clearly with exposure to pollution. And it's very, I think, straightforward to understand. However, traditionally, this has not been the case, or we have not looked into physiological elements in the same way. But what we know now is that high levels of cholesterol or high blood pressure actually also work in a cumulative way. And this is really relevant when we talk about adherence, because if they work in a cumulative way, it means that the longer that you're exposed to the hazard element, which in this case is high levels of LDL-C cholesterol, the higher the damage to your system. And the higher the damage to your system, the more complicated it's going to be to reverse it, if at all possible. So basically, all the time that you are not being adherent and all the time that you are not achieving therapeutic targets, is time that your system is building up on the damage. So with that idea in mind, we develop these different scenarios. The green line that you see at the bottom, it's basically what will happen if you have LDL-C cholesterol uncontrolled for a couple of months. You go to your GP, you start your treatment with high-intensity statins in the first graph, or with the statins plus ezetimibe. And in the vertical, we see the mean cumulative LDL-C levels, and in the horizontal, we see BH. And as you can see, especially for statins plus ezetimibe, the mean cumulative levels, so the buildup of LDL-C in your system, remains quite stable if you do not allow it to be uncontrolled for more than a few months, right? Now, the next line, which is the pink one, sorry, Matteo. I mean yes, the next line, the pink one, that is what happens if you delay that process for 5 years only. So if you have uncontrolled LDL-C for 5 years, and then you control your levels, you're basically never going to go back to what will happen if you were controlled overall the whole time. And this gap that we see in the graph, the gap in between the pink line and the green line, is actually the lost therapeutic benefit, is the lost benefit for patients that are not benefiting, are not achieving benefits from the treatment, even though they are being treated with lipid-lowering medications. Now, these two scenarios we modeled, we did a mathematical model and we projected in time, but sadly, the yellow line is what we saw in our real cohort. So that is what happened in the standard of care in the patients in Australia. Basically, their mean cumulative LDL-C levels are always going up. Even though they are being treated, we know that mainly because of adherence, but also because probably other reasons, but they are not getting their LDL-C levels controlled. Next slide. And this is important because it translates into cardiovascular risk. So here we see exactly the same pattern. We see that people that control their LDL-C levels immediately, they are going to be always at a lower level of cardiovascular disease compared to people that have a 5-year delay, or with people that never achieve controlled cholesterol levels. And again, this gap in between the lines is the incremental risk that we have these patients living. They are living with this incremental risk because they are not controlling LDL-C levels. Next slide. Again. So I thought that rather than to give you some conclusion, because this is still a work in progress, I thought maybe to present some questions or some food for thought. The first one is, can we improve adherence by increasing awareness on cumulative risk? We think that this conversation needs to be happening with patients, with clinicians, because I think it's really quite important for the patients to understand that if they control their risk factors today, it's much better than if they do it tomorrow, because the damage that they will build up in between today and tomorrow is going to remain in their system, even if tomorrow they reduce their cholesterol levels. Next, Matteo. Now, if this conversation is useful, should we target patients or should we target clinicians? Who is the population subgroup, or who is the better receptor for this message, or are they both? And what are the tools that we have to discuss this with them? Next. And finally, and this is kind of the basis for our next project, what is the cost effectiveness threshold for improving adherence across primary prevention populations? So we know, as I told before, that the cost of non-adherence is huge for healthcare systems and for the society. So basically, we are trying to quantify exactly how much we can invest and what the return on investment from the strategies to improve adherence, and how long it would take for governments to make that investment back by improving patient outcomes in the long run. So that was basically that from me. Thank you again for having me. It's my pleasure to present. I'm sorry I was not there, but thank you. If you have any questions, I am of course very happy to answer them, any comments. But if you come up with something later on, please do get in touch, and I will be very happy to engage.
Thank you, Clara. And I think we are going to keep you on for a little bit just for some questions at the end with everyone. And you've made my job very easy by putting some questions up already. And just a reminder for anyone else, if you have got some, put them on Slido. And I think it was a really, really interesting presentation, Clara, kind of looking at what the impact of non-adherence really is. I'm going to pass over to Sean Lybrand from Amgen, who is going to finish us off with our sort of quick presentations, and then it'd be great to have a little discussion with everyone. Over to you.
So, Mark, if I was here in the French Revolution, I don't think anybody would be bothering me. A few points first. So I'd really like to say thanks to ILC. This body of work is interesting for many reasons. Adherence is not something, as Aaron has pointed out, that is commonly researched, particularly in some of the areas that we have done here. Most of these areas have generic medicines in them, so the interest is lost, and yet, as you can already see, the gain is profound. The other point, the report is up the back, doctor's orders. It's also available online and in your nearest gift shop, hopefully, as well. We are also working on a short summary of the recommendations that we can have as a 1-2 pager to be able to distribute to stakeholders. I've found in many years with government, if we give them a 55-page report, it goes to the round file that's right next to their desk. So I often try to communicate very simply and using words that government will relate to. And we made a point earlier, before that when I try to speak with government, one of the things I want to do is not tell them what's important for me, but ask them what's important for them, and then make those two things mesh. The other point I'd like to say is thanks very much to Clara and the team at Monash University. The papers that she presented, there's a series of 7 of those. They're available on PubMed. I think most of them are free. That is the most contemporaneous analysis of lipid management in Australia. It's only recently been produced. As Clara has noted, in Australia, lipid management and the lipid guidelines are still relatively high compared to other countries. So what you will see that Clara has just presented is if we can't reach 2 millimoles per litre now, when the government decides to change it and move to 1.4, we are a long, long way. And adherence is key for that as well. Right, so a few slides. I will use some personal examples here as well. We'll share it with just the 30 people here and a bunch of people on the internet, so don't tell anybody. All right. The first thing I'd like to say, with apologies to Albert Sabin, which I thought was apropos for being in a company owned by, or in a place owned by Miriu, is Albert Sabin said a vaccine that sits on the shelf is useless. For many years I worked in vaccination, and I used this phrase many, many, many times with governments in low and middle income countries as well as high income countries as well, because the fact is that procurement is one thing. Often governments are purchasing vaccines and they're being given away for free to individuals, and yet we know what vaccine uptake rates are like as well. So it's not just the cost. I will come back to cost as well. It's also important for medicines, and I will point out that doctor's orders is not just about medications adherence, it's adherence to medical orders, and it's particularly with relation to chronic disease. I'll raise this as well, that in acute disease people or present disease, people will see what their condition is, pain as an example, and do many things in their power to be able to move away from that stimulus. Cancer is another one. In chronic disease, where we have things that are inside our bodies that we can't see or can't feel or can't present, or the outcome is many years away, it becomes somewhat odd for a person to try to manage that type of risk. And Clara pointed out, how do we engage with individuals to help them understand what their risk is going to be, and then set about giving them action-oriented opportunities to address them. So a few of these points have been made, and I could have finished this presentation in 4 words by saying what you guys said, because almost everything in this report has been threaded through the vaccine discussions, the issues that relate to cost as well. But a few things. What gets in the way of adherence? There are so many things that get in the way of adherence, and it's not just cost, and it's not just misperception. It is all of these particular things. We talked over the last day and a half or so about illness versus health. For better or for worse, health systems are really ill systems. They focus on the disease as opposed to trying to maintain personal health and therefore more broadly population health. I mentioned acute and chronic conditions as well. Acute, once again, for better or for worse, is managed well, relatively well in hospital systems. Clearly you can tell from my Swiss-German accent that I'm actually Australian. I think the Australian healthcare system is very good at acute care. We have public hospital systems run by the states where you can go for treatment for anything that's acute and you will get treated for it. Our general practice system and the medicine system is funded by the federal government, and general practitioners, like in many countries, are essentially small business people as well, trying to run their business with funding that comes from the government as well as private pays as well. This issue about adherence as treatment versus adherence as prevention is interesting, and I'll use a personal story here. So I started on statins a number of years ago. One of my team members in Australia died of a heart attack. And I thought, well, I better go and get my lipids checked as well. My lipids were relatively high. They were certainly almost double what the Australian guidelines were. When I talked to my doctor about it, he says, well, Sean, I'm kind of okay with that. And I said, Colin, I'm kind of not, actually. And Colin knew my particular interest and area of research, and we went through why, for me, taking a statin was primary prevention, because I didn't want to be like Mark. And, I think many people should be able to think like that, but ultimately the population is not conditioned like me. They're not focusing on research. They know plenty of people who have been stented and live productive lives. But for me, as doing all that research with Clara and the team was great as well, because it's very, very clear that taking intervention early for me is at least one thing I can do at relatively low cost. I've put here paternalism versus autonomy, and where's David? David mentioned yesterday, with due respect, paternalism is dead. But in some ways, I think, as your retort was, that sometimes a little bit of paternalism wouldn't go astray. It's a little bit directive to say, well, here's the things that are important for you. And I'm not saying that it should be jammed down someone's throat, as there's this nice healthy balance in a perfect world where I can have a conversation with the doctor, talk about my fears, the doctor can talk about things that we can do, and we come to a shared care plan. So I have autonomy within that. It's not mandated care, but the balance between how do we give people directive or appropriate advice and while allowing them autonomy is something that we need to consider as well. Perverse disincentives, and I've got labelling here. I'll use another example. So my identical twin brother is a senior naval officer in Australia, probably not giving it away to the internet. His LDL is about the same as mine. We had a conversation about his LDL, and he said, I don't want to ask my doctor because if I decided to take statins, that might affect my deployability. So in the military, you've always got to be ready to go. So he is worried about his impact to do his job appropriately. When I framed it for him, this is about prevention. It's actually not about treatment. And so we have this natural experiment going on in our family to see who dies first from a heart attack. Hopefully not me, because won't I look silly? The personal costs and value assessment. We've talked about co-pays. There's an interesting thing that the Pharmacy Guild in Australia did running up to the most recent election, where they talked about reducing the co-pay for people with multiple chronic conditions, which I think is an absolutely fantastic idea. In Australia, the co-pay for the general patient is about $40 Australian. For an older person, it's $5 or $6, and for people on healthcare cards, it's $0. As an older person, a $5 copay multiplied by 6 or 7, the average number of medicines, still adds up. And while in Australia there is actually a level at which there is no more payment, they have to get there. So people make choices based on those costs as well. The value assessment is the other. What impact is this going to medicine mean for me? And how long do I need to take it for? And what's the value of something not happening to me as opposed to something that does happen? A point at the end here I used short, the numerator and denominator, is the way that government assesses the costs versus the outcome. So the numerator for any particular healthcare system is clear. That's the impact to my budget this year. The denominator is profoundly hard for governments to think about, because what is the timeline over which those events may or may not happen? What is the breadth of the denominator? So most governments only take into account, from a health economic perspective, the direct healthcare costs and cost offsets. Productivity is explicitly not taken into account in reimbursement submissions. So we're not seeing the true value of the medicine and over what time horizon. So is it any wonder that governments really think about the costs of things within their budget lens, but also the payoff lens? And the payoff lens is also political as well. When's the next election? What are we going to get to? So the point here is that we shouldn't be moving from an individual spoke in the wheel, so that was the last picture, but to consider the systems approach to adherence to medical orders. And what I've added here is many of, but not all of, the factors and individuals and groups that are impacted by improved adherence. The person, of course, is impacted through improved outcomes or improved expected outcomes. The doctor, of course, no GP ever decides to prescribe a medicine to someone and not expect them to get what it is that you want out of the prescription. So you have a process outcome expectation, but also the health outcome expectation as well. And those things, particularly in chronic conditions, are often mismatched. The family, we talked about the impact of the family earlier, and kids thinking about how do they talk to their grandparents of things like good bone health. The family does have an impact, and not just in high-income countries, but in low-income countries as well. For cervical cancer, for instance, if a lady is affected by cervical cancer at or around the age of 40 and is taken away, those children often need to go to work or certainly leave school to pay. So there's huge consequences from the lack of adherence to available therapies. Government is an interesting one. Government, so I won't name this person, but I said to a health minister at one day, why is it that your government stops thinking about the cost effectiveness of medicines the day after it's listed on the reimbursement scheme? And the person said, what do you mean by that? And I said, well, we make submissions to the government on the basis of a particular adherence rate at a particular price. There's an outcome, a cost per quality that comes from that. And yet, after that medicine is listed on the PBS, I have been told directly by bureaucrats in the department that, Sean, if people comply to their medicines, it costs us more money. You cannot hold those two things to be true. Health insurers are interesting. So from an actuarial approach, health insurers do have a good look at all of the costs and all of the outcomes that can happen under an insured life. So health insurers can take, and certainly some health insurers do very much take, an approach where they're trying to undertake preventive health. Pharmacists have access to data, which is great. And whether it's linked health record data or individual data that sits within their system, pharmacists are beneficiaries of the outcome for individuals because they are small business people as well. And the ability to think about pharmacy as a recall vehicle. Mrs. Jones, we see that you haven't turned up for your medication for X. Would you like to come in? I've got it prepared for you. Industry, of course, as us, we're a supplier of medicines, and adherence is a component of what our business model is. We can contribute, I'll show this in the next slide as well, but there are many ways that industry contribute, but being able to contribute directly to individual patient engagement is often very limited. We spoke about employers as well. I work in a health-related company. My company provides vaccinations, but we're not providing on-site health checks. So there are ways that that companies like mine and companies more broadly can undertake health-seeking behaviours and help people make the right choices. And then society as a whole. There was a slide presented yesterday that talked about the very small incremental impacts that happen over somebody's lifetime with a particular health condition, but multiply that by the population, let's just take chronic disease, and the impact to an organisation, to a country, is profound. I'm having to read French here, folks, sorry. Oh, there we go. Super. So, we've talked about incentives a few times. I'm actually not a great advocate of incentives for individuals. I think incentives have their place, as we've spoken through COVID. Some of those incentives were providing people with firearms in the US. What are they really going to get vaccinated for? You know, the outcome that the government wanted in a certain population happened, but there are unintended consequences sometimes from incentives. I do feel quite strongly that doctors have the ability to engage in behavioural science techniques, and the point here is that talking to an individual about their particular health condition and thinking about what type of words can be used to most effectively change somebody's behaviour or mindset. The other, we've spoken about some graphs being moved up and to the right. Doctors sit on at least their own individual data set as well, so there are ways to consider incentivising GPs. Here's a great idea. What's the very last thing that a dentist surgery will often ask you before you walk out the door? Can I book your next appointment? I can't recall that ever being asked of me at a general practitioner. Incentivising a GP to make a rebooking appointment to ensure that person comes back for their chronic condition at a relatively small amount of money, multiplied by how many visits per day? 15, maybe 20 in a busy general practice, adds up to a lot. So the way we think about incentives should be systems appropriate as well. I'll go through the rest very quickly. I'll perhaps just concentrate on the industry component here, is that industry, companies like mine, are usually unable to communicate directly with individuals. But what we do have is a very, very good understanding of data and patterns of care, regional patterns of care. In fact, it was one of the reasons why we did the work with Monash, was our understanding of what the lipid management landscape would be in Australia, and to be able to demonstrate where there are opportunities for government to be able to take action to improve rates overall. So, last slide. This has been mentioned a few times. The point about adherence to medical orders, adherence to medicines overall, is that often the individual is blamed for their particular health condition, particularly for chronic disease. If somebody is overweight, I've heard this before in governments, well, they're just eating too much and not exercising enough. Highly complex, but that's a blame-related culture, as opposed to a shared responsibility culture. And the purpose of presenting the wheel, somebody mentioned earlier, so I actually see that wheel as a tension diagram. So when the tension is balanced across all of those particular stakeholders, the wheel is round, it gets to roll. So we all have an equal stake in the outcome for the person that sits at the centre of the wheel, and that's the person under care. So this idea of moving from blame to ownership and partial ownership and shared responsibility becomes a really important next step for adherence to medical advice. Thank you.
Thank you, Sean. And I'm just going to, I don't think Lindsay is here, just to see how much time we have. Thanks so much. And I think it's really illustrated how complex the factors are of, an individual's relationship to adherence, but also all the kind of complex stakeholders that are involved and that we need to be bringing in. Do we have any questions in the room? If not, I do have one myself. Yes, Nicola?
Just a question for Aaron, actually. Thank you so much for your presentation. It's just a very technical question. How did Sweden measure adherence? Because I know that adherence is a really difficult thing to measure, because a lot of patients are reluctant to be honest about whether they're taking the medication. There's plenty of evidence in the UK that they'll get repeat prescriptions for antihypertensive medication but not actually take them, mostly around side effects, which are pretty unpleasant. At least half of people who take antihypertensive medication in the UK aren't actually taking them. And the cumulative effect that Clara mentioned is really, really very acute in hypertensive disease. So exactly how are we measuring adherence?
Yeah, that's a really interesting question. I have to admit, I have to get back to you on that one because I think, you're absolutely right. There's definitely barriers in terms of issues in terms of properly measuring adherence. But I think also in terms of understanding it across conditions as well. But I'll definitely get back to you on that. And I think, probably I think we're probably at the very sort of initial step in terms of just getting countries to even consider adherence and measuring it. And then maybe the next sort of, the question we also need to be having is, you know, how effective is that measurement and what can we do? And afterwards, like, it's actually going to help us address adherence rates properly and in the right way.
And sorry, just a very quick second mention. You said that one of the recommendations was to do, when we're looking at polypharmacy in older people with comorbid conditions, because there's plenty of problems with that. There's interactions, there's unnecessary drugs, and the fact that most clinical trials are run on people who are not over the age of 50 and who don't have comorbid conditions. But I'd just like to mention, I'm sure Ed knows this, in the UK, GPs already do regular medication reviews. They have a really good framework already set up. So there are several drugs that will immediately red flag, like warfarin and other drugs. So that's a really good template to look at.
Yeah, I think that's it's a good example, a good case study to kind of to demonstrate the case for having these sorts of reviews across the board for adherence as well. So yeah, thanks for mentioning that.
Sean, do you want to come in?
Just on Sweden, my recollection, this is in the Swede Heart Cardiovascular Registry, and they do collect 1 or 2 different medications adherence, but then I believe it also might stop at 12 months. So as you can see from Clara's slide, 12 months isn't telling the whole story. It's not great, but at 5 years it's terrible. So it was interesting, I was thinking in Patrick's presentation through the ECDC, where we've been quite good at tracking vaccine rates, and you know, frankly, at least in the Sydney Morning Herald, every day they reported what the new compliance rate or what the uptake rate was for vaccines. I wouldn't suggest we do that for all medications, but that type of model that becomes a comparative model in particular conditions perhaps and is reportable would be a very good way to have that shift up and to the right that one of the presenters made yesterday.
Yeah, Mark.
So I think I sort of shook my head when you said side effects with antihypertensives. I don't think most people taking antihypertensives do suffer side effects. I think a lot of them say they do. And I think it's there that they rationalise non-adherence.
Yeah, just quickly to add to that, people who know about the side effects of statins get side effects. People who don't know about the side effects don't get side effects.
Exactly. So it's a bit like vaccine hesitancy, right? That actually people are often explaining behaviour that they may not even be able to explain to themselves. And I think one of the things that I've seen when we looked at adherence to HIV medicines is there's an element of denial. I think it's even more true with cardiovascular, that people want to deny the unpleasant event that they're trying to prevent. And so I think that has direct implications for the messaging. You know, one of the questions that Clara asked us was, what should the messaging be? I don't think the messaging should be a high fear message, that you've got this cumulative thing building up in your body and if you leave it untended it'll kill you. I think that pushes people into denial. It's more a positive message that we can protect your heart, and you keep on taking the medicine, it keeps protecting your heart and it keeps your blood vessels open, and isn't it great? And you know, you'll be like the Queen, you'll be 96 and at the concert. because that's what people want to hear. And we just finally, I think it's so long ago, MSD won't object if I say it, but we did quite a lot of work for MSD after the 4S study, the original simvastatin study. And we discovered that telling people they'd live longer isn't a very good motivator, because people's idea of what living in their mind to be 90 years, at least at that time, which was 20 years ago, was not good. Telling them they'd live to be healthy and older was a good motivator, and we actually studied it. So
that's really interesting. One question for you, Clara, and I think it relates to this question of messaging really is, there clearly are all these different stakeholders, and it sort of seems a bit of a no-brainer. We have the evidence. Who do you think is best to, either Aaron or Sean come in as well, who do you think is the best person to start with? Who do we need to target? Who do we need to influence?
I think really we need to have a conversation with GPs. And maybe as I mentioned before, I think pharmacists can play a key role here, because they are really perfectly positioned within community to actually track adherence. And if we can also incentivize them, if we can, I know that in Spain, like a few years ago, they did have like these high blood pressure checks in the pharmacies. And I think that is a fantastic way to track adherence and to track not only adherence, but in the case of high blood pressure, for example, you can even track therapeutic goal achievement. So I think, first of all, we need to start with clinicians and with other healthcare professionals. And then, of course, we have to be careful with the message to patients, as you were saying, because, of course, we don't want the message to be like, you have to take this today or you're gone. So definitely, it's a conversation, I think, with healthcare professionals first, but also then, and I think the message to patients can be also quite positive, like you can take charge of this, you can change the course of the damage that is happening into your system.
I'll split the difference and say both for a few reasons. One, I'll give another example. So in Australia in 2019, the Australian government funded a heart health check for people over the age of 45. It was blood pressure, LDL, HbA1c, waist-hip ratio, and one other measure. There was an article that was written in one of the national papers by a very well-known Australian cardiologist saying that reimbursement for the test wasn't high enough and it couldn't be added to the current consultation, and people didn't know about it. So GPs were incentivised theoretically to do it. The government found that to be cost effective. People weren't coming in. GPs weren't recommending. And then Shane Warne died, who was a famous Australian cricketer. The CEO of the Australian Heart Foundation just told me recently their uptake of the Heart Health Check website went up by 50% almost over time. So the important point there is that there is incentives to play with government. Thinking about that reimbursement model, it would be an important way to consider what's, even if it wasn't double, if it was 30% more by combining consultations, there's an incentive to do so, and not a disincentive to do so. I had perverse disincentives up there for this particular reason. The other is never let a good crisis go to waste, as we've found with COVID as well, is that the opportunity to have a great communications campaign based on Shane Warne's untimely death is to say, here's some human-specific language that relates to actually how you can care for your cardiovascular health, not prevent cardiovascular disease.
Great. Well, thanks everyone so much. I know we're a little over time, but we've made up time again as well. So I'm going to wrap this up here. David, in terms of the walk, when do people need to...
Yeah, shall we aim to meet by the gate, by the front, at about past? And we'll just go for an hour and we'll stroll down for half an hour and then, of course, turn back whenever you want. But I today have done, based on, and we were talking yesterday about the office than I do at home. Today I've done about 2,000 steps, which is about 15% of my normal one. So if we can cope with the sun, which we might not be able to, no, it'll be fine. We'll go down, go down and have a chat. And Lily, were there a few things you wanted people to talk about?
I think the main one is this thing around, what can we as individuals take forward as actions? What's a thing we can do in the next sort of 6 months? So something quite actionable. It might be a small thing, it might be a massive thing. Save the world. And we can all have some conversations. We have got we might force some of you over dinner to take some photos with little speech bubbles. But yeah, just have a think.